217 students have joined. I think 217 delegates have joined, ma'am.
Yes.
18.
Yeah. So our students, if they have joined, means we can start. Or otherwise, we have to wait for another minute, five minutes. You ask all the students to join first.
Yes, ma'am. Our students are settled and they are joined, ma'am. They are in the classroom.
Coming together is a beginning. Keeping together is progress. Working together is success. Let today be the start of something new. Good morning to all. It gives me an immense pleasure to welcome you all this 8th National Nursing Virtual Conference on Resilience and Reinvention in Nursing Education, Practice and Research Towards Excellence, organized by SRM College of Nursing and co-hosted by Society for Nursing Practice. Please adhere to this conference protocol, like mute yourself to avoid background noise, which will help you to focus on the sessions. We will have our beloved staffs to manage the chat box. To answer your questions, please submit your queries over chat window. Your active participation will march this conference towards a successful event. Now, we have shared the pre-assessment link. I request all the delegates to fill and submit. At the end of the conference, we will share a link to submit your feedback. Without your feedback and registration, no conference certificate will be issued. Yes, you got me right. We know how to get your feedback. The secret of getting ahead is getting started. Since we are about to start our plenary session, I would like to invite our respected Vice Principal Ma'am, Professor or Vijayalakshmi, SRM College of Nursing, to introduce our first esteemed speaker. Ma'am, please do the honors.
A very pleasant good morning to all. I am privileged to introduce our first expert speaker for the day, Madam Dr. Asha Shetty, Professor cum Principal, College of Nursing, All India Institute of Medical Sciences, Bhubaneswar. Madam had completed her MSc Nursing in Child Health Nursing in the year 1997 from Manipal College of Nursing, Manipal Academy of Higher Education. Madam had completed her MPhil in the year 2002 from Manipal College of Nursing, Manipal Academy of Higher Education. Madam had completed a PhD in Nursing in the year 2014 from National Consortium for PhD in Nursing, formulated by INC and WHO and Rajiv Gandhi University of Health Sciences. Madam has an illustrious career path, started her profession as a nursing tutor cum staff nurse from Lombard Memorial Hospital School of Nursing, Udupi, in the year 1992-93. And she had been served in various cadres as a clinical instructor, lecturer, assistant professor, associate professor, acting head of child health nursing department, professor and postgraduate coordinator, principal College of Nursing in various nursing educational institutions. At present, Madam is the professor cum principal from College of Nursing, AIIMS Bhubaneswar. And Madam has a rich experience as committee functionary in various associations. Few to mention: Life Member, Trained Nurses Association of India, Life Member of Nursing Research Society of India, Life Member of National Neonatology Forum, and many to add. And Madam had published index journals around 50, and Madam had guided many PhD scholars, and still under her guidance, 5 are pursuing their PhD degree. Madam had guided many MSc research projects as well. Madam's presented papers at local, regional, state, national, international level conferences. It is more than 70 papers. And Madam had authored a chapter for book on radio diagnostic investigations and nursing management, published by Manipal College of Nursing, and many other books Madam had contributed as chapters. And awards received by Madam: a recipient of University Distinguished Alumni Award conferred by Manipal University in the year 2011. Madam is a recipient of Excellence in Professional Contribution Award conferred by K. Pandyaraj Balal Institutions in the year 2013. Madam had received many other awards she has in her credit. This is in brief about Madam Dr. Asha P. Shetty, Principal, AIMS, Bhubaneswar. Over to you, ma'am.
Morning to all of you.
Very good morning, ma'am. I am Dr. Tanya Mal. I am Dean College of Nursing. So very nice to see you. So proceed with your presentation. Wish you all the best.
Thank you, ma'am.
May God bless you, ma'am.
Thank you, and it is nice meeting you too. And thanks, Professor Kalavali, for introducing me. And first and
ma'am, Professor Vijay Lakshmi, but she is coming in other laptop. So Professor Vijay Lakshmi, she is the vice.
Vijay Lakshmi, ma'am.
Okay, fine. Because the name indicates it is.
Yeah, that I know. I know, ma'am. Yeah.
Okay. Thank you. Anyway, it is first and foremost, I think I thank and congratulate to all of you for organizing this 8th National Nursing Virtual Conference. And as the title rightly indicates, that is resilience and reinvention in nursing education, practice, research towards excellence. I think it is a very appropriate topic that you have selected, and my congratulations to your other co-host, SRM College of Nursing, along with you, SRM Institute of Technology, SFNC Society for Nursing Practices, BioLeaks, etc. So I think without much further delay, let us go ahead with the today's topic. Just give me 1 second to share my slides.
Yes.
Is it visible?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
My voice is also audible?
Yes, ma'am, it is audible.
Much audible, ma'am.
Fine. All right. Okay, fine. So now in this session, we will be discussing briefly on partnership and innovation, the future of nursing education. So in next few minutes, we will be discussing about what is partnership and innovation in nursing, what is the need and characteristics of these innovation and partnership, what are the prerequisites that we need to have, what is the expected outcome with this, and what are the important innovations that we have in nursing education now. And with that, we will conclude the session. So to begin with, as we all have come across very deadly this COVID pandemic, and through this, we have come across a lot of changes, a lot of innovations, as all of us agree. A quote by John Cage, as he says, I can't understand why people are frightened of new ideas. I'm frightened of old ones, he says. But many a times, we were also frightened when COVID came, why and how we have to face. Because if we look at the beginning of COVID, I think majority of the nurses or nursing students or the nursing faculty, we were into this profession, but we were not aware of how to don the PPE. So these all things we have learned now. So it is many things are situational that makes us change according to the situation, and accordingly we need to change as the technology changes also. So nursing education is evolving to prepare the nurses for new challenges, and especially this 21st century, this is a metaphor for extraordinary challenges for us, and because of the opportunities that is available to us in the nursing profession. And these are the challenges that we face in the academic institution, because we need to prepare the next generation nurses accordingly. So that is a signal change for us all around, that is to define, that is not only what we teach is important, but how we teach is also important for us. So change is implemented by the nursing programs during the pandemic, that again keeps continuing and evolving, because there were many changes in this, how we talk to the patient, how we interact with the patient, how we do the documentation of the patient. So I think these are the things we need to incorporate in our teaching and learning activities. The nursing students will have the opportunity to solve the real world problems in real time. So they need to have the exposure in the coming days, how to handle the situations. So now let's understand what exactly is partnership and innovation. So a partnership is defined as an arrangement where parties agree to cooperate in advance their mutual interest. So that means there should be cooperation from both the parties. So what are these parties? So for example, in our profession, that is in nursing profession, the most common partnership that we can give example is the academic service partnership. So that is, it is a strategic relationship that we have between the educational institutions and also the clinical practice settings. So these are established, that is to advance the mutual interest that is related to practice, education, and research. Because unless we have a good partnership with the clinical, or practice setting, we cannot advance in the research or the education or in the practice, because that is practice setting is an ocean where we can swim. And to understand what is innovation, innovation has been described as an art. It's a process of diffusion and a process of transforming the ideas into real value. So transformation is taking place in nursing, and this nursing education that is driven by the development which is happening in the healthcare delivery system. So these innovations, what is happening in the clinical field, these are unique to nursing. And based on that, we know that we are aware, a lot of innovations have taken place. Even many a times, for example, when a nurse is taking care of the patient, when oxygen was more important, that is to be given for COVID positive patient. So how to give how to connect oxygen from one source to many patients. So these are the things which are coming out of the clinical practice, which are unique to nursing profession. And that is possible only if we have a good partnership with the clinical, practice setting. Now, so let's see why transformation is essential in nursing education. Because there is a lot of growing need for interdisciplinary education for collaborative practice. So nursing cannot be practiced in isolation. Nursing is practiced along with the other professionals. And if we see the healthcare today, there is a lot of technological explosion. Even in COVID times, we have seen how the ECMO, which we have not seen earlier, or a lot of mechanized ventilators and a lot more things, and how communication technologies that we have improved in talking to the patients and all these. Then there is an opportunity for lifelong learning and workforce development. So nursing is continuously evolving. It is not the same that what we have studied. So we should be ready to learn. For example, when we have learned to take, temperature of the patient, maybe by the mercury thermometer. So now we have done away with the mercury thermometer. So there is a lifelong learning, and we must get accustomed to it. And accordingly, we need to incorporate in our nursing curriculum. So there are also various alternate therapies, the genomics and palliative care. We all are aware how a lot of home remedies and everything. I think during this pandemic, the many people, those who were not drinking of these, what they say kachayam, or ginger and garlic, and everybody has started taking it. So there are a lot of alternate therapies and genetic studies. And this is an era of consumer, educated consumers who come to the healthcare institutions. So when they come to you, they are already aware. What are you going to talk to them? They know everything. It is not that we prepare health education like how we had been preparing, because they know more technology. They can easily search in the Google. And also the changing demographics, the increasing diversity of the population, and also there is significant advances in nursing science and research. There are a lot of research studies which we need to incorporate, which we need to put in practice in our nursing practice. As we talk about this innovation, so if we look at this pyramid, like we have been teaching the students, there are passive teaching methods as well as the participatory teaching methods. So if we look at this pyramid, we understand that it is a participatory teaching method which makes the students more knowledgeable, which will help them to disseminate the information, because 50% of it they learn, their knowledge retention occurs by discussion in the group. It is not by just by lecture or reading or just by showing a PPT, and by practice, by doing. That is where we need to have a good partnership with the clinical setting, and they need to be exposed to practice. They must do it by themselves. Like in nursing, practice, what happens, students many a times do the procedure just one time, for the sake of doing and for the sake of taking signature in the book. No, I want to tell, there are many students in this platform. See, when you do by yourself, that you understand, because at this student period, yes, you don't understand what is the importance of going to the clinical and doing it, but definitely you will understand once you finish your course, and when you go and when you're appointed somewhere, you will realize how much you have lost your clinical practice because of this COVID pandemic. Because when there is any pandemic, any news, they say, okay, we don't want to go to clinical and we don't want to, we get infected. No. So I think it is like how soldiers fight in the border of the country, and that is what we are, soldiers in the healthcare setup. And also we retain the knowledge by teaching others. When we know something, we need to share, and we need to take a lead role in teaching and discussing others. So with that, 90% of the knowledge retention can be done in our nursing profession when we do that, because ours is not an isolated profession. So now, what is the importance that we have to give when we teach in nursing? There are some competencies we have to focus, when we teach the student. One is we need to have in our curriculum, that is patient-centered care, which has to be very, very important. The next competency that we need to teach the student is the teamwork. I think this is something which is very much lacking in many. It is not, I don't mean to say there is no teamwork, but this has to go in a very broad way. And also collaboration, because as I told you, nursing cannot be practiced in isolation. So there has to be good collaboration, and the evidence-based practices which need to be given importance. There has to be the quality improvement, the ideas for quality improvement. Everything that we see, that has to be improved. So it is not that, okay, I'm comfortable with it and I, this is how I will do. No, or this is what was done yesterday and I will do it today. No. So we need to focus on quality improvements, and also the safety and informatics, which has come into this healthcare field, the safety of the patient, the safety of the workers. And the informatics, the medical informatics, the nursing informatics, I think these are the competencies that which are the part of the healthcare environment, and that must be incorporated into new graduates' practice. So nurses not only need to have the practical skill, but they also need to possess, and that is how appropriately they use their knowledge and the skill and the practice, and to have a right attitude to move into this profession, and especially in this 21st century. And that is how we can share nursing. That is how we can bring up the nursing profession. Now, is there a real need for it? Yes, because there is a lot of shortage of nurses, regional nursing shortage. There is a shortage of nursing faculty, and the complexity of illness, because many a times we do not know, like, what is the thing, that what is the illness. There are a lot of complex illnesses which are coming up, and increasing complexity of the healthcare environment. Okay, and also the insufficient clinical placement. Okay, we need to have appropriate clinical exposure. Only then we will be able to handle the situation properly, because there are a lot of technologies that we need to be aware, a lot of models of healthcare that we are not aware of in the clinical setting. And there is, as I already told you, diverse population. There is a shift towards the patient-centered care. So without being aware of all these, we may not be able to, handle the healthcare situations appropriately. Now, when we need to have this, what are the characteristics? So one is the relative advantage. So when we use something innovative, we need to have some superior idea than the old idea. So this is something which we need to, which we will be able to accommodate with that idea. At the same time, the compatibility, that means the degree of congruence between the innovation and the existing values, the habits, the past experiences and need of the participant. That means one should be able to handle that. The complexity, the degree of difficulty in application of the new idea, maybe the younger generation will be able to adapt to the technology very easily. At the same time, we should gradually make others also learn about it. Then the feasibility, that is a degree to which the new idea can be tested or tried, or the degree to which the outcomes are identifiable. Because the important thing here is that what is the expected outcome by using this innovative technology. So that is what is important by incorporating the innovations in the nursing curriculum. So if we look at the technology, what is happening, if in the last decade, the focus was on medical products, like whatever the product that you want, whether you want a wheelchair, whether you want a stethoscope, whether any other, that was a market, that is medical products were available. Now, if you look at the current scenario, the medical products along with these services, we see a lot of items with in the medical platform, and we see there is the app based technology. Even we don't have to use even a blood pressure sphygmomanometer or anything. There are apps which monitor that, even the our oxygen level or hemoglobin level. It is our temperature. We don't even need to use any instrument or any medical equipment. Just by using the app, that you will come to know. Wearable apps are there, and that is the medical platform, which by it is having its own technology, and that will give you the data, and it will give you the accurate data. Even like, I'm sure all of you are aware, when you're using a mobile phone, if you don't use any, if you don't walk, and that will tell you, okay, your walking steps are only this much today. So now the technology is that it is along with the medical products, there are apps which are involved in it. And in the next decade, it will come along with the medical products, the services and the intelligence. I'm sure all of you have heard about the artificial intelligence, which is, in many countries and all over the world, I think more than 800 billion nurses are replaced by the artificial intelligence. So it is very essential for us. So we go with the technology and we have a good partnership in the clinical setting. Otherwise, a day will come, all nurses will be replaced by the robots or the artificial intelligence. Now, this is something important, and that how the technology that we can incorporate in our curriculum. So I'm sure all of you are aware of Bloom's taxonomy, and here we have a SAMR model. That is, SAMR stands for substitution, augmentation, modification, and redefinition. So in substitution, a technology acts as a direct tool substitute, there with no functional change. We are just using something. Whereas in augmentation, what we are doing, we teach technology acts as a direct tool substitute with a functional improvement, where that means the student will be able to understand, and that student will be able to apply. Whereas in modification, we apply it, we analyze and we evaluate it, and we redefine it, where we will be able to create, that is redefining, and to evaluate. If you look at the example which is given there, see first, when someone looks at the ocean, the person wonders, so what's it in the ocean? And in the substitution, the person gets some technology. So uses a boat. So once he has used that, he understands how to apply it, he learns to swim. Then, the modification he understands, so there is something more in it, then he can dive. And then he will be able to create something of his own, that is, by using technology. And that is where a redefinition, that is what it is going on. So this is how the technology that can be used into the nursing curriculum. So I can give you another example. So for example, as a substitution, we can ask the student to use some printouts or a worksheet, and the student will be able to very easily take down from the computer or download it and will be able to work out on the worksheet. Then you can, as an augmentation, so that the student need to understand and apply. Then you can, what we can do, we can conduct some quiz. So when we conduct a quiz, student will be able to answer any, twisted questions and all that. Then modification. So how we can do that, where the student will be able to apply and analyze or evaluate, is that we can ask the student to write an essay on it. And now redefinition, when a student writes essay, then next we can ask the student to create a documentary. So that is where the student is redefining. I'm sure you are able to understand how the technology goes into the innovative method of teaching, that is face by face. I can give you another example, like in substitution, where see the word processor that is replaced with a pen or pencil for writing purpose. Now in augmentation, what it happens is that so many people are, they are even not even using the pen or pencil to write, but they are using text to speech, that app, and that, that is augmented, something additional. And so modification, there are people who share the things on the blog and they take the feedback from the people. And next, for redefinition, we can ask the student, you come back, you analyze the thought, that whatever feedback that you have got. So this is how the technology that we can incorporate in our day-to-day curriculum, and we can function and modify it. So as World Health Organization in their State of the World's Nursing Report, they say it's calling for an urgent investment to accelerate the nursing education. So WHO also advocates for strengthening leadership. So nurses have an influential role in developing the health policy and decision making, and can contribute to effective health and the social care systems. So now, what are the prerequisites that we need to have for a successful partnership? So there are so many, prerequisites. So it is not that easy to have a, partnership. The process of establishing the collaborative relationship, that can be both difficult and time consuming, despite the rewards. We all understand the good partnership that really will have good benefits, but it is quite challenging. Because at the same time, when we say partnership with the clinical field, we know that the clinical field or clinical setting is completely dominated by the medical professions. So they may not like, nursing teachers to going into the clinical field and having that partnership, because even the, people are afraid, like, why you are coming here, only your students will come, do and go. So it is quite challenging. So successful partnership always start with the self and mutual assessment of strength and opportunities. So we need to go to, to have successful partnership with a learning attitude. We need to understand what we know and what we can do, and the opportunities that we need to utilize for learning in the clinical setting. So for which we need to have open and ongoing communication. It is not that, okay, there are COVID patients, I will not go to the clinical area. No, we need to have a continuous communication, and we need to have mutual trust. So when that mutual trust comes, when we are there in the clinical field, and when we show that we know the things and we can demonstrate the thing, we need to have a shared vision. We need to be committed to the work. We need to have the specific goals. What is the goal that I'm aiming at? We need to respect each other, that is mutual respect, and also recognition of opportunities and the strengths. So whenever there is an opportunity, we need to utilize the opportunity. We need to show our strength, what I'm good at it, what I can do. These are the things that we need to demonstrate in the clinical setting. Now, like there are certain expected outcomes which we can expect. As Tiffany Kelly, a nurse leader, she says, the more we can get students to work together and think about how to creatively problem solve, the stronger we will be in uncertain times. So we need to have a lot of exposure, especially in the actual setting, and that is the clinical setting, and that is how we can prepare the strong nurses in future. So what is the expected outcome? If we have good partnership and incorporating this innovative technology, we can, the number of quality clinical placements will increase and diversify. Because when we have, good skillful products that are coming out of the institutions, I'm very sure everybody will be asking to have the nurses who are trained in such and such an institution. And the opportunities for shared experiences, that you will be identified, okay, so and so who has worked in such an institution has good experience, and we need to call and we need to employ. So that is where the employment opportunity comes. Also, student retention will be increased. Student employment rates post graduation will increase, because we need to show a clear difference. What is that I know as a graduate? What is that I'm learning as a postgraduate? So that difference that we have to bring. The patient safety quality indicators of success, that also will increase. When we understand what is important, when we develop these competencies, as I told you earlier, one of the important competency that we have to incorporate about the patient safety and the quality indicators, and we then understand in the clinical setting how this can be improved. Research productivity will increase. Satisfaction of the staff, students, faculty, and the employers will also increase when we have good partnership and when we incorporate innovation. So what are some of the important innovations that we have come across? That is, one is the online education. So online education, that is, ideal for students whose work schedule or family commitments, they don't allow them to attend the classes on the campus, and it is, distance education also that can provide with the opportunity to meet the educational goals. So it allows that the classes can be attended in leisure time, or participating in classes in a comfortable zone. So we understand this, there is a lot of technology, or the digital technology that is creeping into the nursing education. So we need to adapt for digital future. So nurses must accelerate the transformation to a digitally enabled profession by investing in informatic education, research, and practice. So in every domain that we need to bring in the digital technology, so that we will be able to practice in our future practice area. Nurses should upskill the data science and other digital health topics to ensure emerging practice and patient care. And also, we must invest in and lead digital health development and collaborate with others to develop and deliver digital tools that patients and public need. Here, one thing important is that, so nurses are the one who spend a lot of time with the patient. It is the nurses who will know what is needed for the patient. So it is the nurses need to be involved from the time of some technology that is developed for patient care, and then that can be implemented and that can be assessed how it is essential, or what is the feedback, what improvements can be needed. So nurses can be an important figure in the technology development for the patient care. Nurses should be champion informatics across all areas of professional practice. They must create leadership opportunities in digital health and inform the health policy in this area. The next innovation that we have is interprofessional education. Even in COVID time, we have seen it is not that only only the nursing profession, but the technologies have evolved because of the interprofessional education. As we provide patient-centered care, we need to work together in an interdisciplinary team. If you look at this picture, like this is what we do usually. There are intensivists, there are anesthetists, there are nurses, there is a nursing faculty sitting there. So we need to have discussions, meeting, work together, what best that we can do in patient care setting. We need to apply the quality improvement practice, because the clinical practice is a health professional education where there are so many other members who are involved in the patient care. we need to use the evidence-based practices and informatics, which will help us to use the clinical care pathways. New degree 4 programs that we have to develop. That is the as we know that the curriculum reform that is becoming urgent matter, and also the Indian Nursing Council has also evolved, has brought out a new curriculum. There is a complete paradigm shift in the nursing education, and also it's more flexible and student design curriculum. That is what it is implemented, where student has that is elective modules and the mandatory modules. There are some unique features that it has to incorporate is integration of the population and the practice setting, and also application of the whatever learning of different clinical learning activities, the early preceptorship experiences and clinical intensives. So these are the things a curriculum should incorporate. And there are various new models which are incorporated and which we have already seen. There are digital libraries, the nursing informatics, which will help us to bring out a care plan for the patient, the artificial intelligence, which is in use in many other countries. So these are the new models which are in the academic progression. There is also something like wireless technology, where nurse can have immediate telephone contact with the employees or with the patient, and direct or the accurate communication that can be done between the nurse and the physician. So also next, another important innovation that we have seen is the simulation, the virtual simulation, and in recent days. So we know that earlier we used to handle only the task trainers, but we have now simulators, the high fidelity simulators. The patient can talk, I mean the simulator can talk, the simulator can breathe, and it will say that I'm having pain, or he moans, and he shows the reactions, burping, hiccups, urinating, or bleeding, any injuries. Okay, eyes will tell the story that he is not a real person. Okay, so this is the simulation, and now these days we have also seen high fidelity the simulator, where you can give the real scenario, and you can have control it in from the control room, and they will be able to handle it in how they exactly handle it in the real scenario. And you will be able to assess lot of things, how the teamwork goes on, how they are collaborating with the other healthcare team members, how they are communicating with each other, and how total situation, like how it is handled, we will be able to assess by seeing them from the controlling room, that is by the high fidelity simulation. And these days even virtual simulation, because of the COVID pandemic, I'm sure all of you have been many students have been attending the clinicals, that is the virtual simulation. And then the podcast and the podcast. The podcast is the audio, and podcast, it contains the video also. See, podcast and podcast that are web feeds of the audio and video, and that are placed in the internet for subscription, and that can be downloaded. So it is unlike a simple download or a real-time streaming. The subscription feature of it is automatically delivered new content, and what is distinguished in the pod and the podcast from the other media. And next important thing that we all are aware of is that incorporation of evidence-based practice in our curriculum. So it is a combination of professional experience, expertise with the available evidence to produce the practice that lead to positive outcome for the client. So we need to identify the knowledge need and also formulate an answerable question. So I'm sure all of you know the PICO model, that is PICO. We need to ask, we need to acquire the knowledge, we need to appraise, we need to apply, and then we need to assess and evaluate. So the PICO model, so I'm not going into detail, but this is what is another innovation, practice of the evidence-based practice in our curriculum. Then we also have various other things where we use YouTube videos in our learning. And integrity is again it is something which is recorded information that is available web-based, and you will be able to log in into it, and you'll be able to listen to it, you'll be able to download that. So that is integrity. And micro teaching that we have been practicing in our nursing curriculum, and we need to improvise it, like how we can exactly do micro teaching within the limited time, how we can evaluate a skill, the teaching skill of a student, particular skill. So we need to this is something what we have been incorporating. Then the blended learning where a student will have the opportunity to learn by self-learning, that is in the education reform, as well as the virtual platform. So that is another area where we can have blended learning. So both domains that can be incorporated, and this also involves technology, it involves the teachers, the tutors, as well as the other technology, that is web-based learning also. Then there are regulatory influences on nursing education innovation. As I told you already, we need to have clear communication with the other partners. What we need to do, we need to follow the appropriate processes, and we need to follow the laws or the rules. Otherwise it becomes difficult to have the partnership and to go ahead with the innovation. So some of the innovation strategies that is used to ensure the future nurses are well prepared to meet the evolving healthcare needs and work is, one is we need to cover the essentials. That means what exactly that is related to the healthcare delivery system, and what is accelerating innovative efforts in the nursing education. That is important for us to know. So the core function of the nurse here to have to build the partnership with others, and that is within as well as the outside the health sector, to find solution to today's healthcare challenges. There are many changes in the school of nurses into college of nursing, and also which have incorporated the current public health crisis, like a continuously evolving technology, who are continuously using online educations or the virtual simulations. And so we need to think about this, and also there must be equitable learning experiences for all, and that should be consistent. We need to look at the level of competency in domains that especially in providing primary care, the coordination of care, the public health, and also the diverse population management. So these are some of the things that the essentials to be covered in the nursing curriculum in the future, where the upcoming students need to know. And also the creative collaborations to solve the problems. So schools, our training institute, our college of nursings are should be flexible to rapidly change as per the demands of the healthcare system. And there must be the collaboration or the partnership should be strengthening one. There should be a good collaboration, and also the benefits, whatever come out of it, that it should be the patient related benefit, and that must provide a great learning experience for the nursing students. And at the same time, solving real world problems in real time. So students must be exposed to the clinical setting where they will be able to solve the problems of the real world in real time, and that is possible only after their exposure in the clinical setting. It is just not possible if the clinical practice is done in the laboratory, because the laboratory and the clinical setting, there is a vast difference. Even like one of my few students, batch of students who did one study, and where it is found that what they learn in the lab is totally different that what they practice. It was around 80 to 90% of the things they said, it is totally different. So we need to expose them to the real setting, and then only they will understand how the clinical setting is entirely different from the college or laboratory setting. And also thinking by design, that what is that is needed to adapt to the to foster innovation. what is needed for the patient care. That we have to teach the student to challenge, their own assumptions, so that they will be able to better understand the patients and also their needs, and they will be able to identify the patients. Because we have been teaching the nursing process and all that. I can challenge you, like, there is no other nowhere a student can properly identify a nursing diagnosis for the patient care, because it is something we are not critically thinking and exposing the students to the real setting in the clinical care. We need to make the student identify the patient needs and how to come to that nursing diagnosis, and also uncovering the real problems to find the best outcomes. Especially we have seen during this COVID pandemic, even though there were a lot of PPEs that is available, many a time there were many problems where nurses were not able to take a fluid drink or go to washroom. So there's the real problems that we need to understand, and based on that we have to innovate what is that is needed to give out the best outcomes. And also the primary care competencies which we need to incorporate in our education is, that is, we need to educate the students to have empathy, and also allowing the students and the patients to know what exactly that is needed, how the care that the patient expects from the students. And also it is World Health Organization is also recommending that nurses be educated and trained in these scientific and technological competencies, and also sociological skills that is needed for better communication, and also to provide care in the primary healthcare settings. So they need to develop their full potential, because there are a lot of opportunities for nurses where because of the shortage of physicians or physician assistants, the nurse practitioners role that has come up, and even CHO that the nurses are getting the opportunity. So these are the real innovations or real roles that have evolved because of the technologies and the efficiency of nurses. So nurses' role in primary care is more of a partnering with the patient care, and that will help for the optimal patient care management. So there the nurse should be able to monitor the patient health, manage the medication, or teach the patient, like educating them, counseling them for their health improvement strategies, and also supporting the family members, motivating them for the healthy lifestyle, or maybe exercise or healthy eating. As we know, the times are changing. So these educational partnership and better training that will support the nurses to practice at the highest level that is possible. So there are different programs that can be introduced to improve their competencies, so which will help them to really to have a better care coordination, the population health management, the behavioral health integration, the chronic disease management, and a lot of other skills, including the soft skill, the teamwork, collaboration, leadership. So it is very essential to focus on the primary care competencies. And as we know, there are a lot of different roles, like we have a lot of scopes when we have essential skills, like the forensic nurse, where there are a lot of technologies that are involved. We can be a rescue nurse, we can be a flight nurse when we need to be oriented to the various technologies and how to use it. The nurse anesthetist, legal nurse consultant, the clinical photography, even someone good in that can explore that also. And many students are very good in making videos and all that these days. The nurse practitioners, which has been there, the robotic nurse. So one nurse can replace a lot of work of the nurse. And we know there are a lot of new things which are coming up, the replacing the pancreas. Recently you might have heard last month where pig heart is transplanted to the human being. which happened in the Maryland University. And, so we need to learn. It is something beyond the nursing curriculum that we have to learn. So if we look at this small video, this will tell us how a robotic nurse, and the artificial intelligence, gradually they can replace the work of a nurse, where there is a virtual nurse, and where a patient has to just communicate, and there is a virtual communication. And you can see that the nurse tells, you check the weight, and this is what is the weight, and that is entered into it. The nurse will give all the instructions, what the patient has to do. And even the monitoring weight, the blood pressure, or the vital signs. So this can be done, and this can be replaced by the virtual robotic nurses, and also artificial intelligence, which is coming in a long way in healthcare field. So we need to be getting very much oriented to the technology that is there in the healthcare field, and that is possible only by having a good partnership in the clinical care setting. We can become the competent nurses, and as nurse leaders, we have to improve the nursing education, and we need to create the opportunities for the progression of higher levels of nursing education, and also to leverage the technology for more efficient and for effective instructions that we can give. And more importantly, that we have to focus on the learning outcomes. So what is that our student will be able to do, or how exactly the patient will be able to deliver. So I can say that as nursing programs explore, there needs to be more innovation, and we need to ensure that all unnecessary barriers that is to be minimized, and we need to give a great support for all the approaches which will improve the technology and partnership in nursing education. So with this, I think I will conclude my session. I thank the organizers once again, and I thank my institute also for this, all this opportunity, and also special thanks to principal and the faculty of SRM College of Nursing, SFNC Society for Nursing Practice, the BioLeaks SRM Institute of Science and Technology, and my very, very special thanks to all of you, dear students, and other all the nursing personnel who are on this platform, for your patient listening. Thank you very much. Over to you, organizers.
Thank you, madam. It's a very good and nice presentation, engulfing. It is highly motivating for giving a prelude for all the presenters of the day and following day. Actually, really, you have touched everything. So from technology to partnership with various multiple simulation, we are part. I would like to extend my own thanks. So that thought-provoking session in the morning itself. So I'm very pleased to hear. I noticed due to some reason I switch off that video, but I was here for the entire presentation. So really, it's a thought-provoking thing, and for all the students, youngsters, they are the future, and they need to be developed in this area. And the teachers, already trained teachers, have to update. Even the leaders, we need to update to take up changes. So this is what it makes the mind into bring into the theme. And I think all the speakers are equally talented and from various aims and other places. They are highly potentials. I think these 2 days will be highly vibrant days, and start with a good note. Really, it's a very good presentation, and you brought everything into the screen. So I'm thanking my own behalf, ma'am. So it's a very good presentation. Future also, we will have the collaborations with you to any extent of research or any of that seminars or whichever we are going to, we will have link with you, ma'am. Thank you so much. And really, so you are from Manipal. So now only I am interacting with you. So I'm so happy about that, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am, for your enlightenment on partnership and innovation, the future nursing education. Particularly, I liked the tree concept which you used to explain the precautions for successful partnership. As our Dean ma'am told, it is a thought-provoking session.
And one more thing,
Yes.
ma'am, here I would like to add to. So we have a very good Asia big simulation center at our SRM Medical College. So that is the one. So it is giving a lot of input for us. We have a partnership with them, and our teachers are trained for a pediatric and then the adult health, and almost the 6 trainers are there already. Trained people. Now all the teachers are getting benefit out of. In turn, they are going for training to update their knowledge, and the students are also given all that benefits when they are leaving. By 4th year, prior to that, they are getting that certificate of that ACLS, BCLS, and all other high fidelity mannequins for the medical college. Recently, they got permission for 100 to 250 medicals also. They extended to the scope level, and they are helping us to grow. So we are fortunate. Our management is highly concerned with the students to enhance their knowledge in all the way. And all interdiscipline we have within campus, including engineering, that engineering field, technology, everywhere we have a collaborations, ma'am. All are helping us to grow. So yeah, I was just adding to your presentation. We have a partnership in a nice manner within this organization. Thank you so much. So it is a lively presentation. Thank you, ma'am.
Thank you, ma'am.
Thank you very much, ma'am, for your wonderful and informative presentation. On behalf of our organizing committee, we would like to present a small token of appreciation.
Thank you for the virtual certificate.
Yes, ma'am. Thank you, ma'am. So now the COVID, it made us to be everyone from the last year, no, the last 2 years, even last year also through SFNP, we conducted the lockdown period. So now we are in the college. Everyone, we were at the home, but we conducted so that they extended a lot of help for us. So really, it is, we didn't feel aloof or isolation. So we have a touch, and the COVID taught every one of us, the students, teachers, to forcefully learn the technology. So that's the thing. Thank you, ma'am.
Thank you.
Thank you.
Thank you so much, ma'am. Thank you.
Thank you. Please excuse me because I have some other presentations.
Okay, ma'am. No
Sure,
problem, ma'am. So we
Okay.
will meet sometime. Yeah, thank you, ma'am. Yes.
Yeah.
Good day, ma'am.
Good day.
Good day.
All the best, Dr. Gopi.
Thank you, madam. Nice to see you. It's a very good presentation. I enjoyed, madam.
Thank you.
You know,
Thank you.
Gopi, known people for the north.
Hello, madam. How are you, madam? Good morning, madam. Good morning.
Gopi. Good
Good
morning.
morning. Nice to see you, madam. Nice to see you, madam.
Nice to see you also. Yeah, in the screen. Okay, thank you. So where are you? In Delhi or?
Delhi, madam. Delhi, madam. Delhi, madam. Today I am coming.
Okay.
Good
Okay.
evening. Yeah.
Okay. All the best.
Thank you,
All the
ma'am.
best
Thank
for your presentation. Yeah. Yes.
Thank you, ma'am. I would like to invite Mr. Sheba, Associate Professor, Department of Medical Surgical Nursing, SRM College of Nursing, to introduce our next esteemed speaker. Ma'am, please do the honors.
I'm privileged to introduce
Congratulations to the various awards you have achieved, a lot many, even TNA, everything
Yes,
you have achieved. So I am very happy
Thanks.
to see everything.
I am your student, madam. That is the biggest gift.
It is an honor
Blessed.
for me also.
It is a
an
blessed.
honor for me. Yes, yes. I
I'm
am very,
blessed.
very happy to see. So my students are going up, up, up and high. So I'll be very blessed, and I always bless them. Yes.
Thank you, madam.
Thank you.
Good morning to all. I am privileged to introduce to you the second speaker for today's session, the man of the hour, who is simple, very energetic and dynamic and inspiration to all. Dr. L. Gopichandran, Associate Professor, College of Nursing, AIMS, New Delhi. About Sir, Sir did his UG at Adipara Shakti College of Nursing, Chennai, completed PG at SRMC College of Nursing, Chennai, PhD Medical Surgical Nursing in Mahir University, Chennai, Fellowship in Clinical Research Methodology and Evidence-Based Medicine, and also done many certificate courses like BLS, ACLS, and CCLS. Sir started his career as ICU nurse at Malar Hospital, Chennai, worked as special trainee, cardio and CTVS nursing, assistant professor, lecturer cum HOD, Ministry of Higher Education, AL TAF, KSA, and currently working as an associate professor in College of Nursing, AIMS. Sir also holds various roles as President TNI Delhi branch, Founder President Society of Cardiac Nurses, Principal Investigator ICMR funded project, National EC member TNAI, PhD guide for AIMS Delhi, and we also have online training module on British Medical Journal. Awards as such, Sir has got many international, national, and institutional awards. He has been awarded International Award for the Best Faculty from TAF University, Government of KSA, and National Award from the Department of Administrative Reforms and Public Grievances, Government of India. And from the institution, he got for the Best Research Working in Nursing and Best Community Work in Nursing, and also got Certificate of Honor and Recognition by Indian Society of Emergency and Cardiac Nursing at Delhi. And Sir has innovations as such. Sir has developed Nurse-led mobile app for the management of patients with heart failure, mobile app-based prescription for patients undergoing palliative care. Sir undertaken 17 research projects, international 1, national 1, institutional 8, and 3 funded projects. Sir totally published 57 papers. Among that, indexed is 40 and non-indexed is 17. Sir has also published 3 books, and Sir has presented 10 papers at the international level, and he has been an invited speaker for 114 conferences, chairperson for various webinar series, and he also guides many MSc theses. We are fortunate to have the eminent person to present on the topic Mixed Method Research, a cornerstone of evidence-based practice. With this brief introduction, I hand over the session. Over to you, sir.
Thank you very much for the introductions.
Yes.
First of
Still
all,
more to achieve, still more lot is yeah, you have to achieve it and you will do it.
Thank you, madam. Being your student, I want to be the better human. That's what I learned from you. That is want to be continue for till my end of the life.
Thank you so much, and still move your height in the profession.
Thank you, madam.
Yeah.
First of all, I would like to thank my respected teacher, Tanya Mal madam, and Vijayalakshmi madam, and all the team member of SRM College who was organizing, and also Society of Nursing Practice, Rutra sir, and all team, Mr. Gopi, everyone. Really want to thanks to everyone because who invited me to share, because I'm always part of the the SRM, because not only my teacher and all the people who are there always very attached with me, and that is make me to be more always proud and always to work with you and collaborate with you every time. And again, I'm also be the part of the Society for Nursing Practice last 1 or 2 years. It was also made me to be here today, and that's really I think I have the different groups today. Whatever I know it's a 40 minutes my time, but still I'll try to express myself, what is my experience, everything other than because this is a topic, definitely it is a complexity in nature, because when you go one type of approach, you go and study, you find a lot of difficulty. Again, you are how you mix both quantitative and qualitative. That really it's a kind of mixing. It's very difficult one anytime, anywhere. But when you do for the reason, for purpose, definitely make you understand why we are doing, what is the outcome of this research. Definitely going to make to eye-opening for today. Because why I am telling, so last session, Dr. Asha madam is highly highlighted about the innovation. Even I am also part of the many innovation nursing. But really, when I go into quantitative studies, even nurses are in nurse researcher in India. Mostly we started our career as a, mostly we are involved in quantitative research other than qualitative. But in international scenario, they do so more qualitative than quantitative. But today I have seen that my students are coming with me, sir, we want to do mixed method because we want to quantitative, somewhat we don't want to qualitative. What is the reason behind it? Everyone realize that we know that this is we were in the book we thought the school of thought everyone, even I studied in SRMC, I got it, Madam Tanya Mal madam was there. They thought about holistic, they talked about patient centered or family centered. We didn't understand that time when we are talking about almost 22 years before, because we know that for writing, okay, fine, but how I understood. But when today, when I become the nurse researcher, because we know that nurses are working in the clinical, they are loaded, they have nurses patient ratio, it's still not as what we expected, because we are in shortage of nurses in India. It's very difficult to get what we expected, even though 1:1 or 1:2, whatever we do in ICU, when you go to the ward, still I can see many government hospitals, there's number of the nurses, patient load is more for nurses, so they cannot be able to give what we expected, what we see in the curriculum, do patient education, patient counseling. It may not permit them. As student, you are doing so many things because for the requirement you're doing, but you may not understand that time when a student create exactly what the patient expects, what you are trying to achieve it. When you become nurse, full-fledged nurse, really, when you every day being a nurse, you learn something. You learn from the patients. And same like nurse researcher also, when you go to the patients, when you talk with them, you understand multiple things. That's why the COVID made you to realize that today what is technology, made to realize that what is the burden of the patient, realize that what is today looking for the protocol-based treatment. These all we come to know, even the relationship, your emotion, your bonding, importance of the family, that all today we realize same like only when you go as a nurse, you spend with the patient, you really come to know exactly what the patient is looking. Because I am, as a researcher, I landed at AIIMS Delhi. I started to work with heart failure patient, especially end stage of disease. Even I have limitation of the language. I was that time still that I would have learned in Hindi. I learned some extent, but still in my language you would have learned, I would have expanded still more, because I'm telling the language is one of the barriers. If you want to really to explore the fact or explore the things which you are looking, especially for your phenomena, what you are looking. Why I'm talking about, because that every time we go with the quantitative aspect, definitely you have standard tool, the tool which you or what you are looking at to get the answer. Sometimes if the tool is not good, valid or not standard, or it's not to the, it may not generalize to any population, definitely you may not get the answer. But you go into the qualitative study, definitely, again, there is a things, it is dependent, it's completely subjective, it's completely individual based, it's patient centered. Why I'm telling, every patient unique in nature, everything, their background is different. That way, when I worked with the heart failure patient, I really explored about how much is the burden they have, why they are not adherent to medications, what is the problem, other than I have found that is the economical problem or the education issue or something which you come to know by different perspective when I talk with them, but still not able to cover with the tool. Even though the tool have validated standard one, it is maybe tested in different setting, but I cannot able to achieve it very well when I go into that, explore from the patient when I do the interview or maybe do some focused interview. So when it is not only patient, you come to the family who are care provider. That again another, we always witness them, the patient family, they have some burden, but they may not, so many hidden things are not able to understand by them, because I can able to say when the heart failure patient life expectancy. Yes.
Sir, sorry to interrupt you.
Yeah.
The slide is not moving.
No problem. I mean, just no issue. I can move it. Okay.
Okay, sir.
So when I go into that, I understood that that is family caregiver also, they have a lot of burden. Even their condition become more worsening than anyone. Why I'm telling all the things about this mixed method, because the both method, if you apply today, you understand the fact and which you are explore on the phenomena which you are looking into that. That's why how both are supporting each other when you are going to use it. That's what today my talk. Even though I have 40 slides, I'll skip some of the slide very quickly, but some area where I want to give weightage, I will give you. Overall, my objective of the session is either whoever the nurses today, you understand how you are approaching the patient, and whatever the research you do, that is not with only the what you learned from the book. You, with your experience, you learn a lot, that you make that sense of that which are thing, whatever it is. So end of the day, you will understand my session that what is mixed method and characteristics, how when we conduct this study, and what is the reason behind the study, and different types, and what are the steps for conducting the mixed method, and what are the criteria for evaluating the mixed method, and strength and weakness. I think everyone know this process, the research process, especially who are beginner today or students. Just understand that the research is something, make you to today we are looking for expanding the science, we adding on science to your knowledge through your research work, but everything is start with your interest, what you're looking. That take time for you being a beginner, but still you open, you do explore, you think more, one, where you stuck, where you find problem, you want to fix it, that the area is the interest of the area. Then you go for literature on the base of that, whatever this, looking for related to that particular issues, that is called review of literature. Then you state your problem. Then according to the state problem, you go for identify your variables within your problem or statement of the problem. Again, you generate the hypothesis or testing hypothesis. According to that, if you are generate a hypothesis, your research design is different. You go for observational study. If you are testing the hypothesis, you go for experimental study. This is a very key point where this is what today we are going to discuss about the mixed method. Then according to the design, you go for the data collection and analysis interpretations. Again, quantitative, you for detecting your data, and for quantitative or inducting your data. With that, we test the hypothesis and test your, according to that result, what you are obtaining, then you go for the report writing and you are disseminating your finding. This is what the continuous process we do. Again, you can extend your work in further way, which are not, getting your result, what you're expecting. Or maybe you also test in different setting, which you look into that. Or whichever limitation you faced also, you want to overcome in the coming of the research which you are doing. That is what the research cycle. Again, the most important area I told you, this is the design, that we say it's approach. Then we have methodology, design, method, instrument, that where we are today, we are talking about. We may go into quantitative and qualitative. I told the quantitative is a numerically, the data which are looking into that. What madam is told, so many physiological, because medical consultant or doctors, they always look for physiological parameter. They look always physiological parameter, but nurses also look in physiological when you do in acute care, emergency care, or ICU, wherever you look, always look for physiological. But the patient start to recovery, go for the subjective wise, what he is expecting, what he want, how to improve his quality of life. This is what here we are in qualitative. So we do different approaches, different design we are opting according to your limitations, whether you go for RCT or quasi-experimental, or maybe there are, true experimental. In qualitative, I think everyone know that is case study and accent research, ethnography, or phenomenological approach. I already mentioned about deductive and inductive methods. Most important is what type, how you do the data collections and analysis, that even though you need statistical support, or if you are really good enough, you can decide what you are looking for according to the descriptive analysis, or maybe go for inferential, which you look according to your hypothesis. Again, go for the instrument is most important, especially in descriptive study. The instrument is most important to know that instrument ability to answer your question which you are looking into. I think it's a very basic, everyone know what is quantitative research. It's completely collecting the numerical research, numerical data, which converted into the information. That's what you are looking into that. But it is a measurable data to formulate a fact and uncover pattern the research. But qualitative research, it is for gain and deeper understanding the subject. That's what I already mentioned about. How do we deeper understanding about subject? We need time. You have to spend with them. You have to collect. You have to talk with them. You collect the data very appropriate manner. Nowadays, we understand that patient, satisfy the patient is not easy, because even though you may have some system, you may have some protocol, whatever you do manage, every patient is unique in terms of diverse in nature, in terms of education, in their, their economical status, their culture, their belief, and so many things. How do you satisfy them? So that's why when you understand them easily, then you're able to manage. But yeah, that's why I told in nurses scenario in India, they don't have time. I used to talk all the time with my nurses working in the AIMS. AIMS is a top institution who do very good in terms of the managing the patient, is providing the best in terms of the quality of care. Still, there is a lacunae. The nurses doesn't have time to give the health education, which you expected from the from the patient also, or from the healthcare perspective. Why? Reason is lack of time. Even we doesn't have the protocol, but we do. Some of the nurses are valiantly, they do by the giving, our students, they do mandatory for the requirement. Why I'm telling you, when you talk with them only, you understand exactly what they want, and that make the difference in the outcome, especially the patients the quality of life, because what you give that point of care at the institution, what the patient's supposed to carry out at the home, that reduce that, the re-hospitalization and reduce the mortality and morbidity, especially the patient who are with the chronic diseases. So there I pointed out that, why the importance of this doing the qualitative study to understand them, it's better than, because I told every individual, make different, every individual give a lot of, the view about their problem. Then you can able to generalize to the large population. That makes that a lot of sense on that. Even you make the instrument also that be more valid and maybe reliable. So that's why the mixed method required both. It's a mixing of both and quantitative, qualitative methods. And maybe you do with a single study or with a series of studies that make understand the research problem very well, other than you go with only one instrument to measure it, what you're looking for the phenomenon. So I bring it to the pragmatisms. Why when I talk about mixed method? Because every time we talk about something theoretically, but when you come to the action, it is failure. Same thing happen in the patient management. Whenever we want to do something, we do by systematic manner. Finally, we see that patient satisfied, no. Patient is improved, no. Then we come to know exactly what we are doing sometime wrong. That's why the pragmatism thought about all the time, that experience center of the universal, everyone instead of touchstone of the experience, that action gets priority over the thought. That way, the pragmatism is the approach. Always go with the mixed method of research. This is what we do as a cycle, as a researcher. It is not only the pick heart today. It was for replacing the human heart. This is innovation. So we universal everywhere. There is a lot of things happening in scientifically. Sometimes what we today we see, it may not false. What we see false may be true. That is what research going on. As a researcher, we travel. Even today, nurse researchers also travel the same way to journey with it, to look into the patient different way and trying to satisfy them to make it to that. For that, they are looking into the insight of the patient is most, and insight of the family more important. Understanding the patient burden and family burden is more important. For that, we require a lot of exercise. That exercise only systematic research approach, what we are looking into that. So that you get it through your experience. That's why the pragmatism always you look into a prediction, you have assumption, we set your hypothesis, and you do into the adding into the knowledge. Again, on knowledge, you construct the theories. Today you talk about even Nightingale. It's a theorist for the environmental theory. She was just economist. She made understand this, the how to control the infections, how you free from infection. Today, every scientist talk about Nightingale, other than what she is a nurse. So this is always like cycle which you have bring into the knowledge, how you want to change in your practice, how to improve the patient care outcome. That's why the pragmatism is action oriented. And also the key for the mixing method is how your data to be linked. Quantitative is numerical and qualitative is always with thematical. The words, how you link and to appropriately to stage into research. And also it is look like, the diverse research lens look in different angle to see the patient problem. Even the burden of the patient itself, you look in different way to come to know exactly what burden the patients. So these all like making the sense of that understanding about the phenomena through the mixed method. Again, this is one example. Every time the mother is always coming to the delivery, whether they want to to choose it for the cesarean and normal birth, that is always the assumption. They have also choices to go into that, even though whatever. But we usually go for normal delivery because they expected that post delivery they want to be healthy in that concern. And sometimes they don't want to, they want to avoid it also to pain or some other discomfort during the delivery. These all like kind of things sometimes cannot prove by quantitative data. Everyone make the differences, how they're taking the differences by decision making. These all can be also measured by the qualitative. That's why the mixed method always take the differences, which to understand exactly what they are looking, that can be generalized to the larger populations. I think this is a cycle. It's a dynamic one, how you go into the approaches and how you collect the data different way, whether you want to do quantitative or qualitative, which will be priority, which will be sequence. Then you can go for the integration. That means how you mixing and getting into the results in the very logistic manner. And come to the qualitative. I think everyone knows this qualitative. I think the beginner, this is a numerical data which you are collecting from the quantitative studies. Qualitative, already I told, for the thematical word which you are collecting, then there is a different stages you collect from the audio visual, again transcript into the word, from word you went into the theme again go into the categories, then you are able to mix together. And how you collect the data from quantitative and qualitative? The quantitative by questionnaire, survey, census, attendance record, checklist, many more. Same like in qualitative, you always go with interview, focused group discussion, observations, some document studies, case study, and audiovisual material. This is very commonly we do nowadays, audiovisual and recording, and trying to get that tape recorded, and then you go for transcript, then you go for the validations, because we need set of people to work who are with a similar experience, they can able to derive it. And come for the framework for viewing the perspective of the mixed method. This is the framework. We do quantitative, because both are go with simultaneously. This is also one of the types. When go with the finding, after analysis, then go for the comparison. It is called the mixing or integration. Then go for the final outcome which you are looking and stating as a report. So here, only the things before go for the types, how you go, whether you go with both methods same time or one by one sequence manner, or how you give weightage for both, that as an investigator decide. That's what today you are going, you are listening to me, then how you choose this design, why you are choosing the design, with which type you can able to opt it for that, go further for your study according to the research question which you are addressing. The basic characteristics, it's a rational for the design, and also it's the collecting about qualitative and quantitative data, and the priority, and consider the priority, consider the sequence, and how you match the data analysis to the design. And also you have to also keep the schematic diagram for this your procedure, because whoever read your article or your report, they have to know which one you did it priority, whether you did priority of as a quantitative or qualitative, because there is a different design types are there, but still you have to mention by the schematic way, then everyone to understand how you went through your research work. So when you conduct this mixed method study, definitely there is the biggest question in your mind, because I used to see my student always they come with, they want to say that, sir, we want to do some qualitative also. It is good, I can explore my phenomena. It's good. So even though you come with your idea, you interested, somebody influenced you, please go and do the mixed method. But you should have the rational, be the investigator, why you are doing, why you are opting this design, because it is not only complexity you are going to face a lot of problem. You always have justification about choosing your design. That's the most important, because its outcome is what you are looking, what you're expecting, you achieve through only your design. Because every design, even if you talk about experimental design, why you go for RCT, this is the strongest design. Why we say strongest? Because which the design reduce your bias, reduce your contamination, controlling all your extraneous and confounding variables, reduce your error. This means that a rigorous exercise you are doing, or do the best research work as a systematic manner, to say that whatever you are finding can be generalized to the. Please keep in mind all the time, whatever, same like in qualitative also, whatever you do, that able to generalize. When you mix both, you do systematic manner, you do both, that means you are getting the best result what you are expecting. That's why every time you go always, but same time, you should not waste your time, energy to do qualitative, which is not necessary. If you want to be whatever your data looking for quantitative alone. So that way you always keep in your mind, when you look for mixed method, that's always important, because it's not only wasting time, energy and resources or whatever the logistic, but you should know that always to be define yourself why you choose this opting this design. That should be always, but if you definitely needed, you should choose it. So when we have both quantitative and qualitative data, or one type of research not enough to explain to answer your questions, when we want qualitative research to help explain quantitative findings, when you want to generalize your finding into large population, when you want to provide alternative perspective, this is whatever I mentioned, all the things, that is a point for you to know why we are going for this method. Then again, reason again, same thing, it helps you to explain and interpret very well of your result and explore your phenomena, which is the hidden phenomena. It's very difficult to understand insight of the patient, very difficult. You cannot measure with the 120 questions, with go and assess them. Please tell me your whatever you are looking for it. It's very difficult. So many things are hidden from every patient, different way. That all today, even you see in COVID, we come to know many things after this problem. We realize that, oh, that much there. Even patients, everyone ignored about psychological problem. Today, everyone landed in psychological problem today after the COVID. Everyone thought that COVID will just kill the patient, but after COVID, many of them is suffering, so many other issues. These all I am telling, this phenomena, very difficult to explore the phenomena, what you have, prediction, expectation. You may have literature something, but beyond the literature, many things are there. That's why being a researcher, always go into that way. You think, and make your assumption, get into a research question. After the derive your statement as per whatever the phenomena you are looking, that phenomena you want to explore, you go with a different design. You want it to be link between this relation between these two variables. You need the hypothesis that you want to test. This is like Veda. You have to always keep it in mind how you go being a researcher to do that. And again, I told you how to develop and test your new instrument. That is one of the today need of the hour to understand. So because every instrument you think it's a good, you may self-made, you are maybe standardized, but it's not enough. Sometimes you have to need some kind of study to develop the instrument. And also strength of the single design. It may, it complement the strength of the single design. It overcome the weakness of the single design. It address the question at different level and address the theoretical perspective at different level. These are all most important to everyone to understand why you go for, mixed method. That make you to clear than before go for opting this method. Come to this is very simple to understand. This is a very, very, different types. If you go in different research book, they give a lot of things. So there is a convergent, explanatory, exploratory, but it's very simple to understand because no need to worry. You can opt any design, any types that give you answer, but you have to understand which one is priority, what type of the, you have research question. Then according to that, little bit deviations in your, designs will be varied. But overall, what type of problem, research, your question in your mind, according to the, you can opt your design. So there is a basic designs. We have 4 and complexity because a little bit another mixed itself complexity. Still you go for little bit depth in your study, then go for transformative and multi-phase. Multi-phase means multiple studies are involved in the design. The first one is convergent parallel. It's considered parallel means equally you go, data collection go equally and the sequence also go simultaneously. Use the data, both are very similar. That is called convergent parallel. You understand convergent parallel. Example, both are parallel. Both data collect quantitative and qualitative, both are good, do study, both are parallel, both you can start at the same time. After that, you go for comparison, the result, whatever, then according to the result, you go for the interpretation. This is what convergent. Explanatory, next one. Explanatory is the, it is sequence little changed. Here you start collecting the data with this quantitative, then collecting the qualitative data. It helps you to explain, elaborate the quantitative result. The purpose is that qualitative result assist the finding of the quantitative study. You can see that the quantitative data collection is the first one, priority and sequence. Follow with it, go for qualitative, and you go for the, after the result you obtain whatever you can mix with the both, the integrating with the both result and do the interpretations. Again, for the characteristics, the data collection priority is quantitative and sequence is quantitative, and use of the data. Why you use the data? To polish each other, which means polishing each other. Qualitative will polish the quantitative, quantitative will polish the quantitative. That's what. Then go for next one, exploratory. Here opposite to the again explanatory, because here you start with the qualitative and follow with the quantitative. Same like both are have polish each other. Only the differentiation, the qualitative start first one, the quantitative is the second one. The sequence is changed over here for the exploratory. This is the basic method is the last one, embedded. Embedded means nested one. Nested ones, you can often change anyone. You can change quantitative or maybe qualitative as per the priority, but both are sequence, maybe the simultaneously you can go, or also sequentially also you can go. You can opt which one you wanted according to investigator limitation, whichever you like it, you can go. The overall, you have to integrate the data and you're mixing the data and go for the interpretation. So example, you can see the quantitative, you do baseline assessment, you do intervention, you do post measurement. Again, you go for the qualitative measurement, whichever they can ask about what is the participants, what is your experience on your intervention. Some intervention you applied yoga. So you ask the patient, what is your experience on your yoga? You can explore about something. This add on for your result. Then overall the result you go on interpretations. Then come to the little bit advanced one, that means complexity, whichever I told you, whatever we've seen, it's a basic one. This is advanced one, which you do. Number one is transformative design. Transformative, transforming the use of the qualitative method to complement, explore, and augment to the quantitative one. Here we do that. What is the difference between embedded on this one? Because here the qualitative data, what we are doing there, we do after the study. Here you do the experience and before also. Before start your quantitative method, you do the qualitative study. Again, you start with the quantitative pre-measurement. During the time of intervention also, you do qualitative study, data collection. Again, you do for the post-measure quantitative study. And finally, you integrate your result and give the report. The differentiation between is the transformative. You do two qualitative assessment during the time of your quantitative study. That is the make the difference between the basic type compared with the transformative type. According to that, what you are looking, I told you the research question you looked at before start your study. I want to explore something from the patient. You can go with the transformative. You don't want to explore something. You want to explore about at the time of your study or after the study. You can go for the basic one. So this is depending upon investigator which you are looking for phenomena that may decide about how you make the differentiation between both transformative and the basic design. So come to the multi-base design. This is the one largest study because multi-base itself, phase 1, phase 2, phase 3, phase 4, whichever you do, you mix everything, whichever is required, but depending upon what type of research question you are addressing. Example, I want to know, explore, or maybe to understand about the effectiveness of this any program. You want a BSc program, you are the first year, first batch of your basic program, nursing programs come out from any of the university or anywhere. You want to know exactly to evaluate the program by quantitative and qualitative manner. You want to know first year, second year, third year student. You want to explore from the student. You want to explore from faculty. You want to explore from the administration. You want to explore from the system of the exam. Everything you have multi-basic, you do different time and integrate it and get into the result. That way it is called either you go for qualitative, sometimes you go for quantitative. Again, you for qualitative according to the nature of the problem which you are looking, or then you finally you do the integration. That's why this called a multi-phase design, because it is the design with a very longitudinal and it go with a different time, different setting, and finally you give the result after some time, maybe after 1 or 2 years, wherever it's required pre and for the data collections. So overall, and you have to see that exactly what you are looking for the the steps. For the mixed method of design. So first of all, you have to look for determine the mixed method of study is feasible, identify the rationale for a mixed method study, identify the data collection strategy and type of design, and developing the quantitative and qualitative mixed method research questions, collecting the quantitative and qualitative data and analyze the data separately, concurrently, and write a report. These are all the steps. Whatever I told you, this same step you go with any kind of study, or quantitative or qualitative. But in mixed method, you have to know exactly, is it, first of all, you should know that is it feasible, is it rational for you, this study, and you also what data collection, how the strategy, what type of interview technique, or wherever, whichever they required according to the quantitative, qualitative, that you may choose it. And developing again the questions, it's more important, and collecting the data, analyze it and report it. So this is what overall, for the dynamic circle, whichever we discussed with you in the step by one. Same thing only it is showing as a diagram for steps of the mixed method research. You same like you go with any other design, but here little bit to understand how the priority and sequence and visualization, which will be more important. Which one you apt according to design, it may vary, but you have to finalize before go into the study. Whatever I mentioned, the same thing. This is the first one for the determining the mixed method studies. You have to know the research problem, and you have to fit into the problem to the fixed method, and access to the both qualitative and quantitative data and background and resources. I think slides not moving. It's fine. I think I already explained about the identifying also for the mixed method study, to consider that collecting the quantitative and qualitative data, be explicit in the rationale and include the yearly planned report. Okay. So identify the data collection strategy. As I told you, you should know what kind of data collection method you are going to opt it. That should be, you have to plan it. And also you have to develop that, method of qualitative and quantitative mixed method, the questions. This is before you start this mixed method, you should know very well that You have to identify the questions prior to the study and during the studies, and also you have to create the both exploratory question and also analytical variable questions. And the question also will merge depending upon the type of the design. And the step 5 is to collect the quantitative and qualitative data. The sequence of the data collection depend upon the type of the design. As I told you, every design explanatory are different and the exploratory is different. Which one is the prior you have to decide. According to that, you can go for the opting the design. And all the design presentation of data information will be well organized. And I think every study design, you always end with analysis, and the last one is the report writing, depending upon how the pace of the study it may vary. This is the most important in your today talk. I told you, any kind of, if you go for mixed method of research or writing the proposals, you should always keep the 6 questions in your mind. It may help you to know, to justify that why you choose the mixed method. The first one is just the research question justify the use of the mixed method. And is the method sequence clearly described, whether which one is the priority, which one be well aligned with the study aims. This is what we are missing over there always. That should be taken care. And his data collection analysis clearly described and well aligned with the study aims. And any one method dominate other, they will be equally important, because sometimes you may give one more important to the quantitative. Sometimes I have seen some of our students, they come with some part they do qualitative, majorly they do quantitative, but you have to decide that exactly you are doing is right, because what phenomena are looking, it may vary, or your question may be varied. You have to decide, or you want to give equal important or something dominant, but you have to be justification, you have to keep in your mind. And did you use the one method limit or confound the other methods? Definitely that to keep in your mind. That also make you that the quality research you are looking for it. And when, how, why, who the data integration is achieved. So these all keep in your mind when you go for choosing this design, because it is not only the choosing design, not for just to complete your task or to interest of your to do mixed method. You should always have justification in mind why you are opting this design. Is not only for the it's a challenging one. You always keep in that you do work something which be reliable and relevant for your research. So there's also some strength of the study. I think I already described about it. Definitely it is easy to describe and report. It can be useful when unexpected results arise from some prior study. Sometimes you may not achieve from the old previous study. You may go with the mixed method. You get the result what you were expected, or maybe you get some newer things also from your study, and can help to generalize the qualitative data, helpful in designing and validating the instrument, and also can position the research in the transformatic network, which I already explained to you. These are the weakness. Always keep in your mind. It is the time required. Always the discrepancy between the different type of data. You have to be able to understand. You have to be always keep in your mind. And can be difficult design when to proceed in the sequential design. It's definitely a challenging one. And little guidance and on transformative method. So this is the example. Even many books given. I told a lot of example for the patient experience, nurses' attitude for carrying the patient, caregiver burden, so many areas we can discuss. We need the type of study, qualitative and quantitative. I'm not given again, this also given nurses' attitude towards the care of the HIV/AIDS patient. So researcher needs some survey to understand the nurses' attitude toward the care of the HIV patient, to conduct some focus group discussion. Same time, you need some of the data also for the quantitative study to understand about the. Then you go for mixing of this. This is what I keep on telling, that you have to know, you have to have justification why your one study alone not giving your your result which you are looking into that. So I'd like to conclude with that. The mixed method research draws on potential strength of the both qualitative and quantitative methods, allowing the research to explore diverse perspectives and uncover the relationship that exists between an intricate layer of our multifaceted research questions. So many things I told you, it's hidden, especially the patient point of view and caregiver point of view. Sometimes you need kind of the research method, which really as a provider and policy maker strive to ensure the quality and safety. This is today our concern. Today our concern is quality care, quality healthcare. Everyone should at last one to get into the same care which you are expected to provide for, which one we are giving to the first one. So the safety of the patient is our concern, and the patient family member, the safety of the family member. The researcher can use the mixed method to explore contemporary healthcare trends and practice across increasing the diverse practice settings. I'm really happy that again I am be the part of this conference. And I want to say thanks to Madam and all the team members. I think they have given me time exactly. I completed. I think this is a time for you also. If you have any questions in your mind, which you are really, I know this is one of the very challenging topics. And if you go into work, you experience as a researcher, you get a lot of experience other than what you understand. But I hope that I made it clear on that. This is the point which I am looking into. Thank you very much once again for everything.
Thank you, Gopi. It's a wide eye-opening for all of us. So actually, I had an experience when I was handling master students in Ramachandra. One of our candidates, I think you remember her, Annapurna Mary.
Yes, madam. Yes, madam.
And she did the ventilator patient, among
Yes,
the ventilator patient.
Yes,
and one of my batch student, Sashikala.
Yeah.
She also, we have tried with the MSc level itself to incorporate the qualitative type of study.
Yes,
so it was a fascinating time. So in 2005, I am telling 3 and 5. And we have incorporated the qualitative component in the master level study. And it came out very well. And the thematic analysis it gives a lot of, because many queries within the bedridden patients are taking invasive procedures, a lot many cardiac patients and then neuro patients, lot many patients, they couldn't be able to express what are all the quantitative aspect we are going to assess and what is the scale and other thing. So beyond to that, they have the inner many queries within them. So those queries will be built or that thing can be derived through qualitative component. Now the huge cry is for the mixed method. Each one, the qualitative is complementing the quantitative and no method is high or low. So that is quantitative is complementing the qualitative. So it is vice versa. It is a comparison and then we can, whatever says, it is related with quantitative aspect, whether it is matching to the both. So as an evaluator, we too also can compare those things and then really true, whatever they say or feel is matching with the quantitative data. So like that, we need to analyze our finding, then it gives strength. So it gives strength for the entire study and remove bias. So these are some of the important things. We are in the evidence-based era. And we are very much welcome. And not only this COVID, even prior to that, we make an attempt. But this COVID, so as very rightly you quote about, so many of the survivor. So we had a discussion yesterday with the Sweden University of West. And they have undertaken a study as a post-COVID survivor. And we are having a collaboration with them as a MOU. And with that, we need I just represent the quantitative aspect alone, not much sufficient to derive our conclusions. In different ways, they have taken us a longitudinal study. And we are also willing to be a part of them and to take a subset or the study related other data through qualitative analysis. We are having a plan to incorporate the qualitative component, and we do in the Indian scenario and match with the Sweden population as well. So this is what our research collaboration is little more extending to the other universities in other country as well. And we are interested to have MOU with your aims. Definitely. And then we too also can do some inter-institutional study also we can take up. So please kindly work on that.
Thank you.
And then we will take up some good quality and quantity aspect studies and our medical college and then our university is little dynamic to incorporate all to do a collaborative research and other thing. So please keep in mind.
Definitely, madam.
Keep when you are coming over here, we will meet and discuss in which area you are prone for, and you can be able to help us, and simultaneously we can grow.
Definitely.
Your aims, and then our SRM also will start growing with the collaboration. Thank you
Definitely,
so
madam.
much.
Thank you, madam. Thank
I
you.
am so impressed, and then it is very nice. I am very, very proud. As being my student, used to have a very good ideas in the research component as well, and coming up very nicely and putting forth everything in a easy and rememberable way for the student group and then the faculty group. So really, it is very thought-provoking, good session. So I congratulate your presentation, and then God bless you.
Thank you very much, madam.
Family.
Thank you.
Yeah, for a
Thank you,
good professional upliftment. Yes. Thank you.
Thank you, madam. Thank you very much. Thank you to
Thank you,
everyone.
ma'am. Thank you, ma'am. Thank you, sir, for the wonderful presentation on mixed method research. Sir, you have explained clearly when to conduct mixed method research and reason for using mixed method research. And you have explained with examples. Thank you, sir, for a wonderful and informative presentation. On behalf of our organizing committee, we would like to present a small token of appreciation.
Thank you, madam. Thank you, everyone.
Yeah, thank you.
Thank you, sir.
When you are coming to Chennai, try to meet
Definitely, madam.
in person. Yeah. Thank
Definitely, madam. Thank you, madam.
Thank you.
Thank you, sir. A successful event deserves a grand opening. A leader not only gain knowledge for themselves, they set path for their followers to continue their legacy. With such legends who has joined us, we will start the inaugural ceremony. I would like to invite Dr. Kavita, Professor, Department of OBG Nursing, to host the inaugural ceremony. Ma'am, kindly do the honors.
The inaugural session will be started after joining for the Pro VC and then the Vice Chancellor we are waiting for and the Chief Guest. So soon they will be joining. And after that we will start doing the inauguration. Till then, some of the queries about the last two presentations. So any one from the participant, so you can bring into the chat. What are the chat box thing you can able to discuss on that? Who is dealing with that chat box view? Any doubts or clarifications?
Chat box. Ma'am, no queries in the chat box as of now.
Okay, you just check. I think Pro Vice Chancellor Medical and Health Science by 10:35 he will be joining. And we have to check for the Chief Guest and all other dignitaries whether they have joined. You can just kindly find out. Till then, you do some of the play for them to
Yes,
keep engaged. Yeah. Another 5 minutes, or we can wait for another 5 to 10 minutes, probably.
Yes, ma'am. Ma'am, Pro Vice Chancellor joined, ma'am.
Morning, ma'am. I have also joined.
Good morning, sir. Very good morning, sir. Sir, Pro Vice Chancellor, sir, told, I think within 5 minutes he is joining, sir. I just reminded to the secretary.
Okay.
Just I will find out again, sir.
Okay, ma'am. I'll wait.
Yes, sir. Yeah, please, sir.
Good morning, everyone.
Good morning, ma'am. Our chief guest, Dr. Bimla Kapoor, also have joined, sir.
Morning, ma'am.
Welcome.
Morning.
Good morning, ma'am.
Good morning, everyone.
Sir, Dr. Muttamil Chelvan is the Vice Chancellor of our
Yes.
SRM IST,
Yes.
ma'am.
Yes.
Yeah. He is going to preside over the inaugural session, ma'am.
Such a pleasure to meet you.
Yes, ma'am.
And
Thank you.
because you are really supporting the nursing faculty for organizing such a huge workshop and a very, very important topic. Thank you and congratulations.
Yes,
Thank you,
ma'am.
ma'am.
Yes, ma'am.
Thank you for joining this conference as a chief guest.
My pleasure.
Our participants will be deriving a lot of information from your experience.
My pleasure.
Yes, sir. In the early morning, we had 2 sessions, sir. One from Asha Shetty from Bhubaneswar, AIMS. She presented a principle about the partnership, essentiality of the partnership in nursing with the collaboration. So she talked about various means how to collaborate with various other health discipline. That is the need of the hour. She covered very nicely. And the second presenter, Dr. L. Kopi Chandran from AIMS Delhi, he presented about the mixed method of research and enlighten all the qualitative and quantitative aspect, how we can merge in nursing and how each one is complementing each other. So like that, it was eye-opening session for all the researchers, young budding researchers, to go with the research point, how to take up these kind of designs. Yes, sir. And following that, now we are going to continue with the inaugural, sir, within few minutes, sir. Kindly.
So, Dr. Mithumi Chalan, I hope I'm pronouncing your name correctly.
Yeah,
Pardon me for
you are on the dot, ma'am.
Okay. So, so you have really grown very well in terms of all the areas. And I'm really happy that the nursing is taking up. I just wanted to know whether PhD in nursing is started in your university. Yes?
Yes.
Nursing
Yes, ma'am.
also?
We are having PhD nursing, ma'am, with the regulation of the Indian Nursing Council.
Okay.
We have developed, and then many of our faculty, almost 4 doctoral completed PhD faculty we have, and 17 faculty already enrolled, and others are waiting for the eligibility. And even from many other other places also they have completed and registered our university, and they have completed their PhD. And even now we have external candidate, one from even AIMS also has enrolled due to some reason, but she couldn't able to take up. But for the following session, July, she is joining under me. She took some permission. And some other institution within our Chennai also, they impressed and they are coming to take up. And 2 part-time external candidate I have from Venkateshwara. And we have part-time faculty, part-time our own faculty, 17.
Okay.
So almost within 2-3 years, we will have more than 20 doctoral faculty within our college.
Excellent. Excellent.
Yes,
my only, by the time you start, when you start, I can stop. It's just because I have the privilege to talk to Vice Chancellor and you directly. So I thought I can take this opportunity.
Yes,
now you have got a 300-bedded hospital, if I'm not mistaken, you told me.
We have 1,300, more than that.
1,000.
We are extending. Yes, ma'am.
Okay.
We have a medical college within campus.
Now, my request. My request to the Vice Chancellor, to the medical college, you know, you have got a CEO or a medical college medical officer, and to you. My request now will be that the nursing studies which are done, we are doing wonderful studies. We are coming out with wonderful results. But the only thing is that after the studies are done, we forget about them and they are put in the library. May I request, under the leadership of Vice Chancellor and you, Dr. Tanya Mal, because you are the principal and dean, ensure that at least 50% studies are implemented in different wards, you know, in different clinical setting. And once, twice, thrice, 4 times, if the same study is implemented, probably we can bring out a nursing model out of it. Rather than we follow Orem's model, King, Newman, and this and that system model or other theories, let us come out with a model like Tanya Mal, Bimla Kapoor, or you know, whoever. That model is implemented at many places and maybe in different college, schools, hospitals, with the permission and with collaboration of Vice Chancellor and you, so that we come out with our own theories. with our own models. We are
Yes.
tired of using those old models done by the other countries, and we try to modify in our country.
Yes,
So
ma'am. Yes,
my
ma'am.
request to you, you are
Yes.
the dean, and you
Yes.
have the honorable vice chancellor, who seems to be pretty young and assertive, I think. And
Yes, ma'am.
let us take that together.
Yes,
And then, honorable vice chancellor, I would request you that develop a research under the leadership of a principal and dean. You can have a separate research department
Yes, ma'am.
headed by
Yes.
the vice principal, and
Yes, ma'am.
ensure that that research faculty is
Yes.
able to implement the nursing outcomes
Yes.
along with the people who have done study in the clinical area.
Yes.
This will help us in two things. We all
Yes.
are academicians. This will
Yes.
help us in two things. It will reduce the cost of the hospital, because if the models bring the quick recovery in the patient, like
Yes.
oxygen management, like
Yes.
back care,
Yes.
like doing recording, doing postural
Yes.
drainage.
Yes.
I mean, any clinical studies,
Yes. Yes, ma'am.
comfort measures, or colostomy care, ostomy care, anything of that. And if that is able to bring a change in the patient's care and improvement is faster, that can be really documented. And that will bring the cost of the hospital down by saying that the turnover of patient is faster and the
Yes. Yes.
recovery is higher. And then
Yes.
you may become a first institute. I was
Yes,
telling
ma'am.
Gujarat also. Gujarat is going to develop a nursing department,
Yes.
a research department, maybe in the council. You can do it in
Yes.
council also. You have got a good assertive, the registrar. But you can do independent in the university. You are a university. You are an
Yes, ma'am.
institute. You don't have to depend upon the councils or this permission, that permission. You can start with the research cell under the leadership of Muttami Chalan, and see that we are able to implement the clinical research.
Yes, ma'am. Yes,
Thank
ma'am.
you. I just wanted to say these words.
Yes,
Now that
very,
we are
very,
making-
very good suggestion, ma'am. So
Uh-huh.
we also have some good amount of interest in establishing a research department, particularly for nursing. For that only, we are taking up many of the even the outside our management president and vice chancellor all are encouraging to take up the doctoral holder from outside with experienced hand as well. So now recently I recruited one person from Ramachandra. She completed the full time, Dr. Kavita, and I allotted her for take up some initiation in developing the research department within college. And for that, I am also helping her. We are just emerging, ma'am, with your good ideas. And we have additional support from service side. So the integration, since we are more than 300 bedded, we can start. So that is as per INC. So we have started prior to the COVID for the pilot run, for the integration component. Even service side, we have master qualified teachers are there in the service side as an educator. And our nursing superintendent. So initially we have started the pilot, ma'am. But due to COVID, last 2 years, there is some gap. We couldn't able to implement it effectively. But now we have derived procedures and protocols at the hospital level, along with the combination of the service and then the our faculty. So we have a committees and we are functioning, ma'am. And we will take up your good suggestion to develop nursing and try all the research findings which we have grouped, and we can develop a model and then we will implement in our hospital, ma'am. So it is a very good suggestions and we will take up into future implementation, ma'am. Thank you so much, ma'am. With all our higher authorities are for that, they will support us. We will do it, ma'am.
Good morning, madam.
Good morning, sir.
Morning.
Good morning, sir.
Morning.
Morning, sir.
Good morning, sir.
I got a little held up in
Good
traffic.
morning.
Yes, sir. No
Yes.
problem, sir. Thank you, sir.
Listening to the wonderful talk by Dr. Bimla Kapoor about research, I think we
Yes.
should follow her advice.
Yes, sir.
We can
Yes, sir.
start whenever you're ready, madam.
Yes, sir.
Yes, sir.
Ma'am, can we start? Ma'am?
Yeah. I think Dean Medical also have joined, Lama.
Yes, ma'am.
Dean
Yes,
Medical.
ma'am. Yes,
Then
ma'am.
we can start. Yeah.
Morning, madam.
Good morning, sir.
Good morning, sir. I'll start, ma'am.
Yeah.
A warm welcome and very good morning to one and all present here at this August gathering for the inauguration of 8th National Nursing Virtual Conference. The simple truth is that God doesn't need to be invited into an event to show up. I believe God likes it when we invite His presence. To begin this auspicious occasion, may I request all of you to join for the invocation.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you all. A lamp does not speak. It introduces itself through its light. Light symbolizes absence of darkness, grief, and unhappiness. Almighty's divine grace is spread all over the house when you light Kuthuvilakku. I am privileged to invite the honorable dignitaries of the inauguration to light the Kuthuvilakku virtually.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा. शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा. हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्.
Thank you for spreading such a divinity at this auspicious occasion. The secret to success is good leadership. And good leadership is all about making the lives of your team members or workers better. I am delighted to welcome the able leader who drives us towards our goals and targets with an affirmative leadership. Now, I invite the Dean of SRM College of Nursing to welcome the gathering. Madam, over to you.
Thank you, Kavita. So good thoughts precede great deeds. Great deeds precede great day. Filled with success, joy, and happiness, I wish you all a great day ahead. A pleasant morning to the dignitaries and to the impressive participants. I thank God Almighty for divine guidance for today's proceedings. Excellence is never an accident. It is a result of high intention, sincere effort, intelligent direction, skillful execution, and vision to see obstacles as an opportunity. Yes, to work towards excellence in nursing practice with high intention and sincere efforts. This 2 days international national 8th national conference aims to explore on the theme of resilience and reinvention in nursing education, practice and research towards excellence in association with the Society for Nursing Practice. On behalf of SRM College of Nursing, I am immensely pleased to offer the welcome note. Leadership is the capacity to translate the vision into reality. A leader takes place where they want to go. A great leader takes people where they don't necessarily want to go, but ought to be. So the quote by Rosalind Carter, a true inspiring leader whose contemporary thoughts and action derives others to do more and become more. We are privileged to extend our heartfelt welcome to our Honorable Vice Chancellor, SRM IST. Sir, we express our sincere gratitude for accepting our invitation and gracing this occasion to preside over the 8th National Conference virtually. We welcome you, sir. John Maxwell, leadership, he defined leadership is not about titles, positions, or flow of charts. It is about one life influencing another. He further adds, leaders must be close enough to relate to others, but far enough to ahead to motivate them. We express our sincere indebtedness to our Honorable Pro Vice Chancellor, Medical and Health Sciences, SRM IST, highly influential administrator, closely relates with his associates, and far enough ahead to motivate his team, for the continual encouragement, constant support, and reinforcement in all the SRM College of Nursing endeavors. We welcome you, sir, for the inaugural address. True leaders always practice 3 R's: respect for self, respect for others, and responsible for their own action. These words are more suitable for our renowned Dean, SRM Medical College and Hospitals, remains as a strong motivator by expressing his trust and confidence among his team members. Sir, we are welcoming you for the felicitation address of the 8th National Conference. A genuine leader is not a searcher for consensus, but a molder of consensus. By Martin Luther King, humility is a great quality of leadership which derives respect. That is our distinguished chief guest, Dr. Bimala Kapoor, Professor and former Director, School of Health Sciences, Nursing Program Coordinator, IGNO. He is a genuine leader, molder of consensus, and admirable and adorable teacher, inspiring many of the lives of the nursing students and nurses with a great quality of humility. On behalf of SRM College of Nursing, I am gladdened to welcome you, ma'am, for today's chief guest address and release of virtual souvenir. Thank you, ma'am. On behalf of SRM College of Nursing, I am delighted to welcome Mr. Rudrabanu Sadapti, CEO of Society for Nursing Practice, BioLink. We are grateful to you, sir, for accepting our invitation and gracing the occasion to deliver a special address in this occasion. So I felt greatly honored to welcome the distinguished experts and the resource persons who will be sharing the expertise for the 2 days national virtual conference. I am extremely obliged to welcome our own associates, the nursing community, dear delegates, dear nursing students from various nursing colleges and staff nurses from hospitals, including our SRM hospital. It gives me an immense pleasure to welcome the respective deans of other departments like OT, PT, and all other departments who were directly, indirectly helped with us. I'm welcoming each and every one of you. I take this opportunity to welcome our own aspirants, the faculty members and students of College of Nursing, who had put their sincere efforts for an admirable organization to conduct of this virtual conference. On behalf of SRM College of Nursing, I convey our deepest appreciation and offer our most grateful welcome to all of you gathered here. Thank you all for patient listening. Thank you.
Thank you, madam, for your graceful and captivating welcome note. We assure you, madam, we will face obstacles anymore and change them as our stepping stone in our future endeavors. Great leaders never set out to be a leader. They set out to make a difference. It's never about the role. It's always about the goal. Now, I request our Honorable Vice Chancellor, SRM Institute of Science and Technology, to deliver the presidential address. Sir, please.
Thank you, ma'am. A warm welcome and good morning to distinguished chief guest, Dr. Bimala Kapoor, respected Pro Vice Chancellor Medical, respected Dean Medical, Dean Nursing, and all others present here. I am very happy to be part of the inaugural session of the 8th National Conference on Resilience and Reinvention in Nursing Education, Practice, and Research towards Excellence. Being a nurse is highly demanding, but genuinely fulfilling job with a chance to touch many people's lives. This hasn't been highlighted better than during the COVID-19 pandemic. When the whole world is stricken by fear and uncertainty, with many under lockdown, nurses were actively in the front line, assisting patients and physicians. As a nursing profession requires the core of what makes us human, paying attention, being empathetic and caring, will never be replaced by technology. However, technological innovations can relieve nurses of the burden of many monotonous and repetitive tasks, especially in a pandemic where time is of essence. I would like to highlight some of the promising technologies that are to be used by nurses. During the pandemic time, you might have seen many educational institutions and companies coming out with robots for medication management, disinfection, carrying medical devices, lifting bedridden patients, navigating and greeting patients and relatives in the hospital are all tasks that robots could support. We also have robo companions, which keep company to, or which gives company to people feeling lonely or help treat mental health issues.
Yes.
The other area is the remote communication or the telemedicine. The COVID-19 pandemic boosted telemedicine into mainstream practice. It's an effective tool to reduce unnecessary hospital visits, reduce risks of cross-infections, and still provide clinic care. And during the pandemic, I have seen many doctors using WhatsApp video calls to address their patients' issues. Leveraging the same technology is telehealth nursing care, which is employed in both emergency and non-emergency situations. Another area where we can think of technology is how we draw blood samples. More often than not, the process of taking blood is a pain point for both patients and nurses. It's known that patients usually dislike needles, but on the nurse's side, they often have to endure long and miserable moments before finding the appropriate vein. This adds to patients' uncomfortable experience. And here, robots and vein scanners can help quicken the process. So you should also use vein scanners. Then the next one is about portable diagnostics. The appearance of pocket-sized, user-friendly and portable diagnostic devices make it easier and faster to nurses to care of patient. Measuring health parameters and vital signs will be reduced to minutes, and massive oversized machines for an ultrasound, ECG or laboratory testing will become things of the past. Another area which is commonly used in all programs of study is artificial intelligence. Artificial intelligence has the potential to highly optimize processes in hospitals and even eliminate the problematic alarm fatigue. By enhancing efficiency, AI will immensely benefit nurses. Medical education, surgery, rehabilitation medicine, psychiatry, and psychology could all benefit from virtual reality. The other one is called augmented reality, and now both of them are called as mixed reality. And the field of nursing care could reap the fruits of technology too. We also talk about VR, AR, and mixed reality in preparing our lessons too. Managing one's own medications can receive a boost from recent tech such as chatbots, companion robo, and digital pills. You might have seen the use of chatbots during the COVID-19 pandemic. Several dedicated chatbots were launched for remote risk assessment and are still being used. But these chatbots can further ease the burden on nurses by supplementing some of their tasks. For example, electronic personal nurse can remind patients to take their pills, which might be a handy feature for older patients. Both nursing jobs and robots will stay. However, if nurses don't start understanding and embracing new technologies as a part of their work, the profession and the best interest of the patients will suffer.
Yes.
Here at SRM, the nursing students do get enriched clinical learning experience and practice at SRM Medical College Hospital. Adequate learning resources to compete with the existing ongoing technological advancement in nursing education and practice are provided. Counseling and motivational sessions are being conducted to de-stress and re-energize the healthcare team members. I believe that this conference will be able to bring out diverse ideas into a lively and meaningful academic discourse. I wish the conference a grand success. Thank you.
Thank you, sir. Thank you, sir. You have covered, sir. So you have covered almost entire 2 days sessions in an elaborate way. So in a narrative way we have covered, and we will extend and we will take all the possibilities which it is available. And we are fortunate to have the engineering discipline within, and we too also with medical. So we are fortunate, all my faculty and students, and we will utilize to the core and will bring out the best from the students, sir. Thank you, sir.
Thank you, sir, for your thought-provoking and empathetic presidential note. We assure you, sir, that we will imbibe your words in utilizing varied technological advancements in our essential nursing services, nursing education, and nursing research. Leadership is the capacity to translate vision into reality. I am ineffably indebted to welcome our respectable Pro Vice Chancellor, Medical and Health Sciences, to deliver the inaugural address. Sir, please.
Sir, unmute.
Sir, can you kindly unmute, sir?
Good morning to everybody.
Good
Good morning, sir.
Thank you for inviting me to inaugurate this important conference. Respected Chief Guest, Dr. Bimla Kapoor, respected Vice Chancellor, Dr. Muthamil Shelvan, Dean Nursing College, other dignitaries on the dais, and delegates, colleagues from the Nursing College, and my dear friends from the medical and health sciences who are attending this program. It's indeed another red letter day for the College of Nursing, SRM College of Nursing, because they are embarking on a new pathway, if I can say so, involving not only nursing practice and research towards excellence. All along, we've been talking about the important role that the nursing profession plays in the lives of human beings who unfortunately are stricken by illness. But converting that into a learning experience and also to innovate and do some research in how we can do things better is even taking it a step higher. And I must compliment the efforts of the College of Nursing under the able leadership of Dr. Tanya Mal to take this pathway, because I feel that this college has got the potential to leap, as our university motto goes, and take us forward even in the field of research. Now, we just heard a wonderful speech by our leader, the Vice Chancellor, on how technology is going to transform the medical and nursing and allied health sciences in the near future. It's already here, but they will only complement what we are doing right now. I doubt whether it will replace the human behavior and the attitude and the care which a nurse can provide. Going back to the pandemic, which is hopefully on the wane now, we had a very tough time during the second phase. At that point of time, it was the courage, dedication to duty, and the selfless service which the nurses performed. I would like you to imagine yourself as a patient at that time, unfortunately stricken by this disease for which there is no specific cure, and whether you would be like to be served by a robot or by a human being, even though the human beings are different, but looking at a fellow human being caring for you itself is 50% of cure. That is why even in a country like UK, the Prime Minister of the nation, when he was stricken with COVID and survived and came out, he gave his full praise to the two nurses who took care of him during his period of crisis. So as the traditional values of nursing are all well known and all of you have listened to that many times, those cannot be replaced. They can only be augmented, and we can only make it better and better and make it little more patient oriented and intensive. And that is the reason we are here today to debate on these aspects in this conference. Research can add value to our service, and we should try to imbibe, adapt, and practice as soon as possible, because nowadays the emphasis is on bench to bedside research. It's not just theoretical research that is going to help us. The humanity at large wants better and better quality of life. And that can be provided if we imbibe these qualities. On part of the nursing college, I must give a few compliments to what they have done in the past year in involving their nursing students, especially in the third and fourth and final year students, in integrating them into the hospital for learning as well as performing practicals with the hospital staff. That's a very nice step, and I think it's a successful step in the right direction.
Thank you, sir.
And
Thank you, sir.
thanks to the understanding between the hospital staff as well as the nursing faculty, we've been able to make progress on that.
Yes.
Also, they have tried to specialize into areas which were not available in our campus, such as operating room nursing certificate course, critical care, emergency disaster management, etc. These are all value additions. Along with that, the trained nurses get an opportunity to specialize and provide expert care using the latest technological innovations. All in all, it's a win-win situation if taken in the right spirit. And I think this conference, especially with the guidance and experience which Dr. Bimala Kapoor provides, along with the other key personnel in the faculty, will add a lot of value to our nursing quality. And I wish the conference all success. I have great pleasure in inaugurating the conference, and thank the organizing team under the able leadership of Dr. Tanya Mal for giving me this opportunity. At SRM, we don't stop, we continue. And SRM should progress in the field of research much more aggressively, and that is the focus of the medical health sciences faculty also. Thank you very much and all the best.
Thank you, sir. Thank you for your very good inspirational motivation for all of us. We will extend our full cooperation to the extent to the service and for the research development as well, to practice the evidence-based into the bedside. So that is the important core we too also have. Thank you so much, sir, for encouraging us from top level, from the Vice Chancellor and Pro-VC Medical and our President, management, everyone, they are supporting to improve the quality. We are sure to the maximum possible we will develop within our SRM campus, sir.
Thank you.
And here almost around, we have 724 delegates for this conference registered so far, and 400 delegates outside SRM, and 320 from inside we have. And the registrants are various from Ethiopia, Bahrain, Saudi Arabia, even international participants are also, they have sent a research abstract, and they also registered under here. So we are fortunate, and the Society for Nursing Practice, they are extending help, and this is the second virtual conference. Last year we had one with the same society, and they are interested in taking up MOE with us and to lead a lot many laurels, particularly for the research and publications. They are extending their help. Really, we are very grateful, sir, and we are expecting those people in future also, they will have an association with us, sir. Thank you, sir.
Thank you, sir, for such a thought-provoking and inspirational speech. To be inspired is great. To be an inspiration is an honor. I take this opportunity with immense pleasure to introduce the Honorable Chief Guest, Dr. Bimala Kapoor, Professor and former Director, School of Health Sciences, Nursing Program Director, Indira Gandhi National Open University. I am extremely delighted to brief preview of Madam's commendable achievements. Madam was the first President of Nursing Council, Delhi, and first National Vice President of Trained Nurses Association of India. Madam holds the credit of being the first Nursing Director of School of Health Sciences, IGNOU. Madam has headed as chairperson of National Nursing and Midwifery Commission in the year 2020. She beholds the pride of first PhD awardee of Indira Gandhi National Open University. Madam do hold the credit of being the first Indian author to publish textbook on psychiatric nursing for graduate nursing students. Madam has launched PhD program in nursing through distance mode IGNU. Madam has imbibed the best practices for in-service nurses who opt for learning through distance education. Without further ado, I welcome our distinguished chief guest, Dr. Bimla Kapoor, to deliberate the chief guest address. Madam, over to you. Kindly unmute.
Allowing? Okay.
Yes.
Yes.
Thanks. I read the host is not allowing. Okay. Thank you so much, dear Professor Muthami Shelvan. I corrected, I saw Chelvan, but then I heard the Dean talking as Shelvan, so I corrected myself. Nice seeing all of the dignitaries, Pro Vice Chancellor, the Dean of the Medical Education and Medical field. Also, we have with us the CEO of Society for Nursing Practice, Dean Shirley. We have with us Dr. Tanya Mal with her leadership, the Vice Principal and faculty, the nursing faculty of SRMR College of Nursing and Institute, nurses within the country and abroad who are connected for this 2 days international conference, and very, very dear students. It's definitely a pleasure, immense pleasure to be amongst you today to talk and to share my feelings on embracing change and transformation, resilience, and reinvention in nursing education. There are a lot of things which you are going to achieve in these 2 days. You want to talk about the change which is occurring due to various reasons. And I think the Dean Medical and also the Vice Chancellors has given some of the points to for us to dwell on, that what are the changes which are there and what transformation is being expected. Resilience, nurses are the best people, and reinvention in nursing education through research, through practice, towards the excellence of patient care. All these adjectives, what we are using is remember towards one person. Only one person, we all exist, and that is a patient. So we need to bring the excellence of care through all these researches, through all this medical technology, through all these IT technology, that we improve the patient care, but providing them compassionate and excellent nursing care. And that is going to be essence of your research, innovation, and all the discussions. I hope so. Now, time and situation in nursing has taught the nursing professionals to really embrace the changes. Whether it is crisis, whether it is war, whether it is COVID or any, for God forbids, any other pandemic which you've had, or hope we don't get it, the nurses are the one who really need to work 24/7 hours with whatever discussion they have with the medical fraternity. Because medical fraternity is not there with the patient 24/7 hours. They are there on seeing that a right kind of treatment is prescribed. Just to share with all the dignitaries, maybe you are not aware of, Harmon Henderson had described there are 14 skills the nurse is supposed to practice. Out of the 14 skills, and I believe thoroughly in it, out of 14 skills, there is only one skill in which the nurse works collaboratively with the doctors, where the doctors are able to prescribe the medications and the nurse carries on intelligently with right decision the care which she gives or he gives to the patient. And that is the collaborative function the nurse and doctor have. And that makes them team. All the other functions, 13 functions or the duties, the nurse carries on independently. And I'm sure each nurse knows about this, and I'm sure you can put it up in some of the wards where our doctors also wants to get educated, and let them know this, because a team is together and you need to learn together. Look at the resiliency in nursing. See, the methods of teaching have changed, which was inevitable because there has to be research, there has to be evidence-based practice. The evidence-based practice was being implemented way back in 1960s also. But somehow that has not been limelighted by our nursing professional, and which I was talking before the inaugural session with the Vice Chancellor, the faculty members, the students had to really be resilient to the changes which came up due to this COVID. And it has really taught us that how as a team, you need to be more resilient, you need to be more cooperative, you need to be more understanding. Let's take an example of embracing this change, transformation, and resilience, which is adopted by the nursing nursing fraternity, the clinical nursing personnel. Look at the PPE they wore for 6 to 8 hours without even using the washroom or going for any biological needs, and were not able to eat or take water. Look at the trauma they had by not visiting their family members. Look at the stress they had by seeing the patients dying, the young patients dying, and by controlling all their emotions. After all, nurses are human beings. They cannot be void of emotions. You can control your emotions, and you control your emotions seeing the young people dying one after the other, giving the death pack and moving to the other patient to give the care. Now, this is what is a resilience, Look at the stigma which the nurses had to go through by not able to visit home or the neighborhood because I work in the COVID hospital or a COVID ward. The stress which they have had, the lack of the facilities which they were having, the PPEs were not available, the other masks were not available, oxygen was not available to the patients. Now, all this really had caused a lot of stress, but they came out of it and went and looked after the patients, without even expressing once that how stressed they were. We did feel. That is why many of the nurses went into PTSD, depression. They went into a lot of mental health problems. And we really got into it by opening ourselves available to our nursing colleagues, call us anytime. Look at the new normalcy the students had to face. I think a good example was given by your medical dean, that the blended approach of learning was adopted. We could not waste their year. So we went into online, plus we put them in the clinical area when they were not prepared clinically. See, they were young, they need supervision, but they didn't have supervisors because all the supervisors were busy in taking care of the patients. So they learned under stress, they learned on their own, but then they also had to complete their syllabus, for which they sat in the evenings and nights with their teachers, with their nurse educators, with the principals, planning how the course is to be completed, because you cannot give them the degree without completion of the course by replacing them in the clinical area when they were required, when they were not even prepared. There was quite the apprehension amongst the teachers, amongst the principal, that hope nothing goes wrong because our students are still not registered. So that was a challenge, dear Dean Medical, which the nurses were going through without even expressing one. Then imagine the lecture. We brought in pre-recorded lectures from the clinical nurses so that they could learn certain clinical areas. The own hands with the clinical, if posted in the clinical, could not be practiced. So it was simulation. And we had been talking about high simulators, high fidelity simulators, mid fidelity simulators that we should get into nursing so that we are able to provide a simulation-based learning if they are not able to go to clinical. And I'm sure by now you may be having a high fidelity simulators and mid-fidelity simulators, and there are nursing scenarios which can be used and practiced. And I hope the nurses are being allowed to use the high fidelity and mid-fidelity simulators, because sometimes the high fidelity and mid-fidelity simulators are there, but they are locked up and they are only used by the medical professionals, but I think the nursing professional would need more. So this is what The blended learning was, excuse me, please. And the teachers had to go through lot of stress. The transformation which the teachers had to make and take, and also the students had to go through, was causing immense pressure. And I think they bore it very well. Because we know the nursing is providing promotive, preventive, therapeutic, and rehabilitative level of a care. So for that, there has to be evidence-based care. There has to be research. Lot of clinical research is required, which the nurses are doing. But excuse me, this is my post-COVID cough, and I hope you will bear with me. I do take the words of our Dean Medical, where he says that the research implementation is very, very important, and the College of Nursing is doing a wonderful job. But my request is that there has to be dedicated hours allocated to the faculty and also to the people who have done research, that the medical faculty supports them, that please implement the research which you have done and let us see what improvement in the patient care comes. And that has to be done collaboratively. The shift to working under stress due to shortage of nursing human resource had been tremendous, and it had taught a power of communication, communicating from top to bottom, from sideways. So, vertical and horizontal communication became very, very open, and people understood the value of nursing professionals' comments, participating in policy, getting the information, sharing the information with patients, with the relatives, with the team members, had been really tremendous. We also need to have more of a resilient and empathetic nursing leadership. Why I say this? Because the nursing leadership hardly gets time to go and have the, inter-country or interstate exchange programs. We do talk about all the best practices of foreign countries, but we never allow our nursing people on the expenditure of institute to send them so that they also get transformed and share your own kind of practices, what you are doing under stress. So I hope this will give you an opportunity to think about it, how the best practices can be brought in and can be shared, our best practices. If my Indian nurses are able to do wonderfully well abroad, why are not they being respected the same way in our country? Why are they not being remunerated in the same way in our country? Is a big question which we as policymakers, which you as university and deans of the various departments have to sit and think. Now, I am just taking 2-3 minutes more. We also need to see that the empathetic leadership is not just saying, I understand you. No, we don't understand. When we say we understand, we really need to get down to their feeling. We really need to know the stress. A person calling me at 10:30 at night and says, I need to go and meet my 3-month-old child. I cannot go. She's crying on the phone when she's talking to me. How do I go, ma'am, So we had to sit down, talk, and work it out, There has been female doctors also who went through the same stresses, and we really need to see that how we improve their morale. Because if the morale is improved, the productivity and patient care will be more, much better than the nurse was able to provide. Now, keeping a nurse workforce at the safe level, I just cannot imagine the nurse is not having the PPE or using the PPE to save the cost of it for 6 to 8 hours continuously because they could not change it, how safe they were. Also de-stress them, give them those opportunities, and the resilience is important because once they de-stress, they will have better resilience. Because the nursing profession is based on agility, decision-making, quick decision-making to save the life of the patient. By the time you call the doctor, page the doctor, the nurses have done the work to save the patients, and you know that. And it depends upon how well you have prepared your nurses. Now, the dissatisfaction at the work amongst the nurses is there because it does affect on the professional quality of life. I'm talking of professional quality of life. I'm not talking of personal quality of life. The professional quality of life, especially when there is compassionate fatigue. We have never thought about the emotions, the compassionate. You are a nurse, you should be able to know all these. But I'm also Bimla Kapoor. I feel sad. I feel bad, when I find a young boy of 18 years dying in front of me because of we could not save him because of various reasons, because of his comorbidity, because of any other problem. So that compassionate fatigue is never taken care of. That needs to be taken care of. The burnout. A nurse working in the critical care unit for so many days needs a change. Give her a change. Not that she's not capable, but that burnout is there. Secondary traumas are there, So I think the building nurses' resilience will bring not only the importance in giving the care to the patients and to the clients, but it will also enhance to the quality of the work which nurse is able to give, Build self-esteem of the nurse by reminding her, you are the best. You are the best. If you were not there, this couldn't have happened, Start complimenting the nurse. I remember, way back in 1969, when I was a young teacher in RAK College of Nursing, the Colonel Das would come and say me, Madam Bimla, please come. Where are your students? We'll take the round together. He will not move from the duty room unless RAK College of Nursing student and Bimla is there for the rounds, and then we will have a discussion open, the doctors and nurses. That was the status we shared. There was not like godlike feeling in the doctors, but lately, past 4 decades, there has been a lot of godlike feeling amongst the doctors, which I think they need to understand, and more in the private sector. So we really need to come back to a level that we work as a team towards one person only, and that is a patient. And that we are forgetting sometimes, and we need to remind ourselves and give allow the nurse to practice so that she maintains her self-respect. Because remember, if a medical professional is saying something not very pleasant in front of the patient to a nurse, not only disrespects the nurse, but also the doctor loses that respect. I'm sure the senior doctors like Dean sitting over here would understand what a wonderful team we used to have, and what is that, but why that team we are not able to have now. Maintain a supportive social network for the nursing colleagues. If it occurs, you were so good when you were not married. What has happened to you after marriage? No, there is a change. There is responsibility. As a nursing leader, I need to understand, empathize, and see that how can I facilitate. Try to be flexible. If possible, we need to change. We need to change according to the situation. Look at the technological changes which is described by the Vice Chancellor, and how much it is going to help. I agree with you, Honorable Vice Chancellor, but I think the Dean Medical would stand with me when I say all these technological changes need to be there. But a nurses and doctors' human touch is always prime. So the technological changes like providing mental well-being and mental health, when a nurse goes and speaks, when a doctor holds the hand of the patient, I think they make immense difference when there is a human touch. But yes, checking the blood pressure, when I go and check the pulse, I don't only check the pulse. I look at the patient and I say, you look pleasant today. You look worried today. So those are the things which also technology may not be able to replace. Develop positive thinking and optimism so the resilience is better, because this promotes resilience. Pay attention. Tell the nurses to pay attention to your own needs also, You're a human being. And same is for the medical fraternity, because, a lot of studies have been done. I will not talk about the implementation of research because I have talked pre-inaugural address to our Honorable Vice Chancellor and to the Dean, and I'm sure the Medical Dean has understood my point of view very well. With these few words, I'm confident that there will be very productive deliberations, because your experts are wonderful, your team is wonderful under the leadership of the Dean Nursing, and you have a support from your Vice Chancellor, from your Dean Medical, and also the other professionals. So I think the 2 days conference is going to be wonderful and successful. I wish you all the best and success, the Dr. Tanya Mal, under your leadership, and also the support from your university, excellent support you are getting from your university and faculty, and pray that we come out with more of the practical outcomes to improve the patient care. God bless you all. Wish you all the best. Thank you so much.
Thank you so much. It's such a elaborative and nice sharing of all experiences you gain. So really that it is a research component. So we need to have touch with you, ma'am, in future. And we need to develop a separate research forum for the nursing. And we are emerging now. We need your help and support. I will keep in touch with you, ma'am, to make it possible. Yes, ma'am, with all the support of our Vice Chancellor, Pro Vice Chancellor, Medical and Health Science, Dean Medical, all are supportive. And with all's help, we will grow, ma'am. Definitely, ma'am. Thank you so much.
Thank you, madam, for your astonishing and exceptional speech on the theme of this conference. We assure you, madam, we will implement and disseminate the evidences generated through the nursing research in our best practices. Today's moments are tomorrow's memories. Memories are the best souvenirs. Souvenirs of your past are evidence to prove, for it was all a dream. Here we are to release the e-souvenir of this conference through virtual mode. I heartily welcome our adorable and amicable chief guest of this session, Dr. Bimla Kapoor, to release the souvenir through virtual mode. Here we go. The e-souvenir of 8th National Nursing Virtual Conference is unfolded by the distinguished chief guest, Dr. Bimla Kapoor, in the presence of eminent and honorable dignitaries of this session, the Vice Chancellor, the Pro Vice Chancellor, and the Dean of Medical and Health Sciences, the Dean of SRM College of Nursing, and the CEO of Society for Nursing Practices. Now, I solemnly request our respectable Vice Chancellor and Pro Vice Chancellor to receive the souvenir. I take this opportunity to extend my earnest gratitude to the Vice Chancellor and the Pro Vice Chancellor for making themselves available to this function in the midst of their busy schedule in making this event a memorable ceremony. Thank you, sir. Thank you, sir. Memories without a picture are like life without felicitation. Many see a job well done, but a few come forward with a word of appreciation. I take this opportunity with great privilege to invite our respectable Dean Medical and Health Sciences to felicitate this august gathering. Sir, please.
Thank you. Respected Vice Chancellor, Honorable Pro Vice Chancellor, the Chief Guest of the Day, Dr. Bimla Kapoor, Madam Tanya Mal, the Dean of Nursing College, Mr. Rudrabalu Satapathy, and the participants and the faculties. Good morning, all of you. At the outset, I thank the organizing team led by Madam Tanya Mal for inviting me to participate in the wonderful program. I have to congratulate the entire team for organizing such a wonderful conference. The title itself is very much inviting, and it is the need of the hour. The title goes like this: Resilience and Reinvention in Nursing Education, Practice and Research towards Excellence. Excellence is the ultimate goal for anybody's life. And I know that the College of Nursing is doing a wonderful job. I keep following the College of Nursing for the past several years. Continuously, they are doing excellent job as far as the educational programs are concerned. And they are all, many of them also involved in most of them registered as a PhD scholars, and many of them doing wonderful way of doing research also. At this juncture, the conference focused on the inventions, innovation and research is most needed. Our campus is a multidisciplinary campus, high potential for research and orientation. And we are very proud to have such a big campus where we are able to do a lot of work. More or so, the need of the hour is the medical research. And nurses, they form part of the healthcare delivery system. They are the forerunner. I would say they are the backbones. The healthcare delivery is transformed into a total change in the digital form, where so many medical devices have come to operational. As our Vice Chancellor started telling about how the integrated medicine and with the devices, the technology is going to help the healthcare, and where the nurses' potential is most important. And they should not lag behind. As our chief guest said, our nurses are doing wonderfully well outside the country. Why not they are not doing very well here? Yes, they need encouragement, motivation, all these things. Definitely, they should not be sidelined. So far, what was happening is their work is more towards the patient. And he used to tell they are the backbone of the hospital. They are the first to receive the patient, and they are the person where the patients are seeing last when they leave the hospital. So their orientation towards the health services, when coming to the point of research, there is a lag behind. Maybe we have to do more motivation and more teaching, and then they will enter into the research field also. The current way of doing this is evidence-based practice. So unless we educate and transform into their potential outcome from these nurses, they will not perform very well, because the technology is very fast, especially in the medical field. They have to cope up with the excellent development, especially medical devices and all. Only problem is the current the present scenario needs lot of documentation. Nurses enters into documentation, and nurses entering into these services, they need very little time for other extra avenue for research and potential to open up. So that is the way we have to, as our chief guest said, they should allocate time. They should be given the teaching separately. We have to find a separate team that will work for this entertaining areas. At this juncture, the College of Nursing has organized such a wonderful program, inviting so many people and identified so many areas of interest to discuss. Definitely is going to help the entire participant. I'm also have to congratulate the team for organizing the program, and I have to congratulate because they have there are participants. So many participants have registered, and they are participating in this program. That shows how it has been organized, the interest people showing about this one. I hope this is going to be a very useful program for the entire nursing faculty itself. So once again, I congratulate the entire team for organizing this program, and I have to thank them for inviting me to participate.
Thank you.
And I assure the chief guest, madam, that we interact very well with the nursing college, and the integrated nursing is going on. Definitely what you perceive will be happening in our campus. Thank you, madam. Thank you.
Thank you
Thank
so
you, sir.
much. I'm so
Thank you,
happy.
sir.
Thank you.
Thank you, sir, for your astounding and captivating note of appreciation. Unity is strength. When there is teamwork and collaboration, wonderful things can be achieved. Now, with much honor, I humbly invite Mr. Rudrabanu Sathapthi, CEO of Society for Nursing Practice, to deliver the special address. Sir, over to you.
Very good morning, everyone. Chairman and Founder Chancellor of the SRM University, Dr. T.R. Parivinder, sir, most respected Honorable Member of Parliament of Republic of India, as well as the Founder Chancellor of this esteemed university, Revered Vice Chancellor, Dr. Muthupichi Selvam, sir, my respected Pro Vice Chancellor, sir, Lieutenant Colonel Dr. A. Ravi Kumar, sir, Honorable esteemed Dean, Revered Chief Guest, Dr. Bimala Kapoor, Madam, Dr. Tanya Mal, ma'am, my most respected Dean, School of Nursing, and Dr. A. Sundaram, sir, everyone, all the esteemed keynote speakers, plenary speakers, experts, delegates, and my beloved students. Thank you very much for being a part of this esteemed conference and this epoch-making conference. Today, when we see the sun shining over this beautiful campus of SRM University on this sunny day, we think of one thing, the way we started our collaboration with SRM University. And at this moment today, when I got this opportunity to speak on behalf of these two esteemed and renowned organizations of Asia, SRM University as well as Society for Nursing Practices, I have a mixed feelings, a mixed emotion. Well, I have been allocated with only 3 minutes to speak, but I have a mixed feelings of 3 emotions to share with you. I feel obliged, I feel privileged, and I do feel emotional. I'll elaborate it. Maybe why. I feel obliged to represent the community that has battled for us, whether it's pandemic, COVID-19, or it may be of World War I or World War II. The community that holds our hand when we land to the soil and take birth. And the same community that tries to hold our breath when we breathe for the last time, when we die. The community that has stood like pillar, like warrior, to save us from the pain and suffering we have been through. Today, we live in a world of uncertainty between forlorn hopes and frantic dreams. The world is still healing. The globe is diseased. And our nurses are fighting for us. I feel mobilized to address this community that has left no stones unturned to save humanity. I again feel mobilized to address the community that always speaks about service to mankind is service to God, thus resembling the thought process of Bhagavad Gita and golden words of Sri Krishna. Sarve bhavantu sukhina, sarve shantu niramaya, sarve bhadrani pashyantu ma kaschita kavavave. Now let me come to the point of feeling privileged. I do feel privileged to represent SRM University, the finest university that has brought academic revolution in southern part of country and stood for bringing scientific and academic forum that would definitely bring changes in upcoming days of Asia with international standard of education. I do feel privileged again to represent our own Society for Nursing Practices, a unit of Technoarid Group. Today, Technoarid Group is no more a conglomeration of only association. Society for Nursing Practices is no more a mere association. Today, we are a team, a conglomeration of more than 100 universities, 10,000 professional members, and more than 25,000 student members all across the globe connected with us. I heartfully thank all the universities, including SRM universities and our partners located all across the nook and corner of the globe for their immense trust and faith and belief on us to give us the privilege to serve the nursing community. Technoarid Group that governs Society for Nursing Practices is a conglomeration of more than 21 companies today. And we have scientific associations in field of nursing, Society for Nursing Practices. We do have associations in cardiology and diabetology and renal research, International Society of Renal Research, that is organizing our next conference at SRM University on 23rd and 24th of April. That is Cardiometabolic Congress under the leadership of Honorable Pro Vice Chancellor and the Dean of, and as well as Dr. Leela, the organizing secretary of the conference. We are repeatedly connected with the university, not only SRM, we are trying to push Indian universities among the top 100 universities of globe. So how is it being possible? The first and foremost thing is capacity building. We look at the theme of the conference is embracing change and transformation. When we talk about entrepreneurship, it speaks about transformation. We as entrepreneurs, we need to look into the problems, find the solution behind it, and bring the transformation. So today we feel the biggest challenge is that we are not globalizing our innovation. And with this COVID pandemic, according to our survey, we found out that India is the 6th largest scientific article contributor to world repositories. Why can't we beat other 5 countries? And to bring our universities into top 100 universities of globe, the most important thing is capacity building. We have started our venture United Innovators that is rigorously working to build the potential of our young researchers, make them groomed, make them sharpened up, make them more efficient, make them more deliverable towards producing scientific articles and presentations. Now, why we do such conferences? We organize about more than 200 plus international conferences every year. That makes me speak every morning in the welcome address notes almost. But this day is very special for me. Now I'll come to the third aspect. Why do I feel emotional? Well, for that I have to go back to rewind myself to 2007 when I got admission as a student of this SRM University. And we all were addressed by Honorable Vice Chancellor. Then period, he was the Associate Director. And the university showed us the world, me and my colleague, my stakeholder of my organization, as well as Managing Director, Mr. A. Sid Kumar, who holds the Managing Director position of Technoarid Group, as well as Society for Nursing Practices. We both were alumni of SRM University. So the university is the father of Society for Nursing Practices. And the happiness we feel when we get back to our home with our first salary and give it to our parents. Everyone would have done that, all of us who are there. So as an entrepreneur, when we establish this company, and today we come back to our father and mother to SRM University and do this, send the same services to the university, this is absolutely emotional moment for me. And I believe the theme of the conference, when we speak about resilience, reinventions in nursing education practices, research towards excellence, my entire organizations do deal on all these activities, and we focus on few things. Our objectives are bridging scientific community. We believe educational institutions, whether located in developed or developing states, do deserve equal rights. Students, academicians, professionals do deserve equal rights to access available international skills and knowledge. For that, the global scientific knowledge and exposure, what is available, we're trying to pull it back to India and make it available to each and everyone, students and faculties based in the grassroots location of our country. So this is the first objective. So how we fill it up? We went across the country. We met different professors, different head of the institutions. We tried to find out the solutions. Organizing a conference and bringing experts from globe was a challenge. We just asked the university, give us the auditorium, we will arrange the conference. We will take the responsibility of everything. I am glad and I feel proud and privileged to say that hundreds of universities all across India came forward to us with their immense trust and faith on them. And with the reason, by the time I am delivering this address here, we have organized more than 1,000 plus international conferences all across the country. And thus, making India a potential country, and availability of international knowledge and scopes to everyone. The second thing is globalization of ideas and innovations. I believe the innovations and research ideas inculcated in our developing states and developing universities and institutions, as well as developed organizations, should reach beyond the national borders, beyond the campus barriers. So that is possible when our ideas and innovations we speak at forum. We are globalizing our forums so that we are trying to reach everyone. The ideas presented in these conferences would reach everyone all across the globe. And this is being done. And I believe this will pull up investors and this will pull up the funding agencies to our researchers. The third thing is that to create and form a strong integrated virtual community. So community building was our responsibility. So we started building community in nursing, in pharmaceutics, in cancer sciences. International Association of Oncology belongs to us. In engineering, IFERP belongs to us. We have more than 21 plus organizations operating in more than 30 plus countries, and we're trying to deliver the best possible services. We believe this conference will be a productive event, and we have more than 12 international national keynote presentations by brilliant speakers with us. The conference content we have will be definitely informative and will be contributing. I express my hearty gratitude to all the national ambassadors of Society for Nursing Practices, all the faculties, those who have taken painstaking effort to organize this conference, honorable office bearers of the conference, organizing secretary, organizing chairman, everyone, national ambassador, institutional ambassadors, committee members, national, international advisory committee members, and my beloved colleagues of Society for Nursing Practices for their hard work and their dedication towards making this conference a fruitful event. I believe this conference will be a fruitful and will be energizing event. Thank you so much, everyone.
Thank you, sir. Thank you, sir, for graceful and emotional speech and for your undeniable support in making this conference a grand success. No duty is more urgent than that of returning thanks. With deep sense of gratitude, I humbly request the amicable leader, Vice Principal, SRM College of Nursing, to deliver the vote of thanks. Madam, over to you.
A very pleasant good morning to all. Gratitude is a powerful catalyst for happiness. It's a spark that lights a fire of joy in your soul. With this quote, I take the privilege to propose the vote of thanks. We thank the Omnipresent for his divine guidance for the conference proceedings. We are deeply indebted to our management for their impeccable support in organizing such educational forums and being a great source of motivation in our professional endeavors. We express our sincere gratitude to Honorable Vice Chancellor, SRM IST, for his glorifying presence presiding over the inaugural ceremony. Thank you, sir, for your exhilarating presidential address, highlighting technology-driven nursing as well as healthcare. Highly motivating, and you persuaded us to excel. Thank you, sir. Our heartfelt thanks to our distinguished Pro-Vice Chancellor, SRM Medical and Health Sciences, SRM IST, for honoring us with his presence. Sir, your vitalizing inaugural address, recognizing the nursing services, was highly inspiring. Thank you very much, sir. We express our deep sense of gratitude to Professor Dr. Bimla Kapoor, Nursing Program Coordinator, School of Health Sciences, and former Director, School of Health Sciences, IGNOU. Thank you, ma'am, for gracing the inaugural session with your illustrious presence as a chief guest. It is indeed a pleasure to listen to you, ma'am. Your words were insightful. Thank you, ma'am, for the chief guest address. We extend our heartfelt thanks to esteemed Dean Medical, SRM Medical College and Hospital. Sir, your notable presence made us feel honored. Thank you, sir, for your heartwarming felicitation. On behalf of SRM College of Nursing, I thank our most respected Dean, SRM College of Nursing for the constant guidance, directions, and coordination of the conference proceedings, and Madam's admirable leadership in all our endeavors. Thank you, ma'am.
Thank you. Thank you.
We express our sincere thanks to respected Mr. Rudrabhanu Siddharthi, CEO, Society for Nursing Practice, BioLeaks, for their collaboration and association with SRM College of Nursing. Your special address indeed was emotional and heartwarming. We are pleased to know your successful journey as a SRM alumni. Thank you, sir, for your coordination, technical support for the conduct of the conference. We thank the resource persons who had spared their valuable time and are with us to share their expertise. We express our gratitude to the deans, HODs of SRM Medical and Health Sciences who have joined us today. We thank the faculty and staff of SRM Medical and Health Sciences and SRM MCH for their participation. Our heartfelt thanks to the delegates from other states of India, delegates from abroad. We appreciate and value your participation. Thank you all. We thank the delegates from SRM MCH, SRM College of Nursing students for their participation. I thank Society for Nursing Practice for their technical support and coordination. I do thank the organizing committee members, technical support team of SRM College of Nursing, SRM IST for their noteworthy efforts. I thank the AV8s and technical team for their support. Thank you all once again. Thank you for the opportunity.
Thank you. Thank you.
Thank you, madam. I thank you one and all for making this inaugural session a grand success by your presence. Now, I hand over the digital platform to Mrs. Meghala for the next plenary session. Over to you, Mrs. Meghala.
I would like to extend my sincere gratitude on behalf of all representatives of SRM Institute of Science and Technology for this successful inaugural function. We will resume our plenary session now. I would like to invite Dr. P. Abhirami, Professor, Department of OBG, SRM College of Nursing, to introduce our next esteemed speaker. Ma'am, please do the honors.
Happy morning to all. I'm immensely privileged to introduce Dr. J. Jasmine, Professor in Nursing, Mother Teresa Postgraduate and Research Institute of Health Sciences, Government of Puducherry. Madam completed a diploma in nursing from Government General Hospital, Puducherry, post-basic BSc Nursing from College of Nursing, MMC, MSc Nursing from Umayalachi College of Nursing, and PG DHM from Annamalai University, PG Diploma in Counseling from Annamalai University, PhD in Nursing from Vinayaka Mission University, Salem. Madam is having rich practical experience that she started her career as a staff nurse in government sector, and she started her teaching experience from School of Nursing, Government General Hospital, Puducherry, then to Mother Teresa Institute of Health Sciences, Government of Puducherry till now. Totally, Madam is having 33 years of experience. Madam has written chapters for the many books, and Madam published more than 26 papers in a highly reputed journal and 9 in the souvenir proceedings. Madam participated and presented many papers in the national and international conferences, and she was a resource person in many of the national and international conferences. Her significant achievements are many. To list some, Madam received Indira Gandhi Siksha Award for Outstanding Achievements in the field of education by International Institute of Education and Management, and Bharat Vidya Shiramani Award from Indian Solidarity Council, New Delhi, and also she received many awards from many other reputed institutions. May I now call upon the enigmatic personality, Dr. Jasmine Ma'am, Professor in Nursing, Mother Teresa Postgraduate and Research Institute of Health Sciences, Government of Puducherry, to present on Health Informatics and Future of Nursing Education. Madam, please.
Good morning to all. Can you hear my voice?
Yes, ma'am.
Okay, very good morning. First of all, I would like to thank the organizers for the wonderful arrangements. Always we are observing SRM College of Nursing is very much interested in the knowledge, thirst in the knowledge. We are always searching for the knowledge, and it's a very good improvement. And I appreciate Dean Madam Dr. Tanya Mal and others. Even your management also very much supporting for you people. That's also very good. And moreover, more than 450 members are participating in your studies, in your program. That's very much impressive because of your program. Can you able to hear, madam? Can you able to hear?
Yes, ma'am. Yes, ma'am. You can go over it.
Okay. The screen, my face is not coming. That's why I'm asking.
Okay, ma'am.
I don't know what it happened. It's not coming. No problem.
We can see your slides, ma'am. You can go ahead.
Okay, no problem. So actually speaking, I appreciate all the managing members like your VC, Dean Sir, and Dean Medical, CEO, and principals, and the Dean College of Nursing for the wonderful arrangements. And they are very much cooperated in the program. That I have highly appreciable characters. Very difficult task to get the cooperation. So, but here I am observing everyone is very much cooperating and giving the support for the welfare of the nurses. Very good. So now we will, the time is very much minimal. Time was given to you. Me is 11, 16 to 12, but it's already 12. So I am trying to finish up very soon.
Okay, no problem. You and me only prior to lunch, we will finish it up. Jasmine only, no. So I welcome my special welcome for from my side. I thought you will be coming on campus, but however, let it be. So we will talk later. Okay, proceed.
Okay, thank you so much.
With your,
thank you. Okay.
Thank you, Ma. Thank you.
Okay. It's a very innovative and wonderful topic is health informatics and the future of nursing education. The thing behind is actually nurses has to develop knowledge up to date. So when come to the practice, we are going on changing the syllabus, but till now we are getting the new diseases as well as new technologies. So we have to improve in that one. That is the madam has selected a very good topic for this, that I am very much happy on that. So what do you mean by that health informatics? So everyone may be knowing this one because you are studying in the UG, PG and you are handling the mobile, your world is in your hand. Always chatting with WhatsApp, Instagram and Twitter, everything. So you know very much well than us, even though that what significance it got in our education program that we will see today. So small orientation I want to give is the term medical informatics and health informatics have been variously defined. Slide, please. Everyone can see. Next slide, please. That is the thing that we can see is, but understand the term, what we have to means previously that medical informatics has been replaced by the health informatics. Now the attending because it's reflecting widespread concern to define an information agenda for the health services, which recognize the role of a citizen as agents in their own care, as well as the major information handling role for the non-medical healthcare also. Previously, it was meant only for the medical. Now it has been health informatics. All the fields can be which are under the health conditions. We get health program. We can use this one. That is why this term came. It is given by the Biomedical Informatics through American Medical Informatics Association. Can I have the next slide, please? The health informatics is the health informatics concerned with the systemic processing of data, information, knowledge in medicine and healthcare. So the domain covers computational and information aspects of process of and structure applicable to any clinical manager discipline within the health sector, whether on a tele means through some electronic mode basis or not. Health informatics is delivered by the operational health practitioners, academic researchers and educators, scientists and technologists in operational, commercial and academic domains. So what they want to say is it's the data information processing for our knowledge. Okay, next slide, please. Some of the other CDCS, that's the Center for Disease Control and Prevention, offers more comprehensive understanding of health informatics, defining as it's a complete science that concerns the entire why and how the health information technology. Since the health informatics is essentially about using IT for the accomplishment of several healthcare related goals and aims. Previously we have achieved every goal through the manual. Now we can achieve everything by means of information technology. That is the ultimate. Okay, next slide, please. So what are the tools? What are the simple things we can see in this? Tools means what? Tools is the health information tools include not only the computers, but also clinical guidelines, formal medical terminologies, and the information and communication systems. E-health means that broad term, the healthcare practice, which is supported by the electronic process and communication. The term encompasses a range of services that are at the edge of the medicine, healthcare, and information technology. So what are the key elements for the informatics? What are the key elements? Acquisition, storage, communication, manipulation, display. What are these things? Accumulation means what? Acquisition. Acquisition means gaining or getting or obtaining of data from other source. Storage means it's a retention of data in the computer or the electronic system. We are storing everything in an electronic system because to assimilate the data. Next is the communication. Communication means imparting the exchanging of information by e-mode, by an electronic mode. Manipulation means the action of manipulating something in a skillful manner. So many data we will collect and we will give in a simple format. That is the manipulation. Finally, we are doing some analysis. Finally, is the display. Display means it's an electronic device or the visual presentation of the data as an image. In the board, finally, we are concluding and we are giving. Okay. So all these things are some of the basic orientation to the health information. Next, informatics. Next, we'll go to the topics. Okay, next slide, please. Why we want to have this system? Why we want to have a health informatics in this one? Mainly, we can say the intersection of several fields, including computer science, healthcare, and business, to provide needed information anywhere, anytime, to anyone, authorized in prompt, correct, and secure ways. Anyway, anywhere. What it indicates? Anyway, we are getting some information or results immediately. We are passing through it to some mail or any electronic mode. Immediately that the doctor who is there more than kilometers, he can visualize the information what we are sending. That is the thing. Anywhere we can receive the information. The resources, devices, and methods to provide the healthcare services, consumer health informatics, nursing health informatics, organizational health informatics, public health informatics, and medical health informatics. Okay, next slide, please. Health informatics actually we can say is it's a catching up as a field of health and information technology. At its barest, it can be understood as being the area that concern the use of information technology in health. However, the health informatics goes beyond being just this. It consists of the entire IT ecosystem in the healthcare industry, which means the individual healthcare units use IT via a connected system that helps that to coordinate health information via the net. The wider aim of the health informatics is to improve the healthcare quality and efficiency with the use of IT. IT information technology, so many branches and programs we are having, but what is the ultimate aim is, it is to improve the health quality of the patient and efficacy in the use of IT system. Okay, next. What do you mean by informatics? Informatics means what? It's a combination of the terms information and automation, which means automatic information processing. When you are entering 10 data, it will give the mean, median, mode, and graph, everything. So automation will be there. So it saves the money, man, material, everything. The science that combines your domain science, computer science, information science, and cognitive science. Okay, why do we need to study the health informatics? Why, as a nurse, we have to read. Information is doubling every 5 years, if not tripling in quality and quantity. Information is a power. Whenever you know the information, the patient care system, you will be the intellectual and skillful nurse, like entering the data into the computers, processing, segregating the data, you will be excellent. You will be admirable. We need also technological facilities and a creative process in nurses, offering amazing vehicle for patient education, teaching, and learning. It's very much essential nowadays. provides health promotion and prevention in a global scene. Nursing practice will be reevaluated in and will truly be a profession of nurses with our own classification system, bibliographical system, and payment system. Everything we need the technological system to minimize the work. Okay, next slide, please. We will see how the information system came into practice. What are the history of health? Next slide, please. Okay, what is the history of health informatics? Actually speaking, 1977, the first information system conference was held in the United States. Here they have discussed about the nurses adopted computer processing to enhance the client care, education, administration, management, and nursing research. That is why we can say when we are going to the other countries, foreign countries, they are having the format for everything. When the case is admitted, for example, hereditary patient come to the ward, they will go to the tap the computer system. It will say the protocol for the care of the hereditary patient or care process like that. In October 1995, first ANA certification examination in the nursing informatics was given. Next, 1999, a study was formed to identify the international standards for health information and their adaptability for the in the Philippines, referred to as standards of health information in the Philippines. Next, 2003, Master of Science in Health Informatics was proposed to be offered by UP, Manila College of Nursing. Next slide, please. 2006, creation of TIGER. TIGER means Technology Informatics Guiding Educational Reform. It's created to identify the knowledge, information, management, best practice, and effective technology capabilities of nurses. Next, in the 2008, nursing informatics course in the undergraduate curriculum was defined by the Commission of Higher Education's Memorandum Order 5 series of 2008. Next, in the 2009, Mr. Christian and Sambat and Ms. Mia, both nurses and graduates, students, Master of Science in Health Informatics at the University of Philippines, Manila, began drafting the plans to create a nursing informatics organization. Next, in 2010, they began to recruiting other nursing informatics specialists and practitioners to organize a group of latter became as a Philippines nursing informatics. All these things we can say as a history. Next one is common components. This is one more slide I have. This is these are the common components of health informatics. What are the common components, or we can say elements of health informatics? Data, people, system. Data means it describes the entities that are described objectivity without interpretation. Raw data, we will say, we will collect all the information, that's called the data that we put in the computer. Information as a data, however, it's interpreted, organized as or structured. We are putting some organization. Knowledge means as information that has been synthesized so that the interrelationships are identified and formalized. Okay, these are the results to decision that guides practice. Okay, next slide, please. It's a information systems context. There's a community, facility, district, national, international. Community means where we will get the information generally. Information system context, so we will collect the data from the community, that may be a patient community or a family community or wherever. That's ultimately we are monitoring, evaluating, and managing. Facilities means what are the facilities available for the health informations, whether it can be data collection and indicators. So district levels, so national level, international level, all these things, aggregation and analysis we are doing. Okay, next slide, please. Major goals. What are the major goals? Major goals of the health informatics: reducing the various errors in the healthcare, extending the coverage and delivery of healthcare, improving the medication adherence, adverse drug events, support independent living for the elderly, improving improved decision making, wellness and managing chronic conditions, improving efficiencies and reducing the overall cost, supporting the patient empowerment, addressing the limited human resources. Okay, all these things we can give. The big picture, that is what this mean. The big picture means greater influence on health informatics. So what are the influence on health informatics? These are the factors. which has got the greater influence on the informatics. Quality of integrated data, health database, and data for multiple sources, patients, doctors, labs, pharmacists, quality of processed data, qualities of retrieved data, process of stored data. Processed data means what? What do you understand by the processed data? It's a manipulation of the data by means of computer. That is, computer is processing the data. You are entering total data means it will categorize which comes under this biographical data, which comes under the numbers, which comes under the age, which comes under. So it will categorize. That the manipulation of the data by the computer we can say as processed data. Retrieved data means what? What do you understand by the term retrieved data? We are obtaining the data from the database. Okay. Next is stored data. Stored data means which is storing in the computers, that we can say as stored data. Quality of data sensors. Data sensors means what do you understand by the term? It's sensing a physical phenomena. That data which is sensing the physical phenomena. Quality of service, healthcare decision system, networking infrastructure, quality of transmitted data, quality of received data, devices, compressed and processed data, quality of network control data, quality of healthcare decisions, quality of life for the patient, quality of the healthcare service. All these things are some of the aspects which has got the greater influence on the health informatics. Next slide, please. What are the healthcare? So I have given some other slide to share now. This is not the slide actually I sent. So I will tell. Okay, one more slide system is there. I will tell. What are the present healthcare challenges? Present healthcare challenges include bed turnover rates for inpatient care, ICU patient, crowded emergency rooms, high readmission rates, physician shortage, crowded hospital facilities, chronic disease management, elimination of unnecessary visits to physicians, increasing costs with unsatisfactory outcomes. All these things we can say as a challenge. So we are doing maximum work. Some of the newer diseases will come. Now also pandemic came. So we find it very much difficult to manage the shortage of staff. The ward full of COVID patients. General patients getting affected. Again, we are not admitting the general patient. Now all these things we are getting the challenges. So if the technology is advances, we can improve. So what is the reason for evolving the health informatics? What is the reason we want? What the reason means? It's a rapid result of the breakneck speed which concern with the electronic health records. It will have the speed. Healthcare sector growth, the synonym, and then as a result, high at the healthcare provides adapt EHR. Various concepts related to the healthcare, such as meaningful use, have become the part of the health information. Okay. Next, we'll go for the improvements with wireless technologies. What are the improvements we can have in the wireless technologies? In general, can allow the information to be available anywhere and the time anyone which are authorized associate everywhere. We can share. Now we are participating more than 450 candidates from many places. So it's allow us automatically to have the chance. So it's information available anywhere from where I am from Pondicherry to talking to you. Somebody is now morning Delhi, they discuss with us. So anywhere we can make this use of information technology. It's one of the major benefits, and make the delivery healthcare service more efficient, reduce the number of tasks that need to be done by the healthcare professionals. Previous days, we will write all the records, patient admission record, discharge record, patient diet sheets, everything. Now all these things comes in the data entry. In the master sheet, we are entering all those things. It says the total number of patients, total number of diet, total number of investigations, etc. So it reduces the task by the nurses and encourage the patient to take better control on their healthcare needs. When they are seeing this, all this data, results and the lifestyle, they will come to know the actual condition of the patient. They will improve also. Okay, next step, please. Healthcare quality of a service and wireless requirements. So real-time delivery. Why the healthcare quality of a service we need? Real-time delivery, cellular, 3G, 4G reliability, challenge for most wireless networks, wide coverage, cellular 3G, 4G, wireless LANs. LANs means local area networks. LANS means local area networks. Satellites, ad hoc networks, bandwidth, wireless LANs, and 4G networks, location management, cellular 3G, location management where the patient is there, we can recognize. When the rays comes, when the waves comes, we can recognize the patient is in bathroom, patient is in this space. For example, when the patient is going for walking, if they're having smartwatch, it will have the technology that it will monitor the patient pulse rate, heart rate, and where. Nowadays, recently 1 year back, one patient went for walking and he has got the massive heart attack. It's a mobile, the smartphone with the Apple company. So immediately the alarm has been given. They saved the patient. It was a big miracle. When the walking, they are aggressive. And pricing. Pricing means the amount, something offered, payment for something, and the wireless lens. Okay, next slide, please. What are the suitable technology for the healthcare? That you may be knowing. Suitable technology for the healthcare is implanted. That is inside the body. The patient is very much serious. We can implant and a wearable, portable, environmental technology. I told you the watches. It's a watches. What we can say is it will say a smartwatch will say all those health condition. Nowadays, some of the app has come now in that you can recognize the your pulse rate, heart rate, BP, and sugar level also. All these things we can do. Next one is the implanted technology, RFID. RFID means radio frequency identification. RFID means radio frequency identification. That is why I told you wherever though the waves will inform you where you are, what is your pulse rate, how much steps you walk, everything it will inform. Wearable technology, smart shirts, sensor with the sensor designed to wear for extended monitoring of health condition, could be washed, ironed, and charged for use and in future network with the device and people. That is also available. Suitable technology for us. The portable devices such as handheld devices and phones used in the monitoring the recording health conditions. Environmental technologies computing the and communicating close to the patient. Smart home and smartphone also we can say. Next slide, please. Wireless technologies in healthcare. That cellular network, wireless lens, that is the local area network. Sensors, radio frequency identification. That means that it will emit some of the radio frequency waves. By that, we can recognize the patient condition. And Bluetooth and Zigbee, that and all some of the apps for the patient. Patient safety. Satellites, characters, indoor versus outdoor, real-time versus real-time service. Next, coverage of PANs. PAN means a personal area network. WANs means wide area network. And reliability, varying bit rates and level of location awareness. Okay, the level of location awareness is very important. Wherever we go, it will say the location, where the patient is, what he is doing, or what is his health condition. Next is the sensor application. What do you understand by the term sensor application? It is a device with sensing computation and wireless communication capabilities. And it will sense your condition and it will communicate you without any wire. That is why I told smartwatch. Nowadays, they are advising for the geriatric people, smartwatch means alarm emergency number. It will communicate immediately. Next to sensor measures ambient conditions in their surrounding environment and then transform those into signals, which can be processed to determine the conditions of the sensory environment. Where they sense that the environment, they will mention by means of communicating by means of waves. Okay, next is the application. Use in wearable, portable, and environmental implementations, smart shirt, smart house, appliance, and smart watch also we can say, monitoring vital signs. Some of the apps are there that for that we can monitor. Many more applications with the sensor networks. A simple fall, it will inform embedded smart carpet or fell down, heart rate is increasing, that and all it will say. Okay, next is the radio frequency identification. Next slide, please. Radio frequency identification. Okay, mobile monitoring. Okay, mobile monitoring devices. Say implanted, portable, wearable, and surrounding environment. I told you long back, if you're going walking, if you're going for toilet, if you're going for some other place, you can wear device which senses to measure a range of vital signs and other parameters for the patient. You may be somewhere place, your parents will be some other place, but you would come to know their cardiac condition. You can warn them by sleeping also, that heart rate will get increased. They may go for a cardiac shock. You can inform them. They can go and meet the doctor and they can call the emergency services. It's nowadays very much it is usable in many of the places. The devices with intelligence would detect certain conditions by the touch of the user. Intelligence means some of the other conditions. The device with intelligence, like Alexa and other robotic devices, that if you're feeding means it will say the feedback. It will give the dictation. That is a intelligence that we can say as a artificial intelligence. Many of the smaller medical devices can be integrated in the hand-to-hand wearable wireless device, pulse rate, blood pressure, level of alcohol, specific requirement for the vital signs, how to measure and process vital signs like the blood pressure, electrocardiogram, ECG, temperature, oxygen saturations. Everything, each of these requires different types of sensor and a certain part of the human body. That can be in one device that you can wear also. Okay, thank you. Next slide, please. Radio frequency identification that I told you, it's a local tracking of patient healthcare professionals, supplies, equipments, and blood. Where it is there that you can recognize authentication of expensive medications, the storage of information like emergency medical research, and ingestible smart capsules to monitor the condition of the internal organ. That's a GA tracker. They will be the radioactive ingestible, that is swallowing. It's possible it will go inside and it emits some of the risk. That also can be monitored. Further research, we can say, as a requirement of new applications, bio compatibility, side effects, long-term use, cost benefits of RFD. That's a radio frequency identification deployment. Okay, next slide, please. This is a continuation of the mobile monitoring devices. It's a assistive environment, and then smart blinds to control ambient light, smart bed to monitor sleep patterns, smart closets to make clothing suggestions, smart mirrors for message reminders for medications, smart bathrooms with sensors for measurement of weight, height, and temperature, ECG, smart wave to refuse to heating up the items that you are not supposed to eat, social distance dining using immersive videos, smart floor for fall detection. All these things you can do in the mobile monitoring devices. Okay, next slide, please. That the healthcare challenges already I have mentioned. Next slide, please. Related, what are the domains, subdomains? Domains we are having actually delivery of care, promotion, health, information management technology, organization of the setting of health. Related domains will be actually clinical informatics, pharmacy informatics, nursing informatics, pathology informatics, and many others. All these things are domains of health informatics. Okay, next slide, please. What is the health informatics in our education? Health informatics principles. What are the principles we can say? Principles we can say, so use of drives data, interoperability using open standards, incremental development and the strengthening of systems, enterprise architecture approach, and collaborative communities. Okay, what are the reasons for evaluation of the health informatics? Why it came into? As a result, actually various concepts related to healthcare, like meaningful use of, come to part of the health informative vocabulary. So many care and recording systems through the record system only, that the electronic record, we are saving the data by means of patient record system. That nowadays it came as a electronic health records in the form of pen drive, in the form of CD, in the form of drives, the external storage, all those things. So it is how it evaluates means it's these are the reasons for the storage. We are having the informatics by means of evaluation. How it evaluates means by storing, we are using all this technology. Okay, next slide, please. Health information principles, use of drive data interoperatively using open standards, incremental development and strengthening of systems, enterprise architecture approach, and collaborative communities. Okay, next slide, please. Next slide, please. These are the things, health informatics in nursing education. What are the health informatics we can see in the nursing education? Scope of health informatics. So many times we have discussed about the health informatics, what it is, what is the use, what is the everything. Now, what is the importance in our nursing education? That we will see now. It is there used in the education, practice, research, administration. Next slide, please. How these people are using, where we will get the information. How often the patient look into websites for health-related information. So that we can see now. See this picture, it shows previous slide. Frequently, that is a 63% of the patients frequently seeing the website to get the health information. Whereas infrequently, 19.9% of the persons are seeing them website to see their health information. Whereas NR means no response. Somebody will not turn. 16% of the patient never turn to the website to see their information. Okay, next slide, please. Next slide. You can see the what do our students do with information? They're getting the information from the internet and sharing with everyone. That is our students are doing. What is how we can share the information? Next slide, please. So how do the students share the information? They're collecting all the information through the Twitter, through the Facebook, through the emails, and through the snapshot. These people are sharing the information. Next slide, please. So what is that information overload? So what is the thing happen means, as a teacher, when we are seeing this one, though the basic concept is referring many books, some of the newer technology, we are seeing the website only. So in that concept, what are the things we are overloading by seeing the website? The students also feeling overload. So what is the remedy we can do? So next slide, please. All these things we have to collect. Previously it was chalkboard. Now we are being like a boring lecture. Now interactive learning is possible. If you want to talk also, we can talk, interactive learning. So what to do means we have to collect and form one format. It's easy to interact. Next slide, please. See this health informatics in nursing. So what are the usually health informatics? What are the learning occurs? E-learning. E-learning is the commonest one that we are doing. That is, it can be used past 2 years, we are in the e-learning only, online mode only. So e-learning commonly referred to intentional use of worked information. What is the advantage of the e-learning? What is the advantage generally you can say? What is the advantage of the e-learning, electronic mode or learning? Many of them parents are saying it's boring. My students are not listening. My children are not listening. Is it that? So my thing is, what you feel? That is the advantage. What are advantage generally? Anyone can say one advantage? No. Okay. Generally, it's less expensive. That's the first thing we can say. Less expensive, less to produce, and less expensive to produce. It is not concerned by geographical consideration. Anywhere they can participate, and it's more flexible in terms of time, and it can be delivered virtually by anywhere. They can see our face, we can see their face, and the number of students in the never limited. So many students now also our thing, more than 450 candidates are participating, and then the teacher is able to monitor students' progress. That is also possible, and the individual learning is easily realized. Okay, what is the importance of e-learning in nursing? What is the importance? So anytime, anywhere we can learn. Observation, demonstration also we can use, and professional staffs have access to date the information in which they practice. Speeding of easy, we can go for very speed and service to the patients also. Improving the students' psychometric skills and improve the students' learning, and it clarifies each scientific principles. And what are the popular e-learning mode for the students? Generally, voice-based technology as CD or MP3. Okay. Next is a video technology, DVDs. Next one is computer-based technology. Next is the health informatics and nursing education. What are the health informatics? Enhance both students and faculties in the different ways. Literature access to and retrieval, computer-assisted instructions, classroom technologies, distance learning strategies, testing, student and course record management. All these things we can say is a health informatics for our education. So literature access review means it continues updating community indexes of related books and materials can be searched electronically in a fraction of a time. Even simple word meaning also within a second we can search. Previous days we have to go on a search. Chronologically we have to search in the dictionary. A means A we have to search, then B means abbreviation means A, B we have to search, Next, we go for the next letter. It will take much time. Now, within a second, we are seeing the indexes, meanings, everything. Once a list of search matches is displayed on the computer screen, users can select all of certain citations and then print them on store. Or we can store the content and we can get the information also. Next is a computer assisted instruction. Software programs that covers the topics from drugs, dosage, calculations to ethical decision making are classified according to the format. Tutorial, drill and practice, simulation or testing is possible in the computer assisted instruction. Next is diagrams, graphics, animations, video and audio via CD-ROMs or via the internet. Almost instant access to any section of the program and can be designed to branch to different sections depending on the user's response. Whatever you want, you can search and get it. Okay. Next slide, please. Classroom technology, electronic outlet for the students' laptops and wiring for the network and internet access. Electronic outlet, generally the students can plug and they can use the laptop and Wi-Fi they can use and then they get the information immediately. Smart classroom with projectors that display the content of the computer screens and document cameras that display objects and print materials for the entire classroom. So some of the smart board also there. When you are click the picture of a human brain, it will come. It saves the time to drawing the brain structure. Again, it will mention the parts we can explain easily. Same like smart classroom. Clickers means that is a device which click. The clickers use audience response system and class capture systems that record and post lecture and visuals to the internet. Tools ranging from the systems that use of computers, small devices provide skills, practical skills. Some of the time like the simulations and three-dimensional pictures. If you are showing means it will improve the practical the dimensions also. High fidelity human patient simulators with the ability to breathe, speak, display digital readouts and reflect the impact of the nursing interventions. All those things. Okay. Next slide, please. Next slide, please. Distance learning strategies. In that we can say educational opportunities delivered under the situations in which the teacher and the learners are not physically in the same place at the same time. That already we have said different distance we are meeting and we are sharing the knowledge. That's the main thing. Asynchronous, when the persons involved are not interacting at the same time. Same time we cannot interact. That is called the asynchronous. Synchronous means when the teachers and the students are communicating simultaneously. Online class, we can say that is very interesting and interchangeable, and if the students are interested, that is very effective. Faculty can post a syllabi, handouts, assignments, and examination in the individual course shells, and students can submit papers and hold a discussion online. Assignments also we can submit, papers also we can submit. We can discuss in the online itself. Faculty and the students can create avatar virtual self to navigate through the simulated words and communicate using audio-visual lectures, discussions, and posters. That's also possible by online. Okay, next slide, please. Testing. Next slide, please. Testing means we are testing the students. Computer is ideal for conducting type of learning evaluation. We are conducting and we are asking them to send the papers. There's a large banks of potential items written and the computer generates different exams for each students depending on the selection criteria designed by the faculty. No need to give in the classroom. We can give in the mail also. The faculty will send the mail to the different students. And for example, one teacher is taking class of psychology for the nursing students, physiotherapy students, and radiology students. 3 group students combined, she would have taken classes. But the question paper we can separately send to the mail each students in a different question papers. That is also, it's a designed by the faculty. That is also possible by the designated faculty. The computer determines if the applicant passed the examination by using scoring algorithm. That ensures all the required competencies have been evaluated fairly. That can be evaluated. Okay, next slide, please. Student and course record management. How to manage? So computers are useful in maintaining results of the students' grade or attendance and using spreadsheets. Programs can calculate percentage, sort the student scores in order, and print the results for the students and the faculty. You need not to go for the calculation. If you are evaluating, it to sort out and it would total and give the results also. Data warehousing, the accumulation of large amounts of data that are stored over the time and can be examined for the output in the different types of reports, charts and tables. And we can, for the long-term storage, we can use the records like charts and tables for evaluating other aspects also. Next slide, please. Next slide. Future change in the nursing. What are the future change we can expect? 3D modeling. Nowadays, we are reading the stimulation by means of 3D modeling, like human anatomy, human functions, body, livers, structure, functions, everything, 3D modeling. That also we can learn. AI. What is that AI? AI-based teaching learning platform. That is artificial intelligence. For example, we can say Alexa. That will, if you are programming means, that will do all the functions. You are feeding means it will teach to the students. It will minimize the work for you. Same like robotic nurse. Robotic means when the nurse, you are programming into that one and you are recording and saving means that will teach to the students and that will take care of the patient. That is called artificial intelligence. Artificial intelligence based teaching and learning program. That is a learning platform. It will give the platform for the learn by means of artificial intelligence. Example, we can say Alexa. Alexa we can have in the home. It will say who is coming, who is going, and what to eat, everything it will. Because already it is actually you are programming inside it. Same like a robotic nurse also and a teacher also you can plan and it will say. Okay, e-libraries and distance education. All these things are anticipated to make the nursing education more flexible, optimize the teaching learning process, facilitation of education and research exchange, and improving the nursing administration. That's the gearing up of the future nursing leaders. Okay, next slide, please. 3D modeling, you know, it's a bioink. What it will means it's living cells mixer can build in 3D layers, structure of cells layer by layer to form the human tissue and eventually human organs for the replacement. Computers target realistic nursing education. 3D modeling may provide the insight to the realistic way of the learning things. Okay, next slide, please. Next slide, please. That's a artificial A1 base. A1 that is a artificial intelligence. I told you know. Artificial intelligence based teaching learning platform includes visual recognition, voice assistance, machine learning, expert system, and virtual reality. Okay, next slide. What is the form of informatics to the infographs? The teacher will collect all the informations like this, like so many information, the haphazard base she will collect, and she will put one format and she has to teach to the students. That is the ultimate aim. Okay, next slide, please. What is that big data? So this is recent trends. Recent trends in the health informatics is the big data. Big data means we are collecting information from all the sources, like customer data, social data, purchase data, connected data, everything. With the appropriate volume, velocity, and variety of informations we are getting. Next slide, please. There's a big data means it's a data that contains greater variety, arriving in increasing volumes and with more velocity. So simply by data, we are putting is a larger, more complex data sets, especially from new data sources. These data sets are so voluminous that traditional data processing software just cannot manage them. This information system will manage all those things with a high speed. Next is the pursuit form. Big data is used to describe the massive volume of both structured and unstructured data that is so large it is difficult to process using traditional techniques. So this big data will do correctly when compared to the traditional technique. Everything we will do in the online and stored and tracked as a data. Okay, next slide, please. Next slide. What do these things means? What is this previous slide, please? So many components we are saying. It is a management model of health informatics. This picture is management model of health informatics. So in the each things 1, 2, 3, 4, 5 up to 8 it is there. What are the things we can see in the next slide? Next slide, please. First 1 to 4 stage. It indicates in the management model assess and understands what and for what reasons things are happen. That is the one data collection information. Next is assess and understand the context and identifies the consequences for clinical work and imperative for change. Next, selects the and priorities, opportunities, problems, imperative and requirement for change. Knows of appropriate technological development and relates them to information requirements, knows of opportunities and imperative for change. All these things will come under the first 4 stages in the management of model of a health informatics system. Okay, next please. Next is actually 5 to 8 steps. It says create an information technology and a strategy plan that involves, informs, pursues, prepares for these technologies and other changes, plans and introduces new technologies and other changes, evaluate, review and assess the impact and value. All these things in the big data, you're collecting all the information and finally analyzing, we have come to the impact and conclusion. Okay, next is stage 5 to 8. 5 to 8 is create the information technology strategic plan. Same thing we have seen already. Okay, next slide, please. Some of the example we can say monitoring the say a prevention system. That is the radio frequency identification. GPS. GPS will say where the patient comes, where the ambulance comes, where the what is the status of the patient. GSM and all these things we can say. It indicative of where the patient is coming and doing everything. What do you mean by that? All this system, you know, is it not? What is that? Monitoring tracking. GSM, it's an app which tracking the monitoring system. It will monitor where the patient is coming, where the patient is doing, everything will say in the GMS. Okay. Next is the response. Next, the macro decision process to provide prompt to user for the guidance through the activity hand washing. Wristworm integrated health monitoring device for fall detection, ECG, blood pressure, pulse oximetry, respiration rate, and body temperature. Select video clip for the automated human analysis. So all these things is some of the examples. Now we are having monitoring for the diabetes also and hypoglycemia also. Our PG students are doing the study on that by app applications, how the patient is recovering from this one. And then the body patient walking system also, how many steps they have to walk per day. Everything we can do by this app system. So all the nurse must have the knowledge about the app. If you want to do study, that the IT technology people will create the app and give it to you. Okay, next slide, please. The conclusion, the summary, we can say, it's actually summary. Health informatics is one of the most exciting advances in healthcare and computing. With the increasing cost of healthcare and limited healthcare professionals, and we can say as a health informatics can play a very important role in the future of healthcare. How the information can be used most effectively in various health sector, and that is electronic medical records, electronic health record, that is EMR and EHR, health monitoring, medication adherence, and medical decision making. Next slide, please. Health informatics. And what are the things can future leads to many important advances in the healthcare technologies, proactive health and wellness management, design and use of medications that are most suited to individual patients, healthcare systems that are context aware of to provide the necessary intervention for health and medications, smart technologies that can sense and support the needs of elderly in independent living. Personalized and intelligence monitoring of patients can lead to the better health outcomes. So next, to conclude this one, what is the conclusion we can take, the take-home message? Strategies for managing the latest changes has become the need of the hour for nurses today. It's the basic need that we have to all should learn. Though there are always certain pros and cons in any emerging technologies, the skill required to appropriately respond to the approach. Upfront changes need more efforts. Future of nursing education will incorporate such changes along with the emerging technology. So what is the take-home message? Take-home message is it is nurses' role to develop and update knowledge and skill regarding newer technologies related to the patient care to bring out effective teaching and learning with the demonstration skills. Okay, next slide, please. Thank you. for your kind patience. For more than 45 minutes, you people are calmly sitting and listening my class. Thank you so much. Thank you for the organizer. Is there any clarification? Please, you can ask. So much is there.
I appreciate Jasmine brought a lot of content within this your presentation. So actually, no one can escape from the student to leader or administrator. Everyone we are enforced to learn technology. Otherwise, no other survival. So that is the one. So you very nicely brought everything within. Pouring content like anything like the rainwater. So you are just pouring. But even though it is lunchtime, so the students are also getting, the participants are also getting benefit out of that. Really, I appreciate. No distractions. So it is as like it is the flow is very continuous and other thing it is going on. No, so I was just imagining when we were studying the post basic BS nursing in MMC. So I recall those days. So I'm very happy to have a very good person as a person with humanity and humility. So really wonderful session. Only thing was the students. Cannot able to interact now. So because they are in lunchtime, my session is also going to be postponed after the session, afternoon session, because the lunch, I don't want to make the students to suffer with their hungriness. So I myself decline, I will present later. Let me send the students for the lunch session. But it is highly eye-opening with all technologies. Really is a very good informations where we are and how we have to update. So it is need of the hour. Everything you quoted very nicely. So excellent presentation. That it shows your mastery. It shows your mastery.
For Tanya Mal madam, thank you for bringing and congratulations for bringing a wonderful topic like this, which is actually needed for the present scenario. That is very good.
So it is a team effort, and we have designed this topic 1 year ago because we want to give a topic with new technologies and incorporations. We expected prior to the COVID itself, we planned because the annual event we have to submit 1 year ahead. So that is the thing we are putting into just mild term changes alone, but the core is the same. So we are very happy. So actually we thought of calling in person on campus, but due to COVID, so we just move on to virtual now. So this is the in future. If the COVID situation, if it's over, we may again meet in the campus. Thank you.
Thank you so much, madam, for giving a wonderful opportunity.
Yeah, thank you so much. And you do justice. So all the speakers are very good, and they are giving very good content for the today's participants. It is a very much a feast for them. Yes.
Thank you.
Thank you. Thank you, Jess. Thank you.
Thank you.
So convey my regards to all your family members. Take care of your health. Yes.
Thank you, ma'am.
Thank you.
Thank you, ma'am, for the great presentation on health informatics and future of nursing education. You gave us valuable information. Thank you once again. On behalf of our organizing committee, we would like to present a small token of appreciation.
Yes.
Thank you. Now we are end of the morning session. Let us have our lunch break and we will meet up again after 30 minutes. Thank you.
Yes. Ask them to come soon, as early as possible. And the other two presenters, let them do it first. Following that, I'll be doing as a third. Because no, we don't want to make the external people to wait for. So that's what I thought of taking later session. Okay.
Yes, sure.
Thank you.
Thank you.
Thank you. Thank you.
I walk through those doors with pride. Whose life will I save tonight? Someone is waiting for me, and some are alive 'cause of me. Sometimes I cry 'cause I can't save them all, but it's sure I'll make a change in all. I am a nurse, a force for change. I got no wings, but I'm an angel dressed in white, walking the wars in the midst of the night. I got no wings, but I'm an angel dressed in white, walking the wars in the midst of the night. A baby's first breath on my palms, the joy of a newborn in my arms, tears that I wipe away, does not mean it's a sad day. Night seems so dark, but the morning's so bright. Being a nurse, life's a different life. I am a nurse, a force for change. I got no wings, but I'm an angel dressed in white, walking the wards in the midst of the night. I got no wings, but I'm an angel dressed in white, walking the wards in the midst of the night. The night, in the night, an angel dressed in white. In the night, an angel dressed in white. My hand just closed his eyes. He was staring at me as he died. Dear ones cry and leave. Courage and care I give. I hold them tight and help the pain. I hold them up when they feel faint. I am a nurse, a force for change. I got no wings, but an angel dressed in white, walking the wards in the midst of the night. I got no wings, but an angel dressed in white, walking the wards
August 22 we pay advertisement. Hello, madam. Good afternoon. Kindly unmute, ma'am. Ma'am, could not able to hear.
Yeah, am I audible now?
Yes, ma'am. Good afternoon. How are
Good
you,
afternoon.
ma'am?
Yeah,
Good
fine,
afternoon.
fine, fine. And
So
thank you for
nice to
inviting
see
me.
you. Yeah,
Yes,
so nice
thank you.
to see you on screen now.
Yes,
Yes, ma'am.
yes.
Long back we have met prior to
Yes.
COVID, no?
Yes,
ma'am.
yes.
So nice. How is your family, ma'am?
Yes, all
Daughter?
are doing well. Yes,
Good,
yes.
ma'am. Good. Yes. I think almost around 200 have joined.
Very good.
Are you waiting? Waiting few more to add. Shall we start?
now?
We can start. Yes,
Yeah, they will come and join there in the lunch, ma'am. They'll come back, ma'am.
yes.
Okay.
Yes, ma'am.
Good afternoon, all. Welcome back to the plenary session. A gentle reminder to all the participants. At the end of the conference, we will share a feedback link. Kindly provide your feedbacks. Let us move on. I would like to invite Professor Kalavalli, Department of Psychiatry Nursing, SRM College of Nursing, to introduce our next esteemed speaker. Ma'am, please do the honors.
Good afternoon to everyone. With immense pleasure, I am privileged to introduce Madam Dr. Lata Venkateshan, nursing expert, for this plenary session on transforming nurses' role, entrepreneurship in nursing. Madam is having 32 years of total experience in education, clinical nursing, and administration. Madam currently holding the post of Professor cum Principal at College of Nursing, AIIMS, New Delhi. Madam is a PhD guide in WHO, INC, and Rajiv Gandhi University and Health Science Consortium. Madam lead a nursing thematic for learning content creation for COVID by Ministry of Health and Family Welfare. Madam published several articles in Index Journal, authored textbook, and also an editor of journal. Madam organized several international national conference and short-term courses. Madam is advisory board member of Skill to Scale Indo-Sweden Collaboration Initiative. Madam is a committee member of ICMR at Bhopal. Madam is a UPSC advisor, selection committee member, and member of UG and PG students admission committee of various AIIMS, and also expert committee member of RIMS. Madam experienced as governing council member, president of faculty, member of selection committee and finance committee, senate member, board of studies member, and board of research member, and also a doctoral advisory committee member of distinguished universities. Madam is currently involved in WHO project and also AIMS and UK collaborative project. Really, we are privileged to have Madam as a resource person for this plenary session. Over to you, ma'am.
Thank you very much for that kind introduction. And at the outset, my sincere thanks to Principal Dean of SRM College of Nursing, Dr. Tanya Mal, and the organizing faculty members for inviting me as one of the resource speakers. The conference theme is very unique. And it will explore the concepts which are very much required in our country to get implemented by nurses. And excellence is a journey. It is not a single time event. On that note, always SRM College of Nursing organize very meaningful conferences, and they invite resource persons from various parts of the country as well as outside country, and their conferences are well accepted and looked for by the audience. So thank you very much, and my sincere congratulations. Now I enter into my job of talking on entrepreneurship in nursing.
Yes, yes, ma'am. Almost.
Is my slide visible?
Yes, ma'am.
Yes.
Projective view, so you can move to projective view.
Yeah, when I put on slideshow, let me try. Yes. When I go on slideshow, I cannot see all your faces.
Oh.
So, yes. Yeah, still it is visible. Good.
Visible, ma'am. Visible.
Yes.
It will
Yes.
be visible in the
Yes.
ma'am. Yes.
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 So I'm here to talk about entrepreneurship in nursing. So I have some interesting pictures for all of you. Before this, do you know any entrepreneurs in India? Nurse entrepreneurs in India? Any
Already
of you?
you projected.
Sorry, I went forward.
Yes,
so, yeah.
First it says our sir, Dr. Ramasamy sir, established a college.
Yes.
Yeah.
Yes.
So yes, ma'am.
Yeah.
So that is the living example we are witnessing everywhere and beyond
Yes.
that.
Yes. So when we hear the topic entrepreneurship in nursing, what would have been the first reaction of our nurses? Oh, entrepreneurship, is it possible in nursing? How we will do it? What will be the difficulties? Is it really possible? Do we have the necessary skills to become an entrepreneur? And what is the rate of success? And what are all the models available? This must be the questions in the mind of the audience. So I hope, though I am not a nurse entrepreneur, I always have an ambition to become an entrepreneur. But the moment you are salaried, you have a job, you have a secured job, we will never think about entrepreneurship. So that is one of the reason in nursing why we find very less entrepreneurs, because I think for next 30 years, nurses will never be jobless. We get a job and we get salary, so we are very comfortable. So only when we are out of the comfort zone, when the need for survival comes, then we will find many entrepreneurs arising in nursing. So, but still, this is a concept which has to be explored and keep ready, because even after retirement, there is a chance to become entrepreneur. So I have a plan to become an entrepreneur. Once I retire, I want to start a palliative care unit,
Yeah, so nice, man.
Yes,
congratulations to you.
Yeah, for terminally ill patients, hospital expenses are very high.
Need of the hour, ma'am. Everywhere it is a need of
the cost of intensive care and the hospital care is very high, and the families have become very small, and children are not there. Who will look after the elderly population, including us? We are also growing old, and our children might be affectionate to us, but they may not have time to come and be with us physically. So I think we have to evolve a model and help the people who are in need. So that is my plan for entrepreneurship, but not now after my retirement. So
that's why I thought the topic is more apt for you. That's why I've given this topic to
you. Thank you for the confidence.
Yes,
these are the nurse entrepreneurs in India whom I know. Actually, I was looking for some slides on nurse entrepreneurship, and it was just showing the nurse entrepreneurs in elsewhere, in US, UK, other parts of the country. Then I was thinking why I should project project the nurse entrepreneurs from elsewhere to whom I do not know how they become nurse entrepreneur and their journey and their success stories. Then I was remembering who are the nurse entrepreneurs here in India. Then immediately to my mind, these few people came. Of course, there must be many more who have become nurse entrepreneurs. The first one is Professor Dr. Ramasamy. After retiring, he was principal in Savita College of Nursing, and after that, he started his own College of Nursing. I think he is a true example for us. And you also must think that age is not a barrier. At any age you can become an entrepreneur. It is not that you have to become a young entrepreneur or you need some experience to become an entrepreneur, or you're retired, then you have to sit at home idle. Though there are no restrictions, and he is an example. Age is not a limitation to become an entrepreneur, and he lived the profession until the last day of his life. I remember before his death, 2 weeks before, he was calling me, Lata, I'm breathless, I want to come to Apollo, can you help me? He was working until the last day. So those are the role models and inspirational nurses we have to take up in designing our journey in this profession. And next one is Dr. Prakashama. Dr. Prakashama, she quit her government job. She would have comfortably stayed as a professor in Government College of Nursing, Hyderabad, and she must have led a very comfortable life. Throwing away a comfortable job, the two government job, and starting her own enterprise, which is called as Answers Academy for Nursing Studies and Women Empowerment. Till today, I find she is the only nurse researcher who is doing the projects for the government and giving significant findings to the policymakers. So at policy making level, her contributions are very valid, and she is invited to handle projects and give the findings to design the policies for various states. And she is also internationally popular, and her academy is very good, and we should visit any nurse. It's worth visiting at least once the academy. They have a lot of learning activities going on there. They are serving the rural population. Then we have Miss Tangam Gomes. Tangam Gomes, I don't know how many of you know. She was in the corporate sector. She was the nursing head of all Fortis hospitals, and then she has come out, and she also has started her own company called Signia Healthcare, and she is doing consultancy to start the hospitals, to get accreditation. She has a lot of learning activities, modules, and she is very active. Now she is in the digital world. Just click on her website, you will find what kind of activities they have designed. And yet another person is Ajita. Ajita is also very young, and she was also in Fortis, Ruby Hall, and she worked right from the beginning of setting up a few corporate hospitals in Kerala, and that experience has helped her to develop her own company called HealBiz. And right from designing the hospital to that of establishing the standard operating procedures, setting up all the operations, including the finance management, material management, and training the employees, HR management, everything she does right from A to Z of hospital business. That's beyond the scope of a nurse, beyond the role of a nurse. They were all, Tangam and Ajita, both of them were chief operating officers in corporate hospitals like Fortis and Aster MedCity, very, very big brands. And being nurses, the management had the confidence to elevate them as chief operating officers. That means the entire functioning of the hospital will be in their hands, and they will be responsible for the P&L. P&L is profit and loss. That's a great responsibility they all have taken up. And today they are entrepreneurs where they have set up their own consultancy, and they are independent, and they are very successful. So these are the nurse entrepreneurs we have, living example. So I think now everyone, the audience might have had an idea or an inspiration that we too have the potential to become entrepreneurs one day, either today or tomorrow, or one day we will become entrepreneurs. So who is a nurse entrepreneur? A nurse entrepreneur is the one who uses his or her background in professional nursing to start their own business within the healthcare industry. See, you have to understand in the healthcare industry, I know many nurses start other businesses, but within the healthcare industry, when we start, we are called nurse entrepreneurs. And nurses as entrepreneurs have really created a revolution in the making. How did they do the revolution? Nurse entrepreneurs use their knowledge, training, medical expertise, experience, and to create and advance their own business within the healthcare industry. And the nurse entrepreneurs play a crucial role in the development and advancement of new medical applications, that is the devices. Many nurses are working in device manufacturing companies. Many nurses have designed products for patient care, information systems, medical record tracking software, home health products, and much more. Because nurse entrepreneurs do not operate under a specific employer, they are able to work independently and autonomously to provide a variety of nursing services, which might include things like patient care, home health care, consulting services, and nursing education. Nursing education means not running formal courses. It is running the courses to empower the nurses in multiple areas as and when required. Then to be successful in this career, individuals must be creative, hardworking, business savvy, and willing to take risks. You have to you have to understand that taking risks, it is becoming a nurse entrepreneur is definitely taking risk. What risk? Financial risk, professional risk, and personal risk. But it's worth taking the risk at the end of the journey. And if you look at I believe the nurses can be successful entrepreneurs. But why do I believe? I believe the nurses can be successful entrepreneurs because they have good communication skills. We communicate with variety of people, with the patients, their families, with team members, with administrators, policy makers. So we have the opportunity to communicate with a spectrum of people. And you probably don't recognize this, but you are the ones comforting the patients most of the time. And we have great listening capability. Let me get this straight. Listening is one of the most challenging and essential virtue. And nurses are gifted with this essential virtue. And we have excellent selling aptitude. Aren't you selling when you convince a patient to take the test or lure a child into adhering to certain schedule? Actually, so we do have the convincing capability or an excellent selling aptitude. Also, nurses are, I think that slide is not visible. So all in all, nurses have all it takes to be successful as entrepreneurs in the ever-growing healthcare industry. Besides being competent, nurses know how to add value to their contribution and how to market it appropriately, because being an entrepreneur, it becomes like a business and you should know how to market. Whether you make profit or not out of the business is a different concern. And what are some of the common duties and tasks which are to be carried out by nursepreneur? I have listed few, but it is not limited to only these common duties. They need to utilize their nursing education and experience to start business ventures within the healthcare industry. And they need to secure finance. Of course, there are a lot of funding which is given by government for startups, and engineering students are using up startups and they have incubation centers and coming out with wonderful products. Similarly, nurses also can go for startup funding and taking care of accounting, payroll, and taxes. This is also very important because you need to hire and manage the employees, you need some equipments, and you need to go for marketing, and you need to be responsible for patient care or whatever services you are offering. So it is so we need to be acquainted with taking care of accounting, payroll, and taxes, and we should know to hire and manage the employees and making their business in order to attract new customers and retain the old ones. Customer satisfaction will be the driving factor of making your venture successful. And supplying healthcare products and providing nursing services, which could include nursing education or consulting services or direct patient care. And where do they work? Where are they working? The nurse entrepreneurs. Nurse entrepreneurs can work in a variety of settings. The most commonly found employment or nursepreneurs are in the following areas. That is, owning and operating a business, working as a nurse educator to the public. You can train pregnant women to undergo the journey of childbirthing smoothly. You can help them as lactation consultants. You can run a creche. And working as an independent nurse consultant at hospitals, they work as a consultant for the hospital, to design the hospital, to set up the hospital, to establish the accreditation systems for the hospital, and whatnot. And home health care. Of course, now home health care has become very popular, especially after the COVID pandemic. We have realized the importance of home health care and the advantages of home health care, and nurses can play a very vital role in this area. And nursing information technology. The hospitals are turning to be e-hospitals, and to design their nursing informatics, you can give the input. And then once the hospital is becoming an e-hospital, there will be a lot of data, electronic data available that need to be classified. You can do big data analytics and give them inputs, So, and what are the educational requirements? Somebody is raising hands. Yeah. Somebody was raising hands. Yes. Yeah. So what are the educational requirements? Educational requirements, do we require any special education to become a nurse entrepreneur? Definitely no. Our RN, RM is more than sufficient to practice the nursing care skills which we have learned. But of course, there are some nurse entrepreneurs whom they have equipped with MSN, medical surgical nurse, masters in nursing, and MBA. But it is not necessary that you need to be a master's in nursing or a doctorate in nursing, or you're an MBA holder. Our simple nursing skills are much more sufficient. Here I really remember some of my students. I had the boys who were my students when I was working in PSG Coimbatore. So these boys, when they got graduated and they came to the college one day, and I was asking them, what are you doing? They said, ma'am, we are practicing. I asked, what are you practicing? Yes, madam, we know to check BP. So we go in our villages and we check BP for all hypertensive clients. We know how to check urine sugar. So we check the diabetic clients and we educate them. We give injections, we do dressing, we administer IV fluids and whatnot. These are the skills which are required. And I said, okay, how are they paying? They said that we have fixed charges for each of the procedure. Those days they were telling, for dressing it is 75 rupees, for injection it is IM injection is 50 rupees, IV injection is 100 rupees. Yeah, much better for so this is how we have to start. So they have started practicing. This is the story 20 years before, 25 years before. I think even today that opportunity is there. We can still become nurse entrepreneurs. Simply you place a board in front of your house. How many of us have placed a board stating that we are RN, we are nurses? Place a board. Advocates do, doctors do, even engineers are having board in front of their house. You just put your name that you are a nurse. You will know that your own colony people will be approaching you for multiple consultations. Your independent practice, your nurse entrepreneurship will begin the moment you put a name board in front of your own house wherever you are living. And many of you must be living in apartment complexes now where you have thousands of families living. Everybody will have healthcare need, not only that they have to suffer from a illness. Now wellness concept is gaining the momentum. You can become wellness coaches. You can teach them wellness, So there is no requirement. You don't require a special qualification to become a nursepreneur. Even if you are an RN/RM, even if you are a GNM, you are already prepared to become an entrepreneur. And what is their job and salary? Because the nursing, what is the salary? This will be the question for you, because now we get a comfortable salary. We come and work, we go. But when we become a nursepreneur, what will be the money you will get? Because ultimately you have to meet your living expenses, and you must support your salary and support your family. So you need to have some income by becoming a nursepreneur. So what is the income? Nursing field is definitely rapidly expanding opportunities to start successful business within the field are really plentiful. And those nursing entrepreneurs who can incorporate technology into healthcare field will find sky is the limit. Now you start your digital health, you can start your own app, your own website, your own channel where you can get connected with clients and start counseling them, start guiding them, and prepare them. So these are all the ways. Sky is the limit. Only thing is you must have the interest, the commitment, and connectivity with the people. So what is their job description? Because it's a role, then you require job description. So you need to have certain essential skills. That is, definitely you should have traditional nursing skills. That is why I have put that in capital letters, because all the hands-on skills which you learned in your first year BSc nursing, that will be the foundation to become a nurse entrepreneur. Rest all is what you build further upon that. So you need to have accounting skills, marketing skills, business management skills, willingness to take risks, excellent communication skills, friendly disposition, you should be a self-starter, you must be creative, and you must be hardworking, and ability to work independently. So these are the job description or information or the essential skills a nursepreneur will require. And in which are all the areas you can become a nursepreneur? Because I was suggesting the broader areas, like you can be a consultant to set up a hospital, or you can be into direct patient care, or you can be an educator to the population. But you can start your private practice. For private practice, as I said, first place a board in front of your house. Your own house will turn into a clinic. I remember Vailtech Anu. No, I didn't get her picture. She was the principal of Vailtech College of Nursing, and the College of Nursing, the management decided to close down, and she was very apprehensive what to do. She moved to an apartment and she converted her house into a old age home. And when I came last time for the vacation, she came and met me personally. She said, wonderfully I'm doing, Lata. I want to expand the center, because I converted my 2-bedroom house. I have 8 beds there. Now I am unable to accommodate. There are so many clients who are coming, so many patients who are coming. So I want to expand. I want to build the first floor of the hospital, and I want to have an ICU, because the kind of patients whom I am getting are requiring intensive skills. Imagine a nurse who's converted her own house into a old age home, now expanding to start an intensive care unit. What more example we require? And what is the basis is only the patient care, nurse freelancers. What is nurse freelancers? Like, you're available for consultation for freelancing. Any hospital who needs your service, they can take up. Like now, what I was mentioning, Anu, who was once the principal of Vailtech College of Nursing, now she can be a freelancer. She can guide many of the nurses to set up similar nursing home, and medical spa for aesthetic treatments. We find reflexology chairs in airport, only doing the massage for the food. So nurses, we learn the techniques of massaging. We know much more. So we can set up the wellness clinics and do the aesthetic treatments, and we can be nurse influencer. Nurse influencers, there is a channel for nurse influencer. They are sharing their success stories. You can join the channel and you can become an influencer. You can be a motivator, and you can be a childbirth educator. You can write from pregnancy or write from infertility to that of nurturing the children. You can become a childbirth educator, lactation consultant. Though we say breastfeeding, exclusive breastfeeding, it's not so easy. Mothers come across many difficulties, and they consult their mothers or in-laws or neighbors, and each one share their own personal story and confuse the women. So you can become a lactation consultant and guide them to become successful in lactation. And home care agencies, we can start home care agencies. And when the patients are kept in the hospital only during the acute phase of the illness, suddenly they are asked to go home. Who will take care of them? Children have to go for employment. Children may be in some other country or some other state. who will take care of the people once they are discharged from the hospital, once the acute phase of illness is over. So they will be definitely looking for home care nurses, and you can start a home care agency, and you can have pain management clinics. Why patients come to hospital? Only for one reason: when they experience pain and discomfort. So this is the only reason where the patients rush to the hospital, let it be chest pain or let it be childbirth pain or whatever it is. Pain and discomfort is the main reason why patients are coming, and we can run pain management clinics. Content editing, you can be content editors, for the research and for the journals. You can be an editor, you can be a content editor for in various aspects. And the hospitals must be developing standard operating procedures. You can edit their content, because this content editing is a very, very broad field. And creche and nursery, and the people who are not nurses are starting creche and nursery. I saw when my child was very small, when I left them, they are all just ordinary people, Then I thought, if a nurse starts a creche, you will not have any limitation for the entry age. You approach any creche, they say, oh, the child must be at least 18 months old. We cannot handle a child who is less than 18 months old. But as nurses, we can care even from first day of life of the child. We have the capacity to care even the newborns. We need not fix any age limit. So that's the advantage. So we can start creche. We can be a health blogger, we can be a counselor, wellness coach, we can be product designers. So we have all the old products still in use. You can be associated with product manufacturing companies, and you can design products. The beds, you take the beds. What I learned, bed making is not the bed currently in the hospital. Currently you have electronic bed, you have multiple features in it. Who designed this? Naturally there must be some nurses behind the screen who gave their inputs, what they need. And so many other new equipments and products are coming. The pulse oximeter, which I practiced, was like a size of a radio. Today you have finger pulse oximeter. So there are so many advancements. You take, why not health products? You take mobile. No, you have i12, i13, i14, and other phones. Every year they are launching new phones. So we also have to improve our products, and there is a scope to become a product designer, and we can become nurse authors, nurse historians. You interview successful nurses and publish their biography. Yeah, I know an author who publishes the biography of celebrities, like the chief ministers and very famous musicians, and people who are very famous in their own field. There is a person who writes their biography. She goes and spends their time for 1 or 2 years with them and observes their life and takes verbatims from them and publish it as a book. So we can also become nurse authors. There are successful nurses. You can talk to them, you can listen to them, and you can publish their biographies. And healthy meal deliverers. This was something very new to me. Healthy meal deliverers. Now you have Swiggy and Zomato, all they will help you to deliver. Only thing is you have to prepare and you can supply. For example, a renal patient is there. A renal patient will require a potassium-free diet. They may not know how to prepare a potassium-free diet, but you and me, we know how to prepare the therapeutic diets. Why don't we prepare therapeutic diets and supply through Swiggy and Zomato? So you can supply salt-free diet, you can supply diabetic diet, you can supply renal diet. See, sitting at home using your own kitchen, you can become a nursepreneur. So this is the beauty. I think the ideas will be limitless and endless. And I think I would have stimulated the thoughts of you now, given an opportunity. Each one of you will say that, oh, we can do this, we can do that, So I think if I have kindled your thought process, I think the presentation is successful. And what's going to be the future of nursepreneurship? Nursepreneurs are definitely going to bridge the gap between high quality healthcare delivery because they emphasize the use of apt products and modern technology. And nurse entrepreneurs lead the innovative industry. See, it like supplying a therapeutic meal. It's an innovation. So we are going to lead the innovative industry. And of course, we are going to live in the competitive industry because the moment you start, there will be a lot of competitors who are coming. And we have the capability to transform the healthcare sector, and we will be able to lead the healthcare sector in a very rightful way. So, so finally, this is my last slide. That is, if somebody thinks, oh, still nurse entrepreneurship is not possible, it has got a lot of risk, oh, I cannot do it, it is the job of somebody else, it's a cup of tea of someone else, or if you think it is this when we are jobless we need to start, all these queries if you have in your mind, I'm telling you, if nurse entrepreneurship cannot have a future, I don't know what else will have the future. So thank you very much for the opportunity. And thank you, Dr. Tanya Mal and your team for giving me this opportunity to talk on nurse entrepreneurship. Thank you.
Thank you so much, ma'am. It's highly brief and vivid and real lifelike situations we brought into, not copying or from other countries and saying things. It is highly practicable and what we can do. So it is eye-opening for from the youngsters how we can develop as like entrepreneurship, not for the older people or after retirement. Anytime it can be started. So that's it is the need of the hour. Everyone is very, very interesting to hear about this thing, various things. No, we may not be knowing our values. Start from the keeping a board. So we people are not doing that. So these are some of the things we need to think about, and we need to put it into our practice and how far it is. We can think about why we are working for others. At least to some extent, we need to think about some people, they in the young age itself, they may have that idea. That also it is a promotive behavior. So it's very good thing. So nice presentation, ma'am. Thank you so much.
Thank you.
Thank you. It is very lively. Thank you.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
God bless you, ma'am. It is our privilege to thank you personally on behalf of me and from SRM College of Nursing and our management. All the time, whatever may be the topic we are alerting to you, you give your most, what I can say, to the best.
Thank you.
Justice.
Thank you.
Give, ma'am.
Thank you.
So that's what immediately Lata Madam we can call. So that feel
Thank
I
you.
have. So you are
Thank you.
also justifying that. Thank you so much, ma'am.
Thank you for the
God bless
confidence
you.
all of you have on me. Any questions from the audience?
Yes.
Any questions in the chat box, or anyone who want to ask any questions related to?
It's floor. Excellent presentation. Some it is from our college, ma'am.
Yes, I could see Priya. Priya has kept a video on.
Yeah, yes, ma'am.
Yes, Priya.
Yeah, that is the thing.
Thank you.
Delegates, yes, ma'am. So it is a real eye-opening for all of us, ma'am. Thank you so much.
Thank you.
Take care of your health and family.
Thank you. Thank you so much.
Thank you, ma'am. Yes, ma'am. Thank you, ma'am.
Yes.
Thank you, ma'am, for the enlightening speech, power-packed presentation on entrepreneurship in nursing. It was really informative. On behalf of our organizing committee, we would like to present a small token of appreciation.
Thank you.
Thank you, ma'am.
It is a e-certificate, a bit momentum.
Yeah, I think you need to do a spelling correction. My name is Dr. Lata Venkatesan, not Venkatesh.
Yeah, it is error, ma'am. We will do the corrections and we will send it to you, ma'am. Sorry for that.
No.
We will send back to you a small memento also with the certificate. We will send it to you, ma'am.
Thank you. Thank you.
Thank you so much, ma'am. Thank you, ma'am. Good day.
Thank you.
Thank you, ma'am.
We will start our forthcoming session shortly.
Madhavi has joined or not?
Still, she is not yet joined, ma'am.
Ma'am told that she will be joining in a few minutes, ma'am.
The corrections, the certificate இதெல்லாம் நோட் பண்ணிக்கோங்கம்மா. அதை கரெக்ட் பண்ணிட்டு அவங்களுக்கு கொடுக்கணும்.
Yes, ma'am. Sure, ma'am. To all the participants, please do check your email as we have sent an email with gift vouchers. Kindly inform via chat if you haven't received it. To all the participants, please do check your email as we have sent an email with gift vouchers. Kindly inform via chat if you haven't received it. Well, it is a cooked up story to get your attention and make sure you are active post lunch. No email was sent. I'm very sorry if I disappointed you. Now, I would like to invite Mrs. Ambika, Associate Professor, Department of Medical Surgical Nursing, SRM College of Nursing, to introduce our next esteemed speaker. Ma'am, please do the honors.
So good afternoon, one and all joined here. Today we are here to listen and learn interdisciplinary research collaboration, a roadmap to nursing excellence. It's my great pleasure and honor to introduce our eminent speaker, Professor Dr. Madhavi, Principal, KMCH College of Nursing, Coimbatore. Our speaker has a distinguished career in nursing. Ma'am completed BSc Nursing in 1990, MSc Nursing in 1997, PhD in Cardiology Nursing 2009. Ma'am has great depth of experience and hold many various positions like worked as a nursing supervisor, Cardiothoracic Intensive Care Unit, Southern Railway Headquarters Hospital, reader in Ramachandra Medical College and Research Institute 2003. At present, ma'am working as principal, KMCH College of Nursing, and also advisor to Nursing Service, Kovai Medical Center, Executive Editor of the Tamil Nadu Nursing Council Journal of Medical Surgical Nursing, South Asian Advisor Panel member of the Lippincott Publishers. Ma'am visited University of Wisconsin, USA, and presented many vital papers like issues in care of mechanically ventilated patients, nursing alerts while caring for patients undergoing CABG, and observed the curriculum administration of nurse practitioner program and bachelorate program in nursing. Ma'am went as a resource person for numerous workshops and conferences conducted by the professional organizations like Trained Nurse Association of India, Indian Critical Care Association, Asia Pacific Cancer Society, and other nursing colleges. Ma'am is the author of first South Asian edition of Brenner and Sudha textbook of medical surgical nursing, and prepared a online CND module on wound care, which is available at the official website of Tamil Nadu Nurses and Midwives Council. Ma'am got many honors and awards: university rank in BSc Nursing, awarded Best Nurse Educator in Tamil Nadu State Nurses Day celebration, awarded Best Teacher in the Tamil Nadu MGR Medical University, received a research grant from Tamil Nadu MGR Medical University, awarded bed service for enrolling and training more than 1,000 volunteers in disaster management training program. With this introduction, I welcome you, ma'am, for the presentation.
Thank you so much for the beautiful and lengthy presentation. And I am really delighted to see my good friend, Madam Dr. Tanya Mal, who is doing excellent job of organizing, pooling the great experts across the country, and a very wonderful conference. And I'm so delighted to be part of this conference. And I bring a lot of good wishes and greetings from KMCH College of Nursing, where I am the principal. And really, it means a lot. I'm very happy to be part of this conference. So let me share my slide and let us go to the presentation without wasting a lot of time.
Dear ma'am, please unmute yourself. Ma'am.
Dear Madhu, we are most welcoming you for your good deliberation, share your experiences with our participants. So really it is for nursing. So everyone is working for the excellence to the quality care at the bedside. So that is the note it bring, the theme it came arise 1 year ago. And we are very much delighted. All the resource persons, they are doing their own justice. And this topic, you will give more justice, which we are expecting. I believe in that. So we are welcoming you for your good presentation. Following that, we will have any of the queries to be discussed.
Thank you. Thank you so much.
Thank you. Thank you. Yes. You are sharing the screen, or they have to do?
Yeah, I'm sharing the screen.
Okay.
And again, warm good afternoon to all the participants and the great luminaries across the digital platform there. And happy for you. And once again, congratulate you for organizing such a wonderful conference. And let me go. Am I audible to all of you?
Yes,
yeah,
ma'am.
you're audible. Yeah,
My slide is visible?
Yeah, yes. It is
yeah,
too.
thank you.
Good.
So again, a lot of wishes and greetings to all of you, all the participants, and especially our Dean, Dr. Tanya Mal from KMC College of Nursing. So, and today in another 10, 15 minutes, 20 minutes time, I may be taking you across what is interdisciplinary collaboration, what are the composition of interdisciplinary team, principles of interdisciplinary collaboration, and what is interdisciplinary research, the major typology of interdisciplinary research, steps in interdisciplinary research, benefits and challenges, and some exemplars. Let us go to the slide. So what do you see there? All of you had a very sumptuous lunch, I feel. And again, all of you may be in post-lunch, postprandial sleeping mood. That's why, again, I'm bringing you something here.
To think about.
Yeah, think about it.
It's like a powdered sugar, ma'am.
Yeah, here is powdered sugar. That
cube.
is a flour.
Very nice. Very nice.
Flour.
I also thought, yes, good.
Sugar.
Yeah.
And here the eggs. They all are very, very important and nutritious, and they cannot make something that you see now. They are alone, put together all nearby. You cannot make this beautiful cake.
Beautiful cake.
So
very nice.
All these things.
It is a dessert. Following by the lunch, it is a dessert you are giving.
Yeah, I'm providing you interdisciplinary research dessert to you. So
yes.
The egg alone cannot make cake, or keeping all these egg, flour and sugar together in one place, it cannot make a cake. So the flour need to be mixed with the egg, beaten egg, and then it had to be added with the sugar. And then all these things need to be baked very beautifully. Then you get a sumptuous and very beautiful cake. So is the interdisciplinary research. That is the topic that I'm going to go into.
Okay, good.
So why do we? The hospitals of the future will be shaped by scientific, technological advancements that made across wide discipline or wide range of discipline, because complex problems in healthcare cannot be addressed successfully by a single discipline. If you see the many people, they lose the limb. I have seen a presentation by using artificial intelligence. They have created the arms which is lost by people. So it is cannot happen. Engineers separately, they work. The medical professionals work separately. All these advancements would not have happened. So there is essential nature itself, the complexity of the today's problems warrant such interprofessional collaboration. Interprofessional collaborative practice is the key to safe, high quality, accessible, patient-centered care, which is desired by everybody. So what is interdisciplinary collaboration? A breakthrough innovation occurs when we bring down boundaries and encourage discipline to learn from each other. As said by Gyan Nagpal, although each discipline contributes to unique perspectives, together the team can provide optimal integrated services. Yes, very much needed. That is why we are here today on this very vital topic. So what is interdisciplinary practice? It is a joint communication. See, we keep all this, we keep oil, we keep the water, we add oil to the water, it stays in the same place. It is co-locating. So like a nurse and a doctor stays in the same ICU or in the ward or in the theater, they all stay in the same place doing different works. So water stays always separate away, floating up, but interdisciplinarity is not that. There should be, it's co-locating. Many times people say we do a research together, a doctor and a nurse, and you get some ideas and consultations, and then you put as a joint paper. It cannot be interdisciplinarity in research or in practice. It needs essentially a joint communication and a decision-making process with the goal of satisfying the healthcare needs of the target population. So there should be blending of edges or boundaries. So there should be a decision making. So nurses need to be taking part in decision making. How much we do take part in decision making. So as long as we stay as handmaids of at the medical professions, we cannot go for interdisciplinary practice, and we cannot definitely do interdisciplinary research. When we have interdisciplinary education also, we need to have interdisciplinary education. And because inherently in the healthcare team members, all of us are not sharing the same values, all of us are not sharing the same power, and the communication is so narrowed down or so formal. It can be formal, but they're not purposive, deliberate, listening and taking up the points on. So for interdisciplinarity, we need joint communication, decision making with the goal of satisfying the healthcare needs of target population. So interdisciplinary healthcare team is a group of individuals with a diverse training and backgrounds who work together as an identified unit or system. A nurse, a doctor, intensivist, neurologist or pulmonologist or a cardiothoracic surgeon, physiotherapist, occupational therapist, counselor, psychosocial worker, all these people together, when they have a purposeful interaction between each other and they have a shared goal and decision making towards a welfare or achieving the optimal outcome, then we call that as an interdisciplinary team. So aging and chronic illnesses makes the needs are complex. Then complexity of skills and knowledge. The skills of like there are different specialization in the medical fraternity. So there is a increasing specialization in nursing too. And in other fields, every field you can see there is a growing specialization. So you are compartmentalized. When the domain is so compartmentalized, how can we look into the other aspect of the problem and help the patient as an individual? As we all know, the health is not just a physical domain. There is a psychological well-being, social well-being, spiritual well-being, and emotional well-being. All this together, when we want to achieve, we all need to work together. Then there is a global calling for multi-professional. I think from 1970s onwards, the Western world is moving towards the advanced developed countries like US, UK and other countries. They're all going for interprofessional practice and interprofessional education. There are duplication can be avoided, and better patient care and quality of care can be improved. Nowadays, patient demands quality care. So there is a need for continuous quality improvement. So we want to have this interdisciplinary practice and research. The components of interdisciplinary collaboration can be 5 core components as proposed by Brunstein in 2003. The essential first core component is interdependence. Without having this interdependence, very essential, these 5 core components are very, very essential, and they define the collaboration is the thing is interdisciplinary collaboration or not. Interdependence, newly created professional activities. Traditionally, as nurses, we have been administering medication, giving back care, doing these all procedures, whatever demanded. But when we want to move towards interdisciplinary profession, we need, from bedside, we need to move to boardroom. We need to discuss on policy matters at the patient care meeting. So in the multidisciplinary team, we need to sit across the table, we need to discuss. So we newly created professional activities, flexibility in the roles, collective ownership of goals. One, anything happens, the passing the buck to the other person, less privileged, less advantaged person. So this is what happens usually. So compartmentalized or a single discipline practice. But when it is an interdisciplinary practice, we look into the components where we are going wrong and how it can be rectified. Collectively, we think together, work together, and then we achieve the problem. So the collective ownership, if something goes wrong, oh, you have given a wrong medication, have you did this, have you done that? So this is the common questions. I have seen that in our own cardiothoracic ICU. Whenever I have seen, if everything goes well, nobody is thinking about nurses. But when there is an arrest happens, what sister, what did you give? What is the medication you give? What did you do? What did you do? This is what is the common thing. So you want to negate and you want to give better patient care. Everybody is equally accountable, not just nurses, not just the doctors. So when we are working as a team collaboration, this collective ownership gives a lot of satisfaction. Your performance is much more increased. The reflection on process. So you can reflect on process. After something happens, we look at it, it is called reflection upon the process. But while you are doing reflection on process helps you to identify our own shortfalls. We continually improve the quality. So these are the 5 core components of interdisciplinary collaboration. So what do we get out of it? Improved patient and family outcome, improved diagnostic and prognostic facilities, improved health outcomes, enhanced satisfaction for clients, efficient use of resources, enhanced job satisfaction for the team members, and efficient functioning of the health system. Because we can avoid, we can do a lot of lean management, cost effectiveness can be achieved because we can reduce and cut on the cost which is unwanted, and we can bring about better patient care. So efficient functioning of the health system. So what are the major challenge? So as nurses, we are bringing together the interdisciplinary components and getting them working truly in collaboration is the key challenge. So here as nurses, what we are doing, we need to look at it. So we are not assertive, we are not strengthening our own discipline knowledge and our own expertise. Then only we can sit across the table and we can come out with ideas which can be then listened. So when you are not accustomed yourself with the latest technological advancements, so I have seen nurse giving not knowing how to use insulin pen, giving triple the dose of insulin and rotated the insulin pen just like that and gave so much. And what then the blame comes on. So we need to, when we want to go towards interdisciplinary practice and we want to be accountable, we want to be visibly doing our work and we want to enhance our image, we need to strengthen our own disciplinary knowledge, and then not just that, and we need to, we should be capable of transacting with the other professionals. So what are the tools for success? Respect and trust between team members, best use of the skill mix within the team. Everybody may not be having the same type of skill mix, but if you look at for a successful surgical outcomes, the surgeon alone is not enough. The best circulating nurse, best sponge nurse, the pre-operative preparation should be good, the post-operative care in the ward should be good, the post-operative nurse should know what are the things, and above all the health means what do you call housekeeping team, they should follow the right kind of environmental cleaning, and then the outcome will be best. So the skill mix vary between the team, and everybody should everybody's capability should be used. Agreed clinical governance, agreed system for protocols and for communication and interaction. This is majorly missing. So what nurses are not empathically communicating, and assertiveness is lacking. So when we are able to communicate effectively, that's very, very essential for interdisciplinary collaboration for practice as well as the research. Valuing diversity of skills, clear vision, role and purpose of team, role socialization and clarification. For this, the team can have like if you cannot sit together and have a cup of tea, how can you work as a team? That is what Winston Churchill has asked sometime when I was reading some of his work. So we need a type of socialization and then power sharing. That is other essential things. What are the pitfalls? New members are confused. So when you are put in a team, new members get confused what is expected of them and what they can expect from others. Increasing conflict between team members. Crises arise when everybody assume that someone is responsible for the crisis situation. Everybody should take equal responsibility. Then what are the challenges? Team decisions are not carried out effectively, not given sufficient autonomy. Members remain rooted in their same discipline. I want to be holding on only, I will carry what nursing text says, what this is the right, I will do only this. If everybody is in a case, so we cannot, we can be only bundles and we can only tie together. We cannot make a blend of nicely blended coffee, make a nice, all of you also will be looking for a nice coffee with the aroma. So there is a clear blend. So that is what is not available. Then what is interdisciplinary? How do we define interdisciplinary research? Any study or group of studies undertaken by scholars from two or more discipline, distinct scientific discipline. The research is based upon a conceptual model that links or integrates theoretical framework from those disciplines, uses the study design and methodology that is not limited to any one field, and requires the use of perspective and skills of the involved discipline throughout multiple phases of the research, starting from conceptualization, planning, implementation, data analysis, finding, dissemination. Every phase throughout there should be a coherent group communication. This is what is defined by Abio Lila in 2006. So what is facilitating interdisciplinary research? So how can we facilitate integration of information, integration of specific discipline assessment, collaborative assessment and diagnostic process, collaborative plan of care, understanding teammates' role and measurable outcomes. So what are the factors now motivate interdisciplinary? So a few years back, there was no interdisciplinary. The concept of interdisciplinary research is evolved in say 20 to for the past 2 decades probably. So there is a liberal education, professional training, social, economical and technological problem solving, faculty development, financial exigency and production of new knowledge. All this are all motivating factors to do interdisciplinary research. So what are the preconditions for interdisciplinary research? The object of the study must be multifaceted. If it is a linear and it's a single faceted, and this problem can be handled by one single discipline. So it is essentially need to be multifaceted, and the problem multifaceted, not just multifaceted, but if it is not, there is no connection between the facets, then again we cannot use the interdisciplinary research. So if you want to do a interdisciplinary research, it should be the problem should be multifaceted. For example, childhood obesity is a common problem now. So if you think about childhood obesity, there is a genetic component, there is a nutritional component, there is a lifestyle component, there is other aspects of dieting habit, the social aspect. So so when as a nurse, when we want to do something about it, so but all these things can be from different angle, it can be approached, and so that the solution can be found out. So such problem can be taken up for interdisciplinary research. So the problem should be multifaceted but coherent. So there should be a connecting wire between the different facets. To understand the phenomena, insights from different disciplines and integrated insight is needed. When the problem is linear, the insight from one discipline is enough. So integrated insight is needed. Then only we can go for interdisciplinary research. In the interdisciplinary research, we have different typologies so as you all know, interdisciplinary research, there should be more than one discipline is involved. But some, they say multidisciplinary research, we say interdisciplinary research and transdisciplinary research. They may look like synonymous, but synonymously may be used, but it is not synonymous. There is a distinct difference between the three. So when we say multidisciplinary research, the problem statement. So the two people, essentially 2 or more discipline people are involved, but the paradigm, the same question but different paradigm, or different but related questions. And the research style is parallel play. So you do your work, I'll do my work. So there is no, say for example, research conducted on a specific aspect. A doctor who is good at the clinical trials, carrying out the clinical trial aspect, and the nurse who is good at qualitative study, she carries out that aspect of research. So they together they may be working on it, but there is a distinct parallel play. The presentation of findings, separate publication by participants from each discipline. So these aspects all together will not go in for the publication. That's our presentation in a conference or so forth. That is multidisciplinary. Some amount of oil water phenomena exists. There are the 2 or more discipline people are involved, but there is oil water phenomena you can see. That is multidisciplinary research. Interdisciplinary research, here again 2 or more distinct academic fields are involved. The problem definition is described or defined in language of at least 2 fields using multiple models or intersecting models. And research methods are drawn from more than one with multiple data source and varying analysis of the same data. So all the researchers involved, scientists will be pooling the data, and all the data will be analyzed and used as one. And findings are presented in a shared publication with the language intelligible to all involved fields. So a nurse is presenting a scientist, and her findings will not find a place in a medical medical journal. Then not like that. So it will be a shared journal. Involved, all the involved fields, it will be appreciated. Then what is transdisciplinary? It's a research style fully synthesized, like a blended coffee. Like there is no milk separately, no sugar cannot be identified separately. Then the coffee also cannot be identified. Together make the blended discipline. So synthesized method stated in new language or theory that is broader than any one discipline. The presentation of findings, shared publication, probably using at least some new language developed for translation across different disciplines. So novel it also, we have seen about what is interdisciplinary research and interdisciplinary practice, what are its uses, benefits, challenges. Now we will go into the steps as propounded by Novel in 2001. So he is clearly giving two phases, drawing a disciplinary perspective and then integrating and bringing insight into the research problem. What is the drawing of disciplinary perspective? Defining the problem, question, issues or something, then determining relevant disciplines, interdiscipline school of thoughts, developing working command of relevant concept, theories, methods, and gather all current disciplinary knowledge. For example, knowledge about obesity in nursing literature, knowledge about obesity in nutritional perspective, knowledge about obesity by the endocrinologist, knowledge about the obesity and childhood management by the pediatric nurse. So like that. So all the individual disciplinary knowledge and information is gathered. The gap can be identified, studying the problem from the perspective of each discipline and generating disciplinary insight into the problem. Then integrating them and construction of a more comprehensive perspective. Identifying conflicts in insight by using discipline to eliminate each assumption. Sometimes our perception, our perspective may be ill understood by some other professional. So from each professional point of view, the conflicts of identifying the conflicts, and we resolve it and by communication, common vocabulary, and create a common ground, constructing a new understanding of the problem, then producing a model, metaphor, or theme that capture new understanding, then testing the understanding by attempting to solve the problem using the research methodology that is synthesized or not parallel. It is a commonly drawn from all the different disciplines. So this is how the novel has described the steps of so what are the major competencies needed for interdisciplinary research? So if you want to conduct interdisciplinary research, just like that, it may be sounding very good. I'm sitting across the table along with the pharmacist, a doctor, or a cardiothoracic surgeon, a rehabilitationist, a cardiothoracic physiotherapist, an occupational therapist, and so many other different professionals. You are sitting across, and you are, so it looks grandeur. But there is a fear. There is a fear. We will be losing our identity. How to convince others? So if you want to be a member in reality in the multidisciplinary team, you need to have, these are all the commonly identified competencies. In conducting research, you have to be capable of using theories and methods of multiple disciplines, not just clinical trial alone, not just qualitative study alone. So in the qualitative, in the social scientists, when we are thinking about interdisciplinary team, we are thinking about just doctors, physiotherapists. The team can be including a social worker, it can be a sociologist or can be a counselor, and many other different discipline people. So their methodologies we need to understand. Integrate the concept and methods from multiple discipline, designing interdisciplinary research protocol. Investigate. So you need to be capable of draft funding proposals for interdisciplinary partnership with the scholarship from others discipline. So it is not very easy. So many people sit together. So there should be some scholarly outcome should be there. There should be some merit in it. So for that, you need to know how to draft funding proposals. And while conducting research, disseminate interdisciplinary research results both inside and outside his or her discipline. So you should be capable enough to go and address in a physicians conference, surgeons conference and the meeting, and you need to be capable of presenting your findings. Then author publications with the scholars from other discipline, advocate interdisciplinary research in developing within a substantive area of study, express respect for the perspective of other discipline. So while conducting, you should have these all scholarly skills. Then communication. You have to read journals outside of the nursing alone. You need to study wide range of journals so that your understanding is wider. Communicate regularly with scholars from other discipline. Share research from your discipline with the other discipline team members. You should have that. So in nursing, we are very much capable. We are nurses. As nurses, we are having enormous capacity. We are versatile, I would say. The creativity, the scholarliness, everything is there, but we have to be able to visibly, explicitly demonstrate it out. Then we can, and I think we are moving towards that. I think very recently, Dr. Tanya Mal and my student, the previous speaker, Dr. Gopi Chandran, has done interdisciplinary research in collaboration with IIT Roorkee. I think he developed a mobile application whereby the palliative care is improved outcome in prescription of analgesics, and so like that it is all coming up in India also, but only in the Pioneers and Center of Excellence it is coming up. Probably we need funding and other understanding of and improving our own platform. That is what Dr. Tanya Mal is doing now, trying to elevate the standard where we are standing, how we are, what are our goals, how we can raise our platform, how we can move upwards, and she is showing the pathway. So I think the very many scholars, the future pillars of nursing are going to take up these ideas in a great grand way, collaborate with the doctors, not like a puny or without less knowledgeable, not respected. Your knowledge is power. So you should be able to read their journals. What is the latest pathophysiological concept? What are the latest concepts about genetic identification or newer methodologies or newer treatment modalities, evidence-based protocols, what their discipline is saying, that also we need to study. Only then we can improve and our voice will be heard. Present interdisciplinary researches at venues representing more than one discipline. That is what is very much needed. Shouting among ourselves within, so it is like locking within a room and shouting. People will think we are all fools. So we need to go to a space where we can talk sense. That is an essential competency. Interacting with others, engage with colleagues from other discipline, attend scholarly presentation of members, collaborate respectfully and equitable framework. And these are all some of the competencies, 17 competencies identified in the literature review. And I think I have to add that in the review, reference column, very beautiful references. And a few I am left out, I'll add it. Then when you conduct research, describe an important health or healthcare problem. So I think we all have learned a lot about it. Let me go to the exemplar. This is a exemplar where the interdisciplinary palliative care of patients with lung cancer is being published. And this I found it very interesting because the study has been very promising and it has given out very good results. So this is published. This is the interdisciplinary palliative care of patients with lung cancer, published in 2015 by Farrell, Betty, Sun et al. In Journal of Pain and Symptom Management. Here in this study, the stage 1 to 4 non-small cell lung cancer patients are included in the palliative stage, and they have done the interdisciplinary team comprised of, this is a research done for 3 years, and the nurses, palliative medicine physician, thoracic surgeon, medical oncologist, geriatric oncologist, pulmonologist, social worker, chaplaincy, dietitian, physical therapist. So these are the members of the interdisciplinary team, and these interdisciplinary team have sit on, and their idea is to improve the quality of life of patients with the small scale, non-small scale cell lung cancer. 139 interdisciplinary team meetings have been studied. This is reported in the research article which I have given. You can also go through that. Very wonderful. 139 interdisciplinary meeting. The case studies are individually sit, and every meeting was lasting for at least 20 to 30 minutes. So there is a clear ideas are shared between the team. The interventions are educative interventions, and all these are all designed by the group members together, and the nurses are the ones who delivered it, and they have found in the psychological distress have enormously reduced, and 12 weeks each patients were followed up for 6 months, and they found this psychological risk is reduced a lot. Functional ability has improved, and they are LAC, lung cancer subscale. So they are this another functional ability. Using that also they have found it very useful, and the median survival rate using Kaplan-Meier survival estimates for stage 4 patients according to the treatment group, there is a marked improvement in the survival of the patients. They have found the marked improvement in the survival of the patient in all the 4 domains: psychological distress, the functional ability, all that have improved at p less than 0.001 level, high level of increase. And they have found actually nearly 572 patients have been enrolled for this particular study, with 213 patients participating in the receiving the intervention, and the rest of them are in receiving conventional care intervention. So they have found out the usage of services was very high in the intervention group, and they have found the survival also is improved. So there is a satisfaction in each one's. See, it is like patting the getting a pat appreciation from somebody for the good work done. So it motivates. So it is not just motivating, it is also you are getting insight, you are getting appreciation from others' perspective. So that is what is very, very essential. So this study is found to be very, very useful. So from my perspective also, I have seen we have designed a study where we wanted to do a study on supplementing. It's a multidisciplinary research, you can say. It's not interdisciplinary research, it's only a multidisciplinary typology, where one of my student who wanted to do a study on how manually delivered hyperventilation and mechanically delivered hyperventilation is maintaining hemodynamic stability, and how does it improve the quality of life. So in this research, when we went for a discussion with the cardiothoracic surgeon, and we were all happy with some pulse oximeter and hemodynamic parameters like pulse, mean arterial pressure and other things. But he was one who was telling, like the inputs were very helpful. Like he was telling you can go for PaO2 level, and PaO2 level only can give you very good difference, and demonstration of difference can be true workfulness of the intervention, or the difference between manual and mechanical hyperventilation can be helpful. So when we get inputs from the others, you can, and the same way you have to also give inputs to other discipline. That is what is the interdisciplinary. So when we only in the receiving end, we stay in the multidisciplinary paradigm. You want to go to interdisciplinary paradigm, you also should be capable of strengthening nursing discipline and giving out from our discipline. So nursing is hardly 100 years old, whereas the medicine and pharmacy and all well-established professions, the collaboration between them are very high. For that matter, even engineering is very high. But now in the interdisciplinary perspectives, we are including the humanities, social studies, psychology and other people also. And we have to be giving out from our discipline, and we should shed out the fear of losing identity. So nursing value doctor credit. So such thinking should go away, and then you should be able to have a shared goal, shared publication, and that will be the way forward in the days to come. And wish you all good luck in your journey to interdisciplinary research. I hope this group of scientists, young, novice, budding scientists, listening to me, listening to the experts before me, will be definitely taking this forward to strengthen nursing, and it will be definitely a road to excellence in nursing. And wish you all a great day, great learning ahead. And I want to thank you, Dr. Tanya Mal, from the bottom of my heart for this wonderful opportunity to share my thoughts with you, and nice of you. Have a great day. Thank you so much for your valuable time and for your listening. And if there is any queries, I'll be happy to answer you. And thank you once again. Thanks. With this note of thanks, I would like to conclude.
Thank you so much, Madhu. So it is the toughest job of all nurses, but we need to, as per your suggestion, so we need to update our field and the others field where we are going to mingle with. So that is very important. Otherwise, no, they may not accept to gel with us. So that is the issue. So that we have to develop our own strength and in the other field. Then only we can able to confidently, we can deal with people and we can share with the things. Then only they know what is the value of nursing professionals and what is the contributions they have. Otherwise, no, we have to prove ourselves to withstand our image. So that is because it is struggle. Because as very rightly you told, the engineering and then as well the pharmacy and all, they have a lot of funded projects and interdisciplinary projects, and they are taking up even the medicine also. So to some extent they were not cared for, only they used to care for the people and taking care of that doctor's profession, practice like that. But now there is a force and they want to go for the ranking, and they want to go for all are interested now in all the medical. No, they cannot able to simply sit. So they have to do, and now they are having pool of ideas, and they are also ready to take up. But here in SRM, so actually the medical college and the engineering college, we have a different discipline, and the people now only we are working through with various discipline which we can able to incorporate development of app, and then how maybe the clinical trials. So with the microbiology department, so all are very, very good and supportive here. But we have to outbreak. So what exactly you told, within wall we should not shout within ourselves. So that is exactly, I enjoy that, because our people, we have a very small circle of round, and here only our thinking, and then dragging, pulling, pushing, and everything it is happening. So that's why the nursing is not coming to the limelight. So exactly you quote that example. Really, you are great, Madhu. So yeah, so that is very important thing. We have to realize it. We have to come out of the barrier line. Then we have to interact with people, and we have to update our knowledge, and we have to jointly, collaboratively, we have to work. Then only we can able to get this kind of interactions and collaborative researches and all. It is a very tough job only, but we have to outbreak. So this is what I need of the hour. Yes.
Yeah, I think to start with, first let us work with our counterparts in the hospital.
Yes.
Nursing service personnel. We have to collaborate, and then we have to collaborate with the professionals or our own nursing colleagues outside. Multi-site trials we can do, and then we can next move with the discipline, other disciplines. Like we have to move. We are not moved apart from doing research for the sake of MSc or PhD. We are not conducting many research, and since now UGC wants us to publish in journals, we are conducting some more research. Otherwise, we have to have true interest to improve upon our own self. And overall, as nurses, the personality aspects, even including physical appearance, the way of conducting ourselves, the way of commanding language, the way of commanding the subject, and all this all together helps us to grow better.
Yes, that's what. Now it is budding. We are in a budding stage, but anyhow, we have to go into the blossom. There is a long way, but anyhow, we will hope for the best for all of us, and then we have interactions with the collaborative within our discipline. I know. So because the integration and then the service side, they go in different way and we go in different way. That and all, it has to, we have to bring the gap, narrow the gap. Then only, and we have to, equal understanding we need to have within ourselves. Then only we can able to interact with other disciplines. So that is very important. And we are also trying for that, getting into gel with the service side, with through planning of integrations and taking up some of the committees and developing protocols like that. We are just now we are bridging. So slowly we will move further. Definitely nice presentation. It's very essential and vital part where we are in lack, and we will improve. So now this 2 days conference will give a lot of input for all of us, for the students and for the faculty and for the resource persons who are all presenting excellent from morning till all the speakers. I believe all they will give their own justice. So like that only we have selected people. So we are enjoying that. Thank you so much, Madhu. God bless you.
Thank you.
And, and your family, convey my wishes to your family, and take care of your health as well. Thank you.
Thank you so much for all of you and Dr. Tanya Mal.
Thank you, Madhu.
Thank you, ma'am, for enlightenment and also the wonderful presentation on this interdisciplinary collaboration on research. You were witty and the session was very informative. I personally like that set concept. Okay, on behalf of organizing committee, we would like to present a small token of appreciation. Thank you, ma'am.
Thank you.
I would like to invite Dr. Kavita, Professor, Department of OBG, SRM College of Nursing, to introduce our next esteemed speaker. Ma'am, please do the honors.
Thank you, Mrs. Megla. A purview of commendable achievement of our respectable speaker of this session. Here I am to introduce our honorable and eminent professor, Dr. C. Tanya Mal, the Dean of SRM College of Nursing, SRM Institute of Science and Technology. Madam has graduated from Madras Medical College, Chennai. Madam is a postgraduate from Savita College of Nursing And Madam pursued Doctor of Philosophy with highly commendable appreciation from Sri Ramchandra University in the year 2007. Madam has got vast experience in the nursing profession, total 36 years in both academic and service, inclusive of 10 years of ongoing administrative experience in our esteemed institution. Madam has collaborated with international colleges, namely University of Wisconsin, Oshkosh, USA in the year 2007 and University of West Trollhättan, Sweden as part of the faculty exchange program since 2019 respectively. During this tenure of faculty exchange program, Madam holds the pride of initiation of 8-year Linus Palm project in the year 2019 in collaboration with University of West Trollhättan, Sweden and SRM College of Nursing, SRM IST. Madam is a laureate of the prestigious notable award, Dr. Abdul Kalam Gold Medal Award in the year 2017. She is also a recipient of many notable awards such as Best Researcher Award, Best Teacher, and Best Educationist Award in the year 2007, 11, and 2013 respectively. Madam has guided many PhD research scholars pursuing under National PhD Consortium INC and Meha University, Meenakshi Academy of Higher Education and Research. Currently, Madam is guiding 8 PhD scholars that have enrolled under SRMIST. Madam has published 36 papers over in the indexed international national journals and presented 100 over papers and attended 150 over conferences and authored 2 books and 2 monographs. Madam holds membership in Nursing PhD Society and life member of Trained Nurses Association of India. Madam is also member of prestigious Sigma Theta Tau International Honors Society of Nursing, Itapai chapter. With these brief commendable achievements, I welcome our Honorable Dean, SRM College of Nursing, to deliver a session.
Thank you, Kavita, for a brief about me.
Thank you.
Yeah, thank you. Now we'll share our screen. So very warm good afternoon to everyone, all the participants. So really I am delighted to present about the title Academic Nursing Leadership Shaping the Future of Nursing Education. It is a very big challenge in front of the administrator and then the educator. So the topic, so which it will give some highlights for the teachers and for the students, how to go about to meet the challenges in future. So the highlights of leadership, but in particular the academic leadership, what are the challenges we are going to see about and the qualities, how far we need to go about. And the second objective of the presentation is proposed changes in nursing education that reflect the curriculum, so particularly the research finding, and then how we are going to put the collaborative researches and the conducting various and implementing, everything is a challenge for us. So that is what. And examine the concept of excellence as it relates to the nursing education, in particular, in future, in 21st century. Describe the leadership skill needed by the nurse educationist and how to shape for the preferred future for the forthcoming nursing education in the 21st century. So these are some of the 4 broad objectives under which first, so everyone knows what is the leadership, what does about actually mean. The actual meaning is, so that actual meaning here, it goes so that it is leading the group, simple meaning. So it is leadership means only leading the group. So simply we know, we understand. But going beyond to that, it is from 14th century. So it is there from the, even in the traditional period also we have. So this kind of definitions it goes, the leadership qualities, what are the important qualities they need to have. They mention about various things. So now move on to next slide. So here, so crisply by Arthur, so that what the leadership means, it is the most observed and least understood phenomena for everyone. It is most observed. He is a good leader, he is a bad leader. So like that, we are just telling, so that we could not able to explain that phenomena in a correct way. So that's why it is very difficult. And the author says it is most observed, the least understood phenomena on the earth. Leadership is about making others better as a result of your presence. So like that, it is simply defined by many authors in various ways, what it means. Let's move on. So here, the task of the leader. What is the task? So we have to envision the goal of any educational institution where we are and how about we are going for. We need to have a vision, mission, goal, and values we need to have as being a leader, representing the group, motivating, managing, and explaining, serving as a symbol or an inspiration, achieving workable unit. So, and renewing if necessary. So these are some of the tasks, general tasks. What really the leaders do? So oriented towards the future. So leader is one who knows the way and goes the way and shows the way. According to Maxwell, John Maxwell. So it is simple meaning as what defined by what is the leader. And she or he needs to orient towards the future, social architects, comprehensive, gifted generalist, integrative thinker, educator, developer, generator, translator, and theory or research action oriented, trustworthy. So various meanings. And so above all, they need to have a vision. First, the vision is very important, clear vision and inspiration and managing ups and downs and develop and renew the followers. So these are some of the important things the leader should have as a qualities. So the leadership and management are two different confusing terms for all the time. So which is best? So this is what? So he is a leader or he is a manager. So this question all the time it will arise. So this picture you can very well see about this. So that leadership. So here, so the Abraham Lincoln and then Gandhiji, they are the national leaders, but the management, see here. So it is little difference between the leadership and then the management. So we need to know clearly what is the difference between. So then only we can able to, how the academic leader can able to function effectively. So this next slide. So the leading and managing. So the overlapping domain. So both need to have their own accomplishment of the goal, explain their vision, and organization of the figurehead, motivate others, and mobilize resources. This is common core area for leading and as well for the managing. But if you take leading, the vision and strategies, creating values based on the goal, they have to prepare and influence and inspire the followers and leading people and charismatic style, risk taker and change seeker, appeal to the heart. And leader always need to be a proactive person, set directions and raising expectations, asking questions. But on the other hand, if you go for the manager or managing capacity, need to develop the policies and procedure and counting the value, power and control in their hand and have their subordinate. Here the followers in leaders, but here the subordinates manage the work and then authoritarian style. Here it is charismatic, inspirable. So it is some flexible leadership style. Here authoritarian. So these are some of the notable differences. Here leader is proactive and the manager is a reactive person. Plan in detail and maintain status quo and give directions, somewhat authoritative, the work to be done. So that is a mere difference between the leader and then the manager. Yes. So the manager do right things. Manager appeal to the head. They are working along with the head. Yes. Next, leadership. It is do things right. Here, do the right things, and here, do things right. And leader work with heart. So these are some of the difference. What is the leader and then the manager need to have. Remember, not all managers are leader, and not all leaders are managers. It is very difficult. A good leader cannot be a good manager. So that's what we need to go for, have a traits. A good leaders have a lot of umpteen number of more than 30 traits. It is exhibited over here. So everyone is not acquiring all these things, from self-motivation to self-awareness, self-discipline, patience, resilience, accountable, like various things are there. 1 or 2 repetition, the empathy is repetition, and one more is repeated. So totally more than 30 traits a good leader should have. So whether it is questionable. Next, following slide. So here, how to improve the leadership skill. As being a leader in any academic situation also, you need to think about how to improve your leadership skill. Engage in honest, open communication. So that's the first, foremost important. Connect with your team members. Encourage personal and professional growth. Keep positive attitude. Teach employees instead of giving order. So set clear employees' goal and expectations. Give direct feedback about performance. Ask for feedback on your leadership style. Be open to new ideas. Understand your own motivation. So these are some of the very important the qualities, traits we need to have to become a good leader. The qualities of a leader. So again, it goes this way: honesty, efficient communication, knowledgeable and consistency, visionary outlook, selfless, courage, and willpower. So these are the important qualities any leader should have. Yes. What is the 5 important qualities for an effective leader? So here they need to have a clear-cut vision, able to turn big ideas into the executable plan of ideas within the team. So that is the vision they should have. And humility, seek feedback and focus on the need of others. Integrity, has strong values, belief, ethics, and characters. So, and again, confidence, stay calm and confident, helping their team to do the same. And commitment. So build trust by doing what they say they will do. So it is the consistency and commitment. So these are very important qualities to be an effective leader. Yes. So here the self, if you take a personal qualities for a leader, they need to have their own personal qualities are self-belief, self-awareness, self-management, drive for improvement, and personal integrity. This is the core. In order to achieve the core, first leading change through people. It goes from this way. So it is this arrow from here, leading change through people and holding account, empowering others, delivering the service, effective and strategic influencing, collaborative networking. This is coming under the phase of delivering phase. And here setting directions is another thing. You have the political affluence, drive for results and political affluence, broad scanning, intellectual flexibility, and then seize the future. So it is a cyclic process. In core personalities we need to have, and we need to go for delivering the service and setting directions for others. So these are some of the important qualities and traits the leader should have to become effective. Yes. So which type of, there are various types of leadership style. So already we know autocratic, visionary, affiliative, democratic, path setting and coaching leader. So among this, we can select what kind of leadership we can have. And sometimes some situation, it differs. Based on the situation, we need to have 1 or 2 leadership style. Alternately, we may use. So that's what we need to know about what is the style and where the people will act in different style. we need to know. Yes, analyze it. And here we have some 4 important leadership style. It is discussed here. The dominant leader, the leadership style is very strong and direct, giving directions. Do what I say. So that is the type of thing. And influencing leader, so inspiration. So after seeing the person, the people, the followers will inspire the leader and persuade and do with enthusiasm. It influences with the inspiration of the leader. The followers will carry on the exercise. So here the supportive. So the supportive leader collaborate and support with the followers. And caution. So here the leadership style focus the problem solving and decision making. So that very cautious planning and implementation and decision making, everything. This caution type of leadership style will teach you to go about. In particular, to coming to nursing leadership, 5 common style of leadership can be brought into. So for example, the demographic leadership, when we are taking, so participate in all decision making, the employees. So the subordinates will participate in planning in all the decision making equally. They used to participate. But if you go for transformational leadership, it is inspire and motivate the employee to create change. So the leader is giving direct suggestions or inspiration, or they follow as per the leader's inspiration. They motivate the employee and create the changes to reach the goal. But here another one, laissez-faire leader, employees are encouraged to take charges. And equal, the leader and the employees, they are you take, you do, like that. They full freedom they give, no compromise or no directions or anything will be. But here the servant leader, so here the employee's focus is more top priority. We have to make the employee happy. So that is the leadership. Only goal they have that. So that is leader, servant leader type. And affiliative leadership here focus on conflict resolution. And it is almost regarding that cautious leader. It can be comes under this. And to any conflict if arises, how to resolve that and aim to create harmony. So how to resolve and how to create a harmony within people. So this is the affiliative leadership style. So this style in a nursing situation, so anyone or in combination, the nursing leader will be utilizing either in education sector or maybe in the private sector, practice sector. Yes. Move on. Now the concept, the newer concept is transformational leadership style. It incorporates knowledge, experience, and coaching. So in all 3 angles. And it includes a little bit of everything. So it is a combination of. So that's what it is, a new trend. So this is good for giving a good outcome based and dealing with people, how to lead. So this is the recent trend, transformational leadership. So here the vision, you have to develop a strategy and communicate and model the vision and build commitment to the vision and business success. So like this cycle, it goes on repeatedly in the transformational leadership style. Yes. So here, if you take for academic leadership, coming to the academic leadership, so here the mission and people, with the people, we have to take fix based on the vision, we have to fix the mission. And the mission, it has its 4 angles. So how to develop, how to inspire and understand and invent. So here the developing leadership development, team development, pilot project and early wins. So these are some of the prerequisites. We have to develop a good leader in any of the academic institution. That is in other countries and all, the leadership development program or workshops regularly conducted for faculties and other people. So these are the thing. And here inspire. So here under that, identify the need, vision, engaging and motivating. So that is the one, it should be first we have to identify the need, the inspired leader. So we'll identify the need of vision and engaging and motivating the employee and leading to understanding. When the understanding means we need to analyze the culture, climate, everything to be assessed. Then you go for a team workshop strengthening, or inventing in strengthening of their exploration and growth of goal setting, everything. The followers, the leader and followers as a team, it has to be developed. Invent in terms of workshops. So they have to develop their skill. And then again, it is a cyclic process. Based on the mission, it may change. It is ongoing in an academic area. Yes. Move on. So here, effective academic leadership profile have a core of academic capacity, leadership capacity, and style of the leader, and then personal, interpersonal capacity. This is a core. And if you expand to this academic capacity, you need to improve in the research credibility, reputation, community services, resource acquisition, and institutional reputation. So these are some of the points to be covered under the academic capacity. You need to improve in this area. And leadership capacity, so need to develop the leadership competencies and managerial skill, team management, culture-related skill, everything to be improved to enhance the leadership capacity. If you take this style, we have seen already, the conscious leadership style, transformational, democratic, and laissez-faire. All it is there. We need to understand in which situation we can use what kind of leadership style. And now the current trend is somewhat to achieve all the target, the transformational leadership will be most suited for. So that is the trend where it is in academia now. So here the personal interpersonal capacities we all know. So that we need to influence and communication improvement, conflict resolution, self-regulation, empathy, commitment, and decisiveness in taking decisions, everything. These are the personal improvement, personal and interpersonal capacity improvement. So in order to become an effective academic leader, we need to develop in all the way. So this is the leadership in academia. So one of the study finding, it have become depicted in this, the reference, the establishment of world-class research university, they require strong leadership is very important. They need to have a vision. And based on that, articulate the procedure to implement the program, whatever may be the program, strong leadership, and they need to develop the vision and then go and implement to achieve the outcome of the program. So this is what the importance in leadership, the capacity to release and engage a human potential towards the common cause. Academic leadership style, it is diverse. According to the culture and purpose, expectation, different institutions in the academic leadership, they follow their own style. And implementation of the vision. So here active engagement and stakeholder and empowering them to achieve the goal. So these are some of the hints how to take up and what kind of leadership. It may differ from institution, from individual. They won't, according to their own past and own ability, they follow. And the situation also, it promotes the leadership style in different way. Yes. Move on. So the function, overall, what are the function of the leader? Defining the task, planning, briefing, controlling, evaluating, motivating, organizing, and providing an example how to lead with. This is what previous presenters also, how they were very much, we have to, even for the translational research or evidence-based research, everything as a leader, we need to promote them in this various phases where they are, and we need to achieve their goal. So this is what the leadership function. Yes. So here the system in place in education has played a remarkable ability to take the appearance of any number of reforms without changing in any substantial way. We have not yet learned the fundamental lesson. So this is the one we need to analyze it. Yes, move on. no substantial changes can occur in the education without substantial change in thinking of the educator. First, the educator need to think what is the change, substantial changes in what kind of, for example, if the COVID scenario, immediately the educator, how the students can be given a lecture or maybe the practical skill. So immediately we have to accept change and we need to modify our way of teaching and to get the benefit for the students. So immediately the educator is ready to take the substantial change and then only rethink and implement, and then we can bring into the outcome. So these are some of the things the leader. So substantial changes in thinking for a nurse educator act as a leader, and she has to strive for excellence and need for expertise. So these three, leader and excellence, expertise, is needed even in academia. It is very important. Dealing with the education. Yes. What changes are needed in nursing education? How to best prepare the graduate for an unknowing future? Yes, move on. The changes needed in all aspects of the academy are evidence-based teaching strategy, practices, science of nursing education. So it is through research, and ensure all the faculties are prepared as educators to some extent. Curricula are relevant, flexible, and evidence-based. So here, so our Indian Nursing Council is giving the minimum requirement. The flexible and relevant evidence-based, we can able to modify a little bit, but are not reducing that content. So that is what the flexible curriculum should be there. And challenge of the students to think. So involvement or participation of the student is must. Develop effective, meaningful, interprofessional learning experiences. It is needed. And attend more to broad social issues. So without knowing this, we cannot implement the curriculum or a syllabi. So these are some of the important things we have to notice. So coming to the evidence-based teaching practice and science of nursing education. So here one study report, it has become in a systemic review. They have analyzed the report of Medline, Embas, Sinhal, Eric, and academic research premier. So 6 qualitative studies and 1 mixed method study have been taken, totally 7, under which 4 teaching strategy themes were identified in the qualitative studies, 4 under that. So interactive teaching strategy and interactive and clinical integrated teaching strategy, learning outcomes, and then the barriers. So these all elicited in the qualitative study. And the learning outcomes are here analytical critical skill and using research to ensure patient safety. And the barriers identified are the challenges and then limited awareness of evidence-based practice principles and poor information literacy. So these are some of the barriers. So yeah, the reference is quoted over here. So while going for a teaching, even the new methodology, very thing we are talking about, how much it is implemented, it is a very big question. So the systematic review, which we have seen, is the top one. So that is a very good analysis we can bring into. So that's what now it is given. It is the least filtered information we can gain through this, but it is the most filtered. So the correct information through reviews, systematic reviews. So these are under the top. So here all other things are somewhat lower than this, qualitative, simply quantitative, cohort studies. Then about this meta-analysis and systematic review, these two are having some more valid information and filtered information with analysis of published studies will be giving good ideas how to implement the strategies. Yes, move on. So here best practice for the teaching online. Now it is a challenge now. Everyone talk about it is a challenge. So here teach for online students. What are the things the students should need to have? Orient the students to be on the for the online courses and motivate students by making a real world situation, because otherwise it will be very difficult through online or e-learning. Instructor pressure to complete in time and clear expectations. Learning objectives should be very clear, prompt feedback, and engage the students in an effective way. So these are some of the important core areas in order to provide an online or e-learning best practices for the teaching online. Due to COVID, we all are we are experienced. It is the need of the hour. And here in future also, we will have incorporate this kind of online learning. So it is the need of the hour. In future also will be like that. Some different learning we need to adopt. Yes. Move on. So here it is coaching and supporting teacher is the core. So constructive and active learning will happen if the teachers are coaching and supportive to the students. And then evaluation. So here the study 1 and study 2, it says in a study 1 finding self-directed learning about the clinical nursing skill. Here the flipped learning or hands-on nursing care. So how far it is working through the virtual learning environment, and here link education through working life. So how it differs, everything is interrelated to improve the learning environment. So it is one model which it is for the online, how it can be improvised for the students to learning the skill. Yes. So the clinical learning environment. So you still more, this model give more information. So it is interactive, cognitive, behavioral, emotional centered learning. It should be. For this, we need to have all these core: active learning and student engagement, diversity of experiences and shared learning opportunities, student faculty interactions. So these all under this various subtitles are given. You can go through it later on, you can understand. So I cannot read everything. So we need another areas to be covered. So evidence-based teaching practices since science of nursing education, we have a model. So 5-step evidence-based practice model: audit, apply, appraise, acquire, and ask. So here, sorry, the cycle goes this way. It is, I start from here. So here, ask, first you have to assessment, clinical decision. If you want to take any clinical decision on evidence-based practice or putting your research finding into the clinical areas, you have to go for these 5 steps. First, you have to ask, convert information need to be answerable in the clinical question. If, for example, if you go to the clinical area, if you ask some kind of question or arise question from the patients or the caretaker, then you need to ask many questions. From their questions, we can, what kind of studies can be applied, and track down the best evidence of answering questions. You have to think, analyze it. Then you can able to, which kind of study finding can be applied on that. Critically appraise the evidence for validity, impact and applicability. We have to appraise it. So you may have various study finding. Which one here we can able to apply or appraise. So you need to analyze it through the 5-step. Then finally, you are going to implement your research finding on the clinical ground. So this is what the evidence-based teaching and teaching practice at the bedside. Ensure faculty are prepared as educator. Here, first facilitated learning, facilitate learner development and socialization, assessment, evaluation strategy, and participate in curriculum design and evaluation programs of outcomes. So these are all the important steps when we are preparing the teachers as an educator. Yes, for a new program or new syllabus, whatever it might be. Ensure the faculty, as it's continued, the same, it is a repetition along with some change agent and leader. So here, the educator should function as a change agent and a leader. So this is the crutch we need to know. And we have to pursue the continuous quality improvement techniques. So that is also important. Ensure the curricula are relevant, flexible, and evidence-based. All the time, we have to check through if we want to practice the evidence-based. Do all students need to go through the curriculum? So all it is questionable. Theory and clinical need to be happen simultaneously, and enough elective experiences to meet the solution or the unique need or interest. So like that, when we are, so here as per the choice in other countries, they are giving, but here we follow the standard static norms of the Indian Nursing Council. The council is giving a static syllabus, and beyond to that, some additional courses. If our university is providing, that is no harm. But we have to stick on to the Indian Nursing Council syllabus. Here, choice-based curriculum we are not following. But in other countries, these kind of syllabuses are implemented. In future, we will be in India also, it may come. Yes. Now, from next year onwards, the syllabus is going to change for the BSc. It is a semester pattern, 4 year, and credit-based systems is going to be introduced. It is a challenge for all the teachers and then the students as well, and for the administrator. So these all the thing, it is the trend and future challenge we have to take up. Okay, let's move on. Next. So here, when we are challenging, the challenge to the student is to think. We have to balance the challenge and support and implement the art of questioning and radical candor. Here means the participative learning only, it meant. Because the children, the challenge from the student side, so they are asking question means the teachers are ready to give chance, to provide chance to ask question. There are many examples. Our Indian culture, the students, when the teachers are taking, the students cannot able to ask question to the teachers many a time. So very few teachers only, they are permitting the student to ask their doubts, clarify their doubts, ask questions. So that under my own experience, one of my student in Savita, when I was a teacher, I used to permit the students when they are asking question, even in between also, I used to permit and I used to allow them. But many a teacher will not permit. Now that particular student is residing as a green card holder with BSN qualified. So she is residing in USA. She is highly knowledgeable. So these kind of people, 1 or 2 students we come across in life. So yes, move on. Next month, stop giving all the answers. So if you have, the previous slide, where I just stop giving all the answers. So we have to think, we have to make, for example, if any of the situation, brainstorming sessions to be given for the students, and we have to make the students to think and bring their own solutions. For one problem, many solutions they may give. Within that, we can able to take a conclusion which is best. So like that, we have to give time for the students to think and analyze it, and then later on we can apply the best one as an evidence also to the clinical forum. So these are some of the things with evidence. Clinical forum, if we are applying, the research base is needed. But in a brainstorming, unresolved problems can be put forth into the classroom, and the students can answer in their own way, with their own thinking, and we can finally we can able to analyze which may be the good solution for or resolution for the particular issue. Yes. Next. The shared courses like anatomy, physiology, pharmacology concepts and everything. So it will be from the other discipline they are taking up. We are gaining knowledge and collaborative on-site learning experiences. So in order to we want to have a meaningful output to the students, we need to involve the interdiscipline. So that is what, even for the classes. So we are utilizing it now as the same way. Be prepared to address the same areas about nursing. So here, the nursing subjects and all other disciplines we are covering. All other disciplines are also, they are extending their full cooperation for the other medical college and related health disciplines. They are also extending the good support to interprofessional experiences can be meaningful for the students in order to develop an effective students in future. Yes. Move on. So here new skill sets for all healthcare professionals. What are the need? It is needed in interprofessional collaboration is needed for even education or maybe the research, and evidence-based practice and patient-centered care to be provided, and quality patient care and system-wide thinking we need to have. So in order to strive for excellence, we need to follow these all the qualities, new skill sets we need to follow. Yes. The connect of excellence here, not being satisfied with anything less than the very best. Here means we always want to come for first, not for aiming for the second or mediocre performance. So this is why we want to aim for the best. So that's the thing it is given. Yes. So here, hallmark of excellence in nursing education, we have to engage the students, diverse and well-prepared faculty, a culture of continuous quality improvement in engaging or updating their knowledge, innovative evidence-based curriculum, and evidence-based approaches in facilitate, evaluate learning aspect, resources to support the program, to achieve the goal, effective institutional and professional leadership is required. Yes. So here, what might be the excellence in nursing education look like? So here, open flexible curricula and lively exchange of ideas, open classrooms, learning goals, choice of best textbooks, assignments, and differences are encouraged, and the individual performance and emphasis on the affective domain of learning. Yes. So it is continued. So the teachers think out loud, openly admit not knowing. If sometimes the teachers not knowing one concept will not accept. So if any answer doesn't know also, they will just say something and leaving even the wrong things. So we have to admit if we are not knowing, we can very well say, sorry, I will read and come, I will explain it tomorrow. So you to also go through and come. Like that we can say, no problem. But wrong thing too should not be given for the student. So that's what it means. Faculty make their thinking visible to the students. So they have to be open. So that is the same meaning. If the excellence is to be valued and rewarded. Even for the teachers, it has to be performance to be appraised and it has to be rewarded then and then, not only for the student. As administrator, we need to analyze the teacher's capacity as well. Yes, move on. So here, to save the future of nursing education, we need to, the faculties are expert, need to be expert leaders and value. They need to, the deans and directors who create the system of value and reward expertise in nursing education, who are willing to act as a true leader. Every step of the way, we need to support. So in terms of providing them to train effectively, maybe this in terms of skill or maybe the workshops to update their knowledge, because the teachers have learned long ago, but the updation is needed. So that's what we need to value and reward. As time passes, we need to develop for the leadership as well. For example, here various level of leaderships are there. So maybe the middle level, maybe the higher level, even the teacher is also a leader. Not only the administrator is the leader. As being a teacher itself, it's the leader. So even the students are the leader. So we can say, because everyone is the leader. The leader can be anyone at any level, but only the thing, the qualities, and then the style, how they are dealing with problem, that only it helps you in all level, maybe the vertical level or the horizontal level leaders. We need to develop in all the area. Yes. So here some of the historical evolution of the nursing education in other country it is given, but in our country we know. So the pattern of education we already know. That's what I didn't place that one. to knowing about the other country's status. So in 90s, how far the education, it is there here. So like starting the practice nursing and diploma schools and then the postgraduate, slowly it is improved. In the 90s it was. And but in 20s and 1920 and 30s, maybe the other 20 years, there are other programs. It has become so as like here also the same way, but their degree is little bit different, BSN, ADN. So like that, they are giving a different level of education. So the masters and doctoral, the same. So they are the evolution in the other country, US, it is pattern is given. But in our country, it starts from ANM, GNM, all the courses you know. So that's what I didn't place over here. So it is there. The evolution is there till now. We are growing now. Yes. So the nursing education as such, it is a primary goal of nursing education remain the same. The nurses must be prepared to meet the diverse patient need and function as a leader. And advanced science, that is evidence-based practices. So everything we need to keep pace with the recent trend. So that is the one, all it is given in and the transition here, particularly for the academic preparation for the students, how is the transmission from student to the staff. So we need to orient at the leadership skill and we inter-collaborations in order to take a transition smoothly from their academic preparation to the range of practice environment, so from student to staff nurses. The higher level of education and training through improved education system promotes seamless, aggressive academic progression. For example, the teachers maybe from UG, they are moving to higher level of learning to upgrade their self. So these are some of the trends it is there. And here the nursing education, it demands, so we need to have a quality and success of a nursing workforce. So here it is very, very difficult. In particularly the leaders are very much lacking. So now the youngsters are coming up, but the experiences and the availabilities, everything, it is a bit difficult. Wherever it is there, faculty can be it is molding the teamwork, collegibility, solidarity for the student strengthens development of value structures in students. The faculty role as a team, how to act in an education team. So that is the thing. It is everywhere. It is one and the same what we are practicing. Yes. So that is the previous slide, please go. So here the linking of elbow with inter and intra-professional colleagues to tackle the challenges, because so from morning we are hearing about, so we need to have an inter-collaboration, inter and intra-professional colleagues collaboration to tackle the challenges of today's and tomorrow's healthcare environment. So that's what is the team as a collaboration, either in practice or maybe the research, and even in education, we are depending on each other, interdiscipline and intra-discipline professionals. Yeah, move on. So here the embracing the transformational leadership, TFL, as a framework for developing leadership competency in academic administrator, faculty and students is one of the opportunity for cultivating a team-focused faculty culture. We need to develop the team-focused faculty culture. So in order to develop the leader, transformational, as already told, embracing the transformational leader, it is the recent trend. For that, we need to develop the leadership competency. So that is the challenge for the administrator, academic administrator, to develop the leaders, effective leaders. So that is very, very important now. So to face the challenges in the education system. Yes, move on. So here the learning objective, academic nursing leadership, how we can able to shape the future of nursing. Here we have two or three objectives. Here the historical evolution already we have seen, and contribution of differences in various nursing education program. how it is there in other country, and here also we need to know, analyze it. And future of learning and teaching in nursing education, we need to think about what are the changes ahead. Yes. The strategy is based on the changes we need to develop. Academic leaders are equipped with developmental understanding in a better position to support the vertical leadership development of one's own self, faculty, peers, and colleagues. So it is a challenge for the academic leader. So we need to develop our own self and the faculty and all in various cadre, the vertical ladder. So the middle level, as like the manager, the low level, middle level, and the top level. The leaders are also in various cadre. We need to prepare the leadership. Yeah. So for that, the faculty workshops can sponsors the workshops and orientation of new chairs. 2 days for there in other country, they are conducting regarding the legal policies and ethical turnover, promotion, time, meeting management, conflict resolution, performance appraisal, faculty and staff managing, faculty leave. In each one aspect, they used to conduct 2 days of full workshops, and for all the faculties, how far it should be oriented, keep oriented, and prepare them as a leader. So for that, they need to take up some certificate of or from workshops in each aspect in order to develop. So that is the academic chairs or associate deans, they are arranging the workshops for as like interactive sessions, and they can able to exchange their ideas, and they can clarify their doubts in the leadership style, or maybe the what kind of resolutions. Anything, it can be conducted as a workshop to improve the leadership efficiency. Yes. So here they embrace a new vision for academic nursing. So we have 5-6 steps. Under that, first one is embracing a new vision for academic nursing. We need to have a vision and enhance the clinical practice of academic nursing. So, and partner in preparing the nurses in future, and partner in implementation of the for the accountability of the care which it is delivered at the bedside, and invest nursing research program and better integrate research into clinical practice, that is evidence-based practice, and implement an advocacy agenda to support a new era for academic nursing. So this is the pillar of how to improve that academic leader or administrator, improve the standard of patient care and as well to the quality education. So here there are some 2-3 important things we want to discuss. Shift of technology first. So all from morning, I have to explain more on this. And increased age of population. So that is elderly population. And now the current pandemic, COVID-19 and Omicron. So these are the emerging new diseases. We need to keep ourselves abreast of changes, what is taking place in the healthcare industry. And then the nursing professional make sure that up to date with the latest and greatest in clinical practice. So we need to be aware of what it is happening. So the nursing is challenging. So the trends. So the 3 trends: shifting of demographics and increasing of leadership opportunities, growing role of informatics. Informatics already we have seen. The demographic also, there are various changes we will going to see in the following slides. And increasing the leadership opportunities. How to develop the leaders in various level, maybe the horizontal level or maybe the vertical level. So these are the things we need to keep focus future challenges in nursing trends. So here shifting our demographic here, one study, it represents that in the USA, the men in nursing are very less in comparison with the 19th century, only 2%. And in the 20th century, now it is become raised to. So it is almost 1:10. It is increased. So here men and women comparison is almost 10. For every 10 women, 1 man. So like that, it was existing. But now it is improved. Historically, even in the other country also the same way. Yes, move on. So it is here, the US statistics, 2% in 1960, 2017, 13% of men were involved in nursing discipline. Yes, move on. So here, the licensed registered nurses statistics of male. So here, prior to 19, only maximum 5.8, and 2013 to 16, 15, 40, it is increased proportionately, 14.1. So here, the occasional nurse. So not the, here the RN, but here the occasional nurse, male, how it is, for 4.7 to 12.7, improving. In the men discipline, I am a men registered nurse is given. Yes, move on. The future of nursing here, better understanding and of experience in the care in management, improvement of quality and system level change, reconceptualize role of nursing is a reform the healthcare system. It is the future expectation, and the nurse education should serve as a platform for continued lifelong learning and include opportunities for seamless transition to higher degrees. We have more opportunities for higher degrees. Accrediting, licensing, and certifying organization need to mandate the mastery of the core skill and competencies. The NCLEX, many of the examination, the TOEFL, many examinations we need to have if you apply for the other country. The same way, even here also the competencies will be analyzed in future, it is expected. And to respond to the under presentation of the racial and the diverse population, even in education, so the men in nursing and as well the different culture, diverse people have to come to share their knowledges from various country. So that is the future of nursing. Finally, the nurses should be educated with physician and other healthcare professional as students. So even the nurses, if you work as a nurse also, we want to act as a student only, we want to learn. So after getting a staff nurse role, the people are not at all reading, only coming for higher education only, but it is not so. As very rightly told, the interdisciplinary research and other thing, Dr. Madhavi has explained. So we need to keep update all the knowledge every day, even though if you work in a service line also, the updation of knowledge is very important, not only from the education side. So then only we can able to interact with the interdiscipline. Yes, move on. So the increasing leadership opportunities here at every level, as already I told, it is we have to create a new integrated practice model, working with the organizational policies, and then leading of curriculum changes to prepare the nursing workforce to meet the community and patient demands as the need of the hour, and translating and applying research finding into practice, that is evidence-based model we need to develop and we have to apply. And serving on institutional and policy making board where critical decisions affecting patients. So as a leader, we have to have know about everything. Then only we can, for example, the Prakash Mal and all, Madam Entrepreneurship, she told, for the decision making level, policy making level, she is involved. So that is the change as a leader. What is the contributions given for? So at all level, the leaders ought to be prepared, not from the lower level student and then the teacher or maybe the nurses. Every level, the leaders should be developed. So there is a lot of leadership opportunities in front. So for that, we have to prepare. So maybe the nurse anesthetist, nurse midwife, nurse practitioner. So in other countries, these are some of the notable thing. And for the position of advanced practitioners. So the percentage also, it is increased. So from 31% between 14 and 24 year. So it is now everywhere the openings are there in all level. So we have to prepare in such a way in which area you are interested, you have to develop. Yes. So the informatics, this is the trend where what we have from morning: clinical informatics specialist, nursing informatics specialist, clinical analyst and clinical informatic manager, and clinical informatic coordinator, clinical informatic analyst. So like various, depends on the technological, or you can, if you have a knowledge and you can clear those things, and then you can apply for the positions in other country as well. Yes. Current challenges in education. So here, web-based program, online. Academic preparation is very, very essential. Number of registered nurses meet the growing healthcare demand. Rapid pace of healthcare, reassessment of the curriculum, constant reassessment. That's why even Indian Nursing Council, they modified the syllabus according to the meeting the other country need. So credit based, and the system, now the syllabus is a little bit different, semester based, and we need to undergo for the following academic year. Recruitment and retention of the qualified nursing faculty and to teach students, it is a challenge. Online courses take up for the students and then the teacher also, it is a challenge now. Yes. Future challenges in nursing education. Yeah, it is again, we need to go for increase non-hospital patients. So maybe that home care, in the morning also we have discussed about. So that and all, it is a challenge we are going to face. Yes. And that's why a lot of entrepreneurs are coming in. Yes. Let's move on. Next, previous one. Yeah. So that here, so increasing this one I told, new electronic platform, it is very well, it is discussed through Jasmine presentation, and enhance the learners in this area. It is very, both the teacher and then the students. It is a challenge for us, and maintain integrity in online learning process. So that the digital leadership is required. Even the leaders need to be updated with this technology. So that's what not only the teacher student, but in all level, the digital leadership is essential to learn all the technology. Yes. Yes, move on. So here, concluding, so that academic leader is a gatekeeper of the quality of the standard. Imagination and the creativity of higher education need to be urgently addressed, the deficiency, and to make it more professional. So in all the way, for the students or the teachers to be trained in a professional way to meet the challenges. And training, practice, skill-based selection of academic leaders is mandatory and relevant for the maintenance of global quality standard. So this is what, and academic leaders need to explore how the concept of globalization, a meaningful integration of local and global forces, can help them to inform and enhance their pedagogy and practices. Nursing education at all levels needs to be provide a better understanding and experiences in care management, quality improvement methods, system level change management, and reconceptualized role of nurses in a reformed healthcare system. So it is a very big challenge for the academic leader, since she is the key person to maintain the quality and standard at the bedside and the educational standard at the academic side. And recruit and retain the faculty is also very difficult. So it is a challenge. And here the nurses prepare managers who are participative, facilitative, and emotionally intelligent. So that is very essential for a nurse manager or a leader. Leadership style contribute the team vision, lower stress, and higher empowerment and self-efficacy. Leadership is a predictor of quality outcome in the healthcare setting. So as already told, the transformational leadership in nursing inspire and motivate the employee to find better ways of achieving goals, as these leaders excel at conflict resolution. They can mobilize people into groups and can get work done, raising the well-being, morale, motivation in the group through excellent rapport. So because this is the recent trend of transformational leadership as incorporating a bit of a democratism, and we have directive or authoritative, and then as well the other one or two leadership style incorporated to form a transformational leadership in order to bring out the most and quality outcome either the bedside or maybe in the educative side. So this is the leaders' challenges. The leaders are to be prepared at all level, maybe the horizontal and then the vertical level. Some few references are here. Yes. Thank you. Thank you for the patient listening up to this time. Thank you for all the participants. Yeah.
Thank you, ma'am, for your elegant and enlightening presentation on academic nursing leadership, shaping the future of nursing education. We thoroughly enjoyed your presentation. As usual, your speech brought new insights. We connected deeply to the content you have talked about. Thank you very much, ma'am. Because
it is a very difficult job as being an academic leader. So when you are coming to that level, you will see that what are the practical difficulties and how to keep update yourself. So it is very vital for all of us. You need to improve. Yes. Thank you.
Absolutely, ma'am. Thank you very much, ma'am. On behalf of our organizing committee, we would like to present a small token of appreciation. Please kindly accept it, ma'am.
Thank you, ma'am. Thank you. Thank you. Thank you.
Thank you, ma'am. It's time to move on scientific session. Due to time constraints, we request the presenters for scientific session who are from other colleges are requested to get ready for your oral presentation. The presenters from SRM College of Nursing will be withheld. Well, I have come to an end. Let me call upon Mrs. Valarmati, Associate Professor, Department of Psychiatric Nursing, to take over to host the upcoming scientific session. Please, ma'am, the stage is yours. Thank you.
Thank you. Thank you for the opportunity. Yes, we start the real scenario. With the quote, we will start the session. Everything is theoretically impossible until it is done. So it is research. We proved our professional excellence. So in this session, I want to invite and introduce Madam Dr. Tamil Selvi, Principal Professor of Milam College of Nursing, Viluppuram. And with a brief note, she completed start her nursing journey in the year 1997 and completed her UG 2001 and completed her PG 2007 in the Adiparasakti College of Nursing, and she completed her PhD, Dr. MGR Medical University, May 2017. At present, she is working as a principal in Milam College of Nursing. Madam had a 12 years of experience in the field of teaching and 2 years in the clinical practice. Madam guided many UG and PG researchers and is the very excellent person in the field of nursing. So today, Madam is the session chair for this scientific session. And next, I want to introduce Dr. Kavita, or working as an associate professor at SRM College of Nursing. Madam is going to be evaluate both of them are critic and evaluate this session. With this, I'll just go through the names of the outside participants for your attention. Madam Mansula C, Apollo College of Nursing. Madam Dr. Jaslina Jnanarani, Apollo College of Nursing. And Madam Sasikala Dachinamurthy, Apollo College of Nursing. Madam Serma Subhatra, College of Nursing, AIMS, Bhubaneswar, Mary Monica, Apollo College of Nursing, and Madam Geeta M from Apollo College of Nursing. They are the outside participants. First, we give preference for them. After our College of Nursing, participants will be present their papers. So for this time limit, we are just announced here for the 10 minutes. It is for 7 minutes for your presentation and 3 minutes for the discussion. So now I just call upon Madam Mansu, Apollo College of Nursing, to present the paper.
Good afternoon, everyone. Manju is not here.
Yes. Yes,
so I am Dr. J. Jaslene Anyanarani. Can I present my paper?
Yes, ma'am. No problem.
Manju is my colleague. She has requested for tomorrow, I think. So let me go ahead with my presentation.
Yes, ma'am.
Yeah, you can continue. Is that okay, Tamil Chelvi, ma'am?
Can I start presentation?
Yes, ma'am.
The presentation is on awareness and perception of nurses on organ transplantation and attitude of family members.
Excuse me, ma'am. Dr. Jaslene, can you
Yes.
make it slideshow, please?
Yeah. So awareness and perception of nurses on organ transplantation and attitude of family members towards organ donation. That is my topic for presentation today. So this study was conducted in Apollo Hospitals, Chennai. So around 17 million people die every day waiting for an organ transplant. There are several people who are in end stage organ problems and they are waiting a transplant. There is a lack of knowledge and fear of organ donation among healthcare workers and lay people. This is a challenge faced in critical care setting. So researcher was interested to know about the awareness of nurses regarding the organ transplantation and to prepare them as efficient counselors. So that was a need for my study. So statement of the problem is a descriptive study to assess the awareness and perception of staff nurses on organ transplantation and attitude of family members regarding organ donation in the ICUs of selected hospitals. The objectives of my study were to assess the awareness and perception of nurses on organ transplantation, to assess the attitude of family members towards organ donation, to determine the association between selected demographic variables, and awareness and perception of nurses, to determine the association between selected demographic variables and attitude of family members. So these were the objectives of the study. Are my slides moving?
Yeah, it's moving.
Yes, yes.
Yes. The methods that were methods and materials, survey approach was used, descriptive research design. The setting was ICUs of Apollo hospitals. The population were nurses and family members. So the sample size was 60 nurses and 30 family members of patients with head injuries. The setting was Apollo Hospitals, Chennai, Apollo Specialty Hospital, Vanagaram, Apollo Specialty Hospital, Tenampet, and Apollo Hospital, First Med Hospital. The sampling technique that was used was purposive sampling technique. The instruments that were used were a background variable pro forma to know the baseline variables of nurses, structured questionnaire or knowledge questionnaire on organ transplantation on 5 components consisting of 25 items. Organ transplantation, the types of organ transplant, regulation and ethics, process of organ transplantation and counseling. So these were the questions that were asked for the nurses. And the survey questionnaire on perception regarding organ transplantation was a 20-item questionnaire with response from never to always. So perception regarding the role of nurses, adequacy of preparation to do the organ transplantation preparation, challenges or personal factors, challenges perceived in team dynamics related to organ transplantation, challenges related to organizational factors. So these were the 20 items that were asked to the staff nurses. And the fourth one was the attitude scale on organ donation that was administered to family members with dichotomous response. Do they know about brain death and cadaver donation? What are the organs that what are the types of transplants that are available? What are the organs for transplantation? What will be the ventilator support for brain dead person? What are the government policies with regard to the organ donation? So these were some of the questions that were used. Will they consent for organ donation for their family members? If they have given a consent, have the family members given any consent for any other organ? Will they give for, will they approve for an organ donation of their own family members? Such type of questions were asked in the attitude scale. So these were the findings after doing the descriptional and inferential statistics. These were the findings of the study. Coming to the nurses, 60 nurses, majority of them were younger nurses, 23 to 28 years of age, and with BSc nursing qualification, and majority were having about 3 years of experience. And around 66, 1/3 of them had previous knowledge on organ transplantation. And coming to the family members, a majority of them, out of the 30 family members who responded, 73% belonged to 51 to 65 years of age. They were primary caregivers. Most of them were parents or the immediate family members, and 87% were Hindus, and many of them were women. More than half of them were women, and 73.3% at least had a secondary level of education. 63.3% were of low socioeconomic status. Now coming to the awareness of nurses regarding organ transplantation. The nurses did not know about, they knew about different types of transplant, but they did not know about the regulatory mechanisms or the counseling process. They were lacking in those categories, and their mean level of knowledge for 25 was 8.64. This was the mean and standard deviation of awareness regarding organ transplantation among nurses. Coming to the perception of nurses regarding organ transplantation, 76.6% said that there were support resources available for organ transplantation and team reference they can give if at all they found out that they needed support. 56 members, or 93.3% of them, perceived challenges in team dynamics. Especially they felt that the nurses are not being revealed about the patient's condition or the prognosis, and there are team dynamics does not permit them to take an autonomous role in explaining to the patient's family. And 73.3% of them perceived inability to communicate, especially to the members of younger family. They felt personally they had difficulty to communicate to family members of young patients who were brain dead. And majority of them said they were having difficulty to make ethical decision making. So these were the findings with regard to perception of nurses. Coming to the attitude of family members. So 73.3% were aware of organ donation. Only 20% were aware of successful heart transplant, and 86.6%, most of them were aware of corneal transplant. 80% of them supported organ transplantation, and 23.3% of them would donate an organ. 83.3% said they would accept a transplant organ. They will accept harvested organ for themselves. The majority of them, 80% of them who said generally they would not allow an organ to be taken from their family member. They cannot permit that. Although 56.6% would allow the organ to be harvested if the patient had priorly made a consent or indicated before death that they could give. For example, they made a pledge for eye donation, etc. Then they are willing to go for an organ transplant of that particular organ, not of all the organs. So this was the findings of the survey by attitude of the family members. Now, this was a percentage distribution of the attitude of the family members. So we could see that 76% of them expressed moderately positive attitude. And association, there was no significant association between demographic variables of nurses. there was significant association between demographic variables like age, educational qualification, and previous knowledge among family members with their attitude. There was significant association. So these are the limitations of the study: low sample size and ethical aspects. It was approved by IEC. Privacy and anonymity was guaranteed. Participation was completely voluntary. Informed consent was obtained. So nurses can be empowered with organ transplant. They can do advocacy role for counseling. Education about the public will help us to use more available brain, or we can make a larger pool of valuable organs for transplant in our community. With that, I conclude my presentation. Thank you. Impact of the study. So we have come to a main understanding about the difficulties nurses felt, their perception regarding the organ transplantation, what challenges they faced, their level of knowledge we were able to understand. So we can envision a role of nursing counselors, nurses, critical care nurses, neuro ICU nurses can play a critical role for counseling the nurses. They can have a significant role. We can have a training program. We can enrich our curriculum about organ transplantation, the impact of it, etc. And public, we need to have a large drive in the public to educate our community about the youngsters, volunteers, about the impact of this organ donation. Many people are aware of kandanam, eye donation only, or blood donation only. Apart from that, kidney, many are aware. There's limited understanding about liver or heart or lung. So many organs, about 27 people can benefit from one organ donor. Many are not aware. So this study will make a large impact. We can do such training courses without any monetary benefit alone in consideration. We can have a large drive to people who are in need of such organs. Only those who are feeling the need for that organ will know the value of this organ. Though we are thinking about the brain dead people, young people who are losing brain, who are having brain death, still this organ donate are valuable. No use of taking them with us when we die. So that's an important thing, I think.
Thank you, Dr. Jaslina, for your interesting presentation.
Thank you, ma'am.
I have a small query on sample selection. You have mentioned that out of the nurses and the family members, 60 are from the nurses and 30 from the family members. How did you come to decide to the number of, shall we calculate?
We wanted to do at least minimum 30 for it. So a small sample size for generalization purpose, minimum we stuck on to 30. But we had more available nurses. We had 3 neuro ICUs in 3 different hospitals. The number of nurses were more. But patients, we had to wait consecutively. We had to recruit the patients' relatives, neuro patients who had a traumatic brain injury, their relatives. We were waiting one by one. We could minimum take 30. So that's why we had to stick on to at least 30 minimum for patients and 60 for nurses. We would like to take more also. Nurses possible to take, but patients we could not take that many according to availability.
That's a right justification. You have got a point to be considered. Now, what is your recommendation? You have seen the attitude of the family members, right? Have you started any strategy in changing their attitude or improving their aspects based on the recommendation of the study?
There are organ donation counselors are available. They are mainly like psychosocial workers. They have done MSW, they have studied, but nurses have not taken an active role. Nurses prefer to stay safely in the clinical area. But counseling or general public education can be done, because only when they come to the ICU, they know about all this. If they have a person with all this, they are feeling very emotional trauma. That time it's difficult for them to understand. But general public, we have to sensitize in our colleges, through NGOs. We must sensitize our youngsters in the community. So that type of teaching programs, we can have more targeted programs. So nurses are part of the team now. They are one nurse is part of the team. We need to have more nurses, I feel like that.
Thank you.
Educating our students in the education side itself, we need to prepare our students for this.
Yeah. Thank you, Dr. Jaslina.
Thank you.
Thank you for the interesting discussion.
Thank you.
Now I call upon Madam Sasigla Dasmamurthy for their presentation.
Thank you, Jaslina. How are you?
Thank you, ma'am. Very nice to meet you, ma'am. How are you, ma'am?
Yeah, I'm fine.
I'm
How are
fine, ma'am.
you? Yeah,
I'm fine,
so
ma'am.
nice.
Yes,
So
ma'am.
nice.
I'm a
Congratulations to become a
in
vice
Apollo.
principal.
Yes,
Yeah.
ma'am.
Yes,
Yes, ma'am.
so
God's
nice
grace
of
and
you.
your blessings, ma'am. Thank you.
Yeah, so nice of you. Principal, who is she there?
Our own old professor only, ma'am. Satya, Nesa Satya. She's our
Okay,
principal.
okay.
She was previously HOD of
Lizzie,
child health.
Lizzie and all, where is she now?
Lizzie, ma'am, is in Saudi only, ma'am. We asked her
okay.
only first. Management called her back, but she told she wants to extend her sabbatical further. And then we could not wait, and they took others. They waited
Okay,
for
ma.
Lizzie,
Anyhow,
ma'am,
my
first.
congratulations to both of you. Do well. Eh?
Yes,
Yeah.
ma'am.
Okay, ma.
Thank you, ma'am.
All the
Thank
best.
you, ma'am.
All the best. Take care. Yeah. Okay. Thank you.
Thank you, ma'am.
Thank you, ma. Thank you.
Next, I request Madam Sasikala Dasnamurthy for the presentation. Okay. Next, I request Madam Sasikala.
Dr. Sasikala, are you there, ma'am?
Ma'am, please unmute yourself. Dr. Sasikala.
Can you unmute yourself, ma'am?
Unmute பண்ண சொல்லலாமா?
Yes, ma'am. Can you hear me, ma'am, now?
Yeah. You can hear.
Yeah. Good evening to one and all. I'm Dr. Sakshikala from Apollo College of Nursing. And first of all, I would like to thank the SRM College management and the principal and the organizers for giving me this opportunity to present my scientific paper. And I'll share my slide. Can you see my slide, ma'am?
Yeah, you can see.
Yeah. So
can you make it a slideshow, please?
Yes, ma'am. Yes, ma'am. Can you see it, ma'am?
No,
Is
ma'am.
it visible for you, ma'am?
Not in slideshow.
I've projected in slideshow.
Have you?
Is it seen for you, ma'am? As
I can see
slideshow?
the slides, but it's not in slideshow, my dear.
Not, huh?
No.
1 second, ma'am. Now, ma'am?
Yes, yes.
Okay. But it is not moving. I'm not able to move it. When it is in slide. Yeah.
Shall we project it? Can you?
Yeah, now it is. Is it moving now, ma'am?
Yeah.
Okay. Okay. Thank you. Thank you, ma'am. Okay. My topic is on the assessment of facilitators, barriers, outcomes of timely treatment in golden hours for patients with myocardial infarction. So, 1 second. So according to WHO, it is estimated that 7.4 million deaths occur due to coronary artery disease, and it will increase to about 23.6 million by 2030. So MI is responsible for over 15% of mortality every year. So around 80% of the death occurs within the first 24 hours, out of which 40 to 60% occur only during the first hour itself. So every 30 minutes delay increases the chance of mortality, 1 year mortality rate by 7.5%. So in spite of all these major advancements in the medical field and the treatment and emergency medical systems, the pre-hospital delay time has remained constant since 1986 itself. So this inspired the researcher to conduct a study to assure the assessment of facilitators, barriers, and the outcomes of the timely treatment during golden hours for patients with MI. So my statement is a descriptive correlation study to assess the facilitators, barriers, and outcome of timely treatment in golden hours for patients with MI at selected hospitals in Chennai. Objectives of the study were to assess the facilitators of timely treatment in golden hours, then to assess the barriers of timely treatment in golden hours, and to assess the outcome of timely treatment in golden hour for the patient with MI. Fourth one is to find the association between the demographic variable and the timely treatment, then association between the clinical variables and the timely treatment, then association between timely treatment and the outcome of the MI patients. Coming to the research methodology, a survey approach and a descriptive correlation research design is used for the study. The independent variables are facilitators, barriers of the timely treatment, and the dependent variable here is the outcome of the timely treatment. And the attribute variables include demographic variable pro forma and the clinical variables of the patient with MI. So this study was conducted in Apollo main hospitals among 100 patients who are admitted with MI. These patients are the samples are selected by consecutive sampling technique, and the patient with MI are included who are aged more than 18 years are included in the study, and those who are willing to participate and who are available during the time of data collection were included as samples. So coming to the tools which are used for the study are demographic variable pro forma, clinical variable pro forma of the patient with MI, checklist to assess the facilitators, checklist to assess the barriers, and the checklist to assess the outcome, which are developed by the researcher itself. And the content validity of the tools are obtained by getting the expert's opinion in various essential fields. The demographic variable pro forma consisted of age, gender, marital status, education status, occupation, annual income, family history of CAD, living area, health insurance coverage. Clinical variables include height, weight, BMI, history of diabetes mellitus, hypertension, COPD, habit of smoking and alcohol, previous history of MI, and previous history of hospitalization. The checklist to assess the facilitators consists of 14 items. Then checklist to assess the barriers consists of 17 items, and the checklist for outcome of timely treatment consists of 10 items. So each item has the yes or no responses. Coming to the ethical consideration, the ethical clearance was obtained from the Institutional Ethical Committee of Apollo College of Nursing, and setting permission is obtained from the Apollo Hospitals of Chennai, and informed consent were obtained from the study participants. Confidentiality was maintained throughout the study. Coming to the steps. After obtaining the setting permission, the researcher identified the samples in the CCU after the patient is shifted from the emergency or from the cath lab. The researcher first introduced self, and the purpose of the study was clearly explained to the patient, after which the informed consent was obtained from the study participants who were willing to participate in the study. Then the data was collected for a period of 4 weeks using the interview method from the selected samples who were hemodynamically stable in the ward after being shifted from the emergency to the wards. And after collecting the baseline characteristics, the data for facilitators, barriers, and outcome were collected using the predetermined and pre-tested tools. So coming to the results of the study, the frequency and percentage distribution of demographic variables of patients shows that 65% of the patients were aged above 51 years, 79% of them were male, 99% were married, and 32% were graduated high secondary and above, and 42% were graduated, were retired, and 45% were sedentary, were doing sedentary work, and 55% had annual income of above rupees 50,000 per month, and 96% were residing in the urban area. 91% had no health insurance coverage. Then 34% had some source of information about the MI through the mass medias. Coming to the clinical variables distribution, 44% were overweight, and 55% had no history of hypertension. 75% had no history of 55% had no history of diabetes mellitus. 75% has no history of hypertension, and 96 had no history of COPD. 82% do not have any habit of smoking or alcohol. 90% had no history of MI or any other cardiac events, and 79% had no history of any hospitalization. 91% were non-vegetarian. So coming to the distribution of patients who received timely treatment, 64% received timely treatment during the golden hours, and 36% did not receive the treatment during the timely treatment during the golden hours. So coming to the facilitators of timely treatment, 88% said that they were able to reach the hospital because of the bystander or with the help of the family members who were along with them. Then 49% said that they were able to call the emergency system immediately. 61% were able to manage by themselves, and they can use their own transport to come to the hospital. 69% said that recognize that it may be mainly related to the cardiac problem. The symptoms were related to cardiac problems. 56% perceived their symptoms are very serious, so they were able to, so they wanted to reach the hospital as soon as possible. Then 58% recognized the importance of early treatment, and they were aware about the MI. Then 53% said preferred to go to the emergency department first, decided to go to the emergency department considering the seriousness of the problem. 83% were insisted by the family members to go to the hospital as soon as possible. 47% were very anxious about the symptoms, so they wanted to seek the help quickly, medical help. Then 63% felt that the hospital is at a longer distance, that is about more than 5 kilometers. So they wanted to reach a hospital as early as possible. Then 61% felt that they wanted it will be better to go by ambulance so that they can go and reach the hospital and get the accessibility of the ambulances there for them, so that they can reach the hospital as soon as possible. Then 44% said that the pain was severe. So because of the severity of pain, they decided to seek the medical help very quickly. Then 61% said that since the symptoms occurred during the daytime, so they were able to seek the medical help and get the help of the others. So they can get the timely treatment. Then 78% said that they did not want to waste the time by waiting for systems to disappear. Then coming to the barriers, 61% of them said that since they are alone, they were not able to go to the hospital quickly. Then 52% said that they experience symptoms even though they do not want to panic the family members. So they do not want to disturb them. So they did not tell it quickly. 70% said they experienced...
Time over, ma'am.
Okay. And yes, ma'am. So coming to the outcomes, we can see among the timely treatment, survival rate is higher. The medical management and use of thrombolysis and PTCA is more compared to the delayed treatment. The necessity for emergency treatment is very less in the timely treatment. Then hospital stay is also reduced. The use of need for IABP is also reduced in timely treatment, and the complications such as embolism, cardiac arrest, and dysarrhythmias are reduced because of the timely treatment. So this is about the result coming to the association. We have a strong association with the family members and media, that is source of information, and also the hypertensive patient considered very lightly when they have a symptom, so they seek the medical help very late. Then it is the same as it is all we have already seen that timely treatment is associated with the outcome of the patient, such as survival rate, medical management, CABG, PTCA, hospital stay, IABP, and the complications. Incidents were reduced. That's all. So healthcare providers can engage the people in education sessions for the older adults and their companions and significant others to more accurately recognize both the typical and atypical symptoms and act to seek the treatment immediately. So they can formulate and formulate or design an education session and educate them so that the public can get awareness about the timely treatment during the importance of timely treatment during the golden hours. Yes, ma'am. Thank you, ma'am.
The inclusion criteria starting over 18 years. Yes.
Yes, ma'am.
Your inclusion criteria is more than 18 years. Come across any 18.
Ma'am, I couldn't hear clearly, ma'am. Yeah, I can't hear clearly.
Keep your mic. Criteria start from age of 18 years. The inclusion criteria age of 18 years.
Yeah, above 18 years. The people.
Above 18 years. Is there any standard between 18 to 25?
No, Dr. Sasikala.
18 years and above, ma'am.
Dr.
Any sample 18 to 25 years?
Madam, keep your mic nearby. Can't able to add clear.
Is it audible now?
18 years solitaire.
Ma'am, is it audible now?
Audible, ma'am. Audible.
Inclusion criteria more than 18 years, isn't it?
Yes, ma'am.
So is there any sample between 18 to 25?
18 to 25. 18 to 25. No, it is above 18 years, ma'am.
No, we just want to know.
Any sample 18 to 25?
18 years. 18 to 20 years, did you find any samples coming in?
Samples with MI did you get?
With MI.
No, ma'am. No, ma'am. 18 to 25, no. Because I did my study only for a period of 1 month. So during that 1 month, I did not get.
But
Nowadays, we get more younger patients. So that during that particular period of 1 month, I did not get. I got only selected only about 100 patients.
100 patients, data more than 65 years showed more 65%. That's why I asked. Okay.
Dr. Sasikala, I do have same clarification. I just want to clarify. Okay. But first and foremost, I would like to appreciate you for the study. Can you hear me, Dr. Sasikala?
Yes, ma'am.
That is a very interesting study. Okay.
Yes, ma'am.
My clarification here is similar to that of Dr. Tamishalvi, ma'am.
Yes, ma'am.
You have chosen participants right from it. You have categorized right from 18 years, right, as an inclusion criteria.
Yes.
Is there any reason, or did you get any supportive literature that those type of participants are still there, or they are increasing numbers, or you want to increase?
When we go for posting, we observe patients.
Ma'am, yes, ma'am. Yes, ma'am. When we go for postings during the past 1 year, we observed patients below 25 also getting MI, because my own friend's relative who is about 24 years, he got an MI and got treated in M hospital. So the incidence rate nowadays is there even for people below 25 years. And there is also supportive literatures that nowadays we have increased incidence of MI, mainly because of the lifestyle modification, stress, and it is increased among the IT peoples also.
Okay.
Okay.
Okay, ma'am. Thank you for your presentation.
Thank you. Thank you so much.
Thank you, ma'am.
Thank you.
Very nice presentation. Next, I request Madam Geeta, Apollo College of Nursing, for your scientific paper presentation.
கீதா எனக்கு இருக்கா
Madam Geeta, are you there, ma'am?
Ma'am, am I audible? Good evening, ma'am.
Yeah, you're audible, ma'am.
Ma'am, I'm about to present a poster presentation on theme concept, ma'am, not the scientific paper, ma'am. Is that okay, ma'am, to present?
Sure.
Yeah, okay, ma'am. Thank you.
You can continue, ma'am.
Is that visible, ma'am?
Yeah. It's getting shared, ma'am. Not yet visible, but getting shared.
Yes, ma'am. Oh. Yeah, okay, ma'am. Thank you. So the concept for the paper post is health nursing towards, delivering the telehealth nursing to the rural and remote population. So diverse population. So we have terms monitoring, telehealth, telenurse communication, and telemedicine. So in this poster, we are going to focus on the telehealth nursing, how it is going to help the rural and remote population to cover for the telehealth. So initially, it is the evolution of face-to-face, clinical care, and then the telephonic communication about the telehealth, and then the internet and the satellite television took over the session. And then now it is about, after the COVID pandemic, it is all about M-Health. It is all virtual and tele-counseling and consultation. So in rural telehealth, how are we going to expand about the access to the rural communities? It is about we have to identify the rural community, what set of rural community, what type of health status or health issue they are focusing on currently. And then it has to be given to the rural health issue management. And then the community resources, whatever it is available, we have to focus the challenges and then address the rural health needs and the challenges. So the forms of telehealth nursing are remote patient monitoring and asynchronous telehealth. It is about storage and recording, and then the delivering content to the satellite. So we'll be receiving from the unit, and mobile health, and this is a live video conference, one-to-one, face-to-face in the virtual form. So I've given the model for the RPM, remote patient monitoring model for the telehealth nursing. So where the patient communicates to the telehealth nurse. So the patient will be receiving through the mobile health all the data which is collected by the patient, or at least nearby the primary health center, or who is able to accessible the devices through the blood pressure, the blood sugar, and then the patient weight, height. All the lab reports will be conducted at the center, and it will be delivered to the telehealth nurse through the system. And then what are the services which is available for the telehealth nursing services? Mainly focus on the triage, and then the preoperative individual counseling and the preoperative preparation, behavioral healthcare related to mental health counseling, nutrition counseling, home care nurse during the illness and the recovery, UTI, eye examination, all those can be done through the telehealth nursing services. And then the consultation for the minor ailments, injuries, and then the basic telehealth, school health counseling also can be done through the telehealth virtual nursing. And then the care of patient with the chronic conditions, home care based monitoring, patient who need dialysis or patient who need blood pressure monitoring, hypertension, on cardiac rehabilitation, pulmonary rehabilitation, all those patients can be monitored under this telehealth nursing through the home care monitoring. And to improve the access for the maternity care, so I've given the model for the telehealth nursing regarding the prenatal care for the obstetric and the maternity care. So with the virtual, we can go through the patient with the premarital counseling, genetic counseling. So all those can be done. And then when it comes to the prenatal visits, at home visits we can make through the, if it is a rural area or tribal or any form of remote area, we can access through the nurse who is available there. And from there, we can ship the patient through the virtual. We can do all at the home care settings, all the visits. And then when the patient has any issues, through the ambulatory care services, patient can be shifted to the labor ward or to the unit which is need for the childbirth. And then the COVID care management also, can be done. And then it has come to the postnatal care visit. Virtually, we can do lactation management, and then the breastfeeding counseling and postnatal depression can be assessed through the virtual telehealth counseling. And then when it comes to the challenges of the telehealth nursing, organization challenges and the rural population challenges. So when it comes to rural population challenges, it is mainly focusing on how we are going to convince the population. So it is all about how you handle the patient mindset, because they may be illiterate and we don't know how far we are, they're having understanding about the health and the counseling and all. So we have to focus on the challenges of this patient affordability, how far they are able to buy. So we can give model for any primary health center or any government hospital or any government office or police station or nearby the check post. If it is a tribal area, we can give any form of communication for the particular population, for the tribal or the rural people. So through that, they can access to the telehealth nurse who is available at the district hospital or the state level hospital or for the particular zone or division. So that is a challenge we can manage. And then when it comes to the strategies for the improve of the telehealth nursing, it is to provide education and guidance to the rural population regarding how it is going to help them during at the time of pandemic or when they are not able to access to health care, so they can educate the patient. And about providing support to the develop broadband services, because when it comes to hilly stations or any kind of remote area, it is very difficult for the people to make communication with the mobile. So we can give any sort of funded project or something like that. We can ask, we can through this government, we can get the support through the fundal project or the rural providers. We can access to the any form of primary health centers or any particular form of any government offices. We can make that arrangement through the government policies with the supervision due order, and then we can make the plan for the telehealth nursing. And training of the staff is very important, because as we are having so much of improvement in the technology, so the telehealth nurse should be trained under proper guidance with the certificate. So we have to training of the providers is very important, and provision of the security and consultates about the standards and confidentiality, privacy about the patient is very important. And it is a funding program. We have to search for the project or we have to search for any funder for this project. So when it comes to recovery plan, it is mainly focusing upon how it is going to help the patient regarding the broadband services. Through that, how we going to shift the patient when it is emergency according to the triage system. How are we going to shift the patient through the ambulatory care services to the hospital setting? So through that, the patient will be monitored through the telehealth nurse with the certified nurse who is able to do RN or RM, who can able to handle the telehealth, or who are able to handle the advancement in the technology, can able to do this process with the certified courses and under the supervision of any organization. Thank you, ma'am.
Thank you, Ms. Geeta.
Yes, ma'am. Thank you, ma'am.
What do you feel like? What is your recommendation based on this study?
So based on this study, as we participated in the contact tracing during the COVID pandemic in the GCC Chennai Corporation, we come to know even small minor injuries in even the allergies, people were not able to come at the phase 1. So they were asking for what need to be done, how to tackle all those problems. So based on that concept, I'm able to bring this theme poster for this conference. So through this, we can train the student nurses. So as we come to do so much of simulation projects, so with this kind of telehealth nursing also, they can do the project for app developing along with the any computer programmers or something like that. So they can develop the app. And then what are the minor elements can be treated? They can prepare the model or algorithm for that minor elements. So based on that simple form from the student period itself, we can train the student as a tutor working in the institution. So we can ask students to prepare this kind of models for the minor elements. So with the guidance we can do at the community posting itself, we can give them, we can ask them to install the app. So with that, we can start by the initiating this kind of recommendations.
Over to you, Dr. Tamashini.
Any recommendations for emergency services, ma'am?
Ma'am, I'm sorry, I'm not getting you, ma'am.
Are there any recommendations for emergency services?
So for emergency services, can be provided at the primary health center nurse. can go and attend the call, and through that, through the ambulance services, the 108 available at the hilly station or any type of emergency, with the triad system, the nurse can assist. They can inform to the nearby any kind of medical institution from the government setup, and they can ship the patient immediately with the assistance of the ambulance services. So once the patient reaches the ambulance services, which is along with the any nursing aid or any ambulatory technician, I believe the patient will be definitely safe before reaching to the hospital. The patient minimally they will get what are the assistance to be given for the ABC.
Okay, madam.
Thank you.
Thank you.
Yes,
Very
ma'am. Thank you,
interesting.
ma'am.
Next,
Yes,
I
ma'am.
request Madam Subhatra, College of Nursing, AIMS, Bhubaneswar. Madam, please. Yes. You're not audible, Subhatra.
Can you unmute, ma'am?
Hello.
Now I'm audible?
Now you are audible.
Yeah. I'll start from the beginning or I can continue?
Yeah, you start from the beginning, madam.
Oh, thank you. Okay. The study titled with hemodialysis adherence, perceived stress and quality of life among end-stage renal disease patients during COVID-19 pandemic. The background of the study states that ESRD has become a global public health concern, and public population needing hemodialysis preceding renal transplantation, which is increasing as per the Trivedi et al. 2020 studies. And non-compliance to prescribe the hemodialysis has a serious implication on the morbidity and mortality. And the phenomena might have further compounded during COVID-19 pandemic as per Lee et al. 2020. The objectives of the study proposed in this are that to determine the level of hemodialysis adherence, perceived stress, and quality of life experienced by the ESRD patients during COVID-19 pandemic. The second objective would be to estimate the relationship between quality of life and perceived stress, and to find out the association between quality of life and perceived stress with the selected socio-demographic variable. So hypothesis which he proposed here is there will be a significant association between ESRD patients and hemodialysis in terms of perceived stress and quality of life. So methodology followed in this study was quantitative approach, and then descriptive cross-sectional research design was adopted, and a random sampling technique with calculated samples of 100 was estimated. And then we have implemented a 3 questionnaires: adherence questionnaire, quality of life, and coherence perceived stress life. And from adherence, we have estimated adherence and the person who are non-adherence to hemodialysis. So setting dialysis, it's a dual-centric study. So dialysis unit at AIMS Bhubaneswar and dialysis unit at ESIC Medical College Hospital, Sanatnagar, Hyderabad. So calculated sample sizes 100 based on the literature, Mary Clary Mukunda et al. Who were hemodialysis from more than 6 months duration were a part of study, and study duration was 6 months. Sampling criteria included inclusion criteria: participants who are adults, more than 6 months of on dialysis, and who can able to read English, Odia, and Telugu. And we have translated, and content validity also estimated with Cronbach alpha 0.76, and who are agreed to participate. And the persons who are excluded are disoriented with psychiatric illness and unwilling and uncooperative. Assumption of the study participant will adhere to the hemodialysis factor and able to manage stress and ethical considerations. It is a dual-centric study, so we have taken 2 IEC permissions from AIMS Bhubaneswar, as well Collaborative Institute, IEC, ESIC Medical College, and CTRI with observational study category. So throughout the study, participants' anonymity and confidentiality were maintained. Data collection methods, demographic profiles, and self-report strategy. End-stage renal disease adherence questionnaire, Isola with a quality life index, and coherence perceived stress scale. And all the scales we have availed the permissions from the authors. And the results of the study proposed outcome measures, hemodialysis for 76% of persons reported during COVID. They are unable to adhere to the hemodialysis service. And frequency of shortened hemodialysis. In a week, they are supposed to go for a 4 dialysis, but instead of a COVID protocol, they could able to reach only 2 dialysis. And duration, instead of 4 hours, their time was reduced up to 2 hours, and that to 30 minutes of plus or minus. And they are unable to adhere towards the prescribed medication. 63% were estimated, reported, and non-adherence to the dietary recommendations was 74%. And the factors leads for them to non-adherence are transportation issue reported by 73%, unavailability of slots are reported by 88%, muscle cramps due to poor, nursing care was not unable to provide it to the patients, and pain at the catheter sites due to infection, and difficult to getting medicines was encountered by 81%, and inability to estimate fluid restriction was 34%, and inability to monitor the weight changes because frequent changes are unable to carry it out. 68%, and non-availability of physician consultation was reported by 69%. And coming to the second objective, results perceived stress level. 75% has experienced or encountered 75 high level of stress, and 16 were experienced moderate level, and 9% were reported low level. And coming to the association of a stress level with education and habitat, showing the significant association, chi-square value is 9.52 with P level of 0.02. And for those who are residing in the rural, encountered more amount of stress with a chi-square value of 4.76 and with a significance of P is equal to 0.03 level. Then Mizola quality of life in the scale was measured. The symptoms, it has 5 components. The symptoms, the mean average is 1.78, function level is 3.17, and interpersonal coordination is 5.62 mean level, and well-being was interpreted in minus 2.03, and transcendent level it is 3.32. The overall quality of life was, it is 11.86 with standard deviation of 2.64, which results are showing poor quality. And when it's coming to the association level, age, those who are above 50 years have encountered poor quality of lifestyle. So F value shows at 4.06 and with significance of 0.01. And urban and rural, person who are residing at the rural had reported having poor quality of life with the T is equal to 2.03, and the significance of P value is 0.05 level. And when it comes to the relationship between quality of life and stress, so the mean and standard error value was 31 point plus or minus with standard deviation of 6.43, and the quality of life is 11.86 with standard deviation of 2.64, which shows estimated Pearson correlation coefficient shows that R value is minus 0.44. It is negative correlation. If the person would have estimated better quality of life, perceive their less amount of stress. So the scatter diagram, which is estimated and which shows that moderate negative correlation between quality of life and stress score among ESRD patients. So the major outcome of this study are nearly 75% of the patients faced difficulties in adhering towards prescribed hemodialysis services during COVID-19 pandemic. The major hindrance to adherence to hemodialysis services are lockdown guidelines, non-availability of transportation, lack of support, family acceptance, impact on their health. Then increased stress and impact quality was observed among them. The limitations are dual-centric study and some small sample size. So with this presentation, I would like to thank the organizers to given us opportunity, and our beloved principal, Dr. Asha Shetty, who had given us an opportunity to proceed it, and the collaborating center, other co-investigators of this study. Thank you. Yes, ma'am. Yes, ma'am, I'm audible.
Selection of sample less than 6 months, isn't it?
Yes, ma'am.
Is there any supporting study?
Yes, ma'am, I have a few literatures. Ma'am, the study can be carried out even more than a time, but we want to assess during the COVID pandemic and the availability of samples. And we have reached the sample size within that time.
Madam Subhatra?
Yes, ma'am.
Your presentation was very good and you are very sounding confident. I appreciate that. Now, with regards to the the design that you have chosen, right?
Yes, ma'am.
This is a clinical trial, is it?
No, ma'am, this is not a clinical trial. It is an observational study.
But I could see the clinical trial registry in India.
I can explain, ma'am. Ma'am, clinical trial registry, even we can go for observational studies also, ma'am. CTRA trial registration, we can have observational study also under that separate category. It is there. So for our institute, it's mandatory to take.
Yeah, okay. Okay.
After availing ethical permission.
So it's not a mixed method approach also, is it?
Ma'am, only quantitative data I have presented.
Okay, fine. Okay. Okay, ma'am. Thank you.
Thank you, Subhatra madam. Next, I request Madam Mary Monica from Apollo College of Nursing for your presentation. Request Madam Mary Monica. Yes, sir.
You may start, madam. Kindly unmute yourself. Ma'am, can you unmute yourself? Mrs. Mary Monica.
Good evening, ma'am.
Yeah.
I'm Mary Monica from Apollo College of Nursing. Going to present a e-poster on. I'll share the screen, ma'am. Just.
Yeah.
Yes.
Are you able to see my screen, ma'am?
Yes.
Ma'am.
Yeah. Today, I have chosen the topic on theme on current and future educational challenges as the educational challenges as a nurse educator. Today, a nurse educator has a disposable of inevitable gold mine of techniques, curriculum, models, and stimulators, as well as other advanced technique has been which make it possible to teach the classes and impart clinical knowledge from thousands of miles away. So, according to Dr. Watson, writes, it is a common knowledge that more highly qualified the nurse is less than likelihood that there is a attempting to unsoup the medical man. So, according to review of literature, the literature viewed that the intellectual development of modern nurse education and covering the transitional to online delivery of education. Now we are moving on to the online education due to the pandemic situation. So how come the technology has been increased, we are seeing now. Coming to the challenges in nursing, we have on seeing this next thing poster. In the beginning, we were less number of nurses with the clinical part of it with the low. Only we are inculcating only the clinical knowledge and the skill through this. Now various technology has been channelizing through us. This is a current scenario. We are doing all the things in an equity manner, and the nurses are facing as a nurse educator facing day-to-day daily basis, that is hourly 24/7 we are working with a shortage of nurses and the time constraint, and we are during COVID all the nurses are wearing to protect themselves, they were wearing all PPEs. So 24 hours by 7, they are to protect themselves for the infections. And even though nurses are affected with the COVID situations, so these are the part of some sort of things has been nurse educators are facing this. And coming to our future challenges. Now we are stipulating to a stimulated environment where the virtual simulation has been taking part in nursing education, And before entering into the clinical area, we set our student nurses to take a view on visual stimulation, and by touching as the we are giving care to the patient. It will be helpful for the nursing educators as well as nursing student to take part in the clinical setups. So I have given a core competencies of as a nurse educator's role. Then futuristic education will be one among this, that is clinical, as well as we are imparting a visual stimulation. Thus, I want to conclude this recent technology has more challenges as well as giving impact to the skill as well as knowledge. Thank you, ma'am. Hello.
Very. Your voice is not audible. Please keep it.
What are the recommendations from the poster, ma'am? I'm sorry, ma'am, I can't get you. What are the recommendations for this poster? Recommendations. That is how the future thing is challenges. We recommendations of this poster, ma'am.
Your study.
Nursing services. Hello.
Ma'am, what do you recommend from your study, this study and this one?
Already it's taking impact. Virtual simulation is coming on to that. So future expectation, it will be useful for the nursing students as well as nurse educator to cope up with that thing. That's what I want to recommend.
So, Monica, what was the challenge you faced as a nurse educator? Can you share your?
As nurse educator, that is shortage of nurses and mainly shortage of nurses, and the newer technology has giving you that is documentation, electronic documentation.
Okay. Thank you for your presentation, Monica.
Thank you, ma'am. Thank you.
Thank you, madam, for your interesting presentation. Next, I request Madam Sasikala from Apollo College of Nursing to present your paper. Sasikala A.
Yes. Am I audible? Am I audible, ma'am?
Yes, ma'am.
Yes.
Can you take your slideshow, please? Your presentation as slideshow.
Yes. Can you able to see, ma'am?
Yeah, we can see, but it is
still not in slideshow, my dear.
Slideshow.
Now, ma'am?
Yes. Can continue.
Yes. Good evening, one and all gathered here. I'm Sashikala, faculty from Apollo College of Nursing, here to present that the article on effectiveness of educational games as teaching tool on learning outcome of critical care drugs among nursing students. Excuse me, ma'am, the slide is not changing.
The screen is not moving.
Yes, ma'am. Yes, ma'am. Due to the closure of the educational institution, due to the outbreak of COVID-19 lead to an unprecedented impact on the education. During the lockdown, we the teachers also instructed to teach through online learning platform, argued that there is a need to adapt innovative teaching for continuing the education and overcome the mental stress and anxieties during the lockdown. And coming to the need for the study, I have selected the Kahoot, which is a game-based learning platform used to review the students' knowledge for formative assessment as a break from traditional classroom activities. This platform is among the most popular within the game-based learning, with over 70 million population, monthly active unique users, and used by the 50% of the US students. And the use of the educational games in critical care drugs aims to promote the learning, self-efficacy, and confidence in clinical situations, as well as to help the students to acquire skills in empathy, critical thinking, patient safety, and clinical practice. Coming to the statement of the problem, an experimental study to assess the effectiveness of educational games as teaching tool on learning outcome of critical care drugs among nursing students at selected college, Chennai. And coming to the first objective, to assess the learning outcome on critical care drugs among the control and experimental group of nursing students, to determine the effectiveness of education game as teaching tool by comparing the pre-test and post-test scores of learning outcome on critical care drugs among control and experimental group of nursing students. Third objective is to find out the correlation between the previous year academic performance and learning outcome on critical care drugs in the control and experimental group of nursing students. And null hypothesis, the first one is there will be no significant difference in learning outcome scores on critical care drugs between pre-test and post-test in control and experimental group of nursing students. The second hypothesis is there will be no significant difference in pre and post-test learning outcome scores on critical care drugs between control and experimental group of nursing students. And third one is there will be no significant correlation between the academic performance and the learning outcome of critical care drugs among control and experimental group of nursing students. And coming to the research methodology, the approach was experimental approach. The design was a true experimental pre-test and post-test design was adopted to this study. The setting is Apollo College of Nursing, Chennai. And coming to the independent variable, the educational game is taken, which I have used the Kahoot app as a teaching tool on critical care drugs. The dependent variables, which is learning outcome on critical care drugs among the nursing students. The attribute variables are the background characteristics of the nursing students. And the samples were the BS nursing third year students. The sampling technique was systematic sampling. The sampling size is total 88 samples, 44 in the control group and 44 in the experimental group. And coming to the sampling criteria, inclusion criteria who are willing to participate in the study and who are present during the time of data collection. And then exclusion criteria, those who have taken leave during the period of data collection, I have excluded this study. And then the tools used in this study were the background variable performer of the nursing students and multiple choice questionnaire on the critical care drugs, which is got the content validity from the experts in the field of medical surgical nursing, and then the rating scale on level of acceptability of educational game as a teaching tool. And the steps of data collection, after selecting the samples, the initial introduction was given, informed consent was obtained from the participants of the study. For both the groups, the background characteristics and the pre-test assessment on learning outcome on critical care drugs were assessed. The data was collected by self-administration method using the Google Forms through the WhatsApp and emails, though the patient were in the online teaching, that's why. And this Kahoot form I have used, Kahoot app which I have used. On day 4, the educational games was implemented for the experimental group of nursing students, which include MCQ, true or false, puzzles, jumbled words, crosswords, pictures, and connections in critical care drugs. On the day 5, the post-test on critical care drugs was conducted for both the group of nursing students. The collected data was tabulated and analyzed using the descriptive and inferential statistics. And coming to the analysis and then the discussion, the frequency and percentage distribution of the background variables among the nursing students. Most of the students were in the age group of 21 years and majority of them from the Tamil Nadu in both the groups, control and experimental group. And coming to the previous year academic performance, there is no difference in the control group and then experimental group. The distinction above was 59% and the first class was 41% students. They were equally distributed. And then comparison of the pre-test and post-test mean and standard deviation learning outcome on critical care drugs between the control and the experimental group of nursing students, which is in the experimental group only, it shows a very effectiveness. The t-value was of 10.29, which is significant. The correlation between the academic performance and learning outcome, which is mild positive correlation are present in the control group. There is very mild correlation was present in the experimental group. The R value for the control group is 0.49 and the experimental group 0.16. Coming to the finding of the study, the finding of the present study indicated that the students who were exposed to the educational games had adequate learning outcome scores on critical cataracts than the students who did not attend the game. This can be attributed to the effectiveness of educational games as teaching tool on learning outcome of critical cataracts among nursing students. And I want to conclude this study. The game-based learning methodology can be used to foster the active participation of students and to increase the competitiveness among them. And then game-based learning tools not only improve the learning process and facilitate the content acquisition and comprehension. Also, it promotes the teacher-student interaction also. And these are all the journals I have referred. And thank you for the opportunity. I thank SRM College, and then I thank Apollo College of Nursing, our principal, Dr. Nisa Satysachi, and our vice principal, Dr. Jaslin Ma'am, for the valuable lessons. Thank you, ma'am. Thank you for the opportunity. Yes, ma'am.
Ethical consideration of our study.
Yes, ma'am.
Ethical consideration for our study.
Ma'am, I have get from our IEC committee, ma'am. First, I had permission from the College of Nursing principal, and then from the IEC committee of the Apollo College of Nursing. Then only I informed concern from the individual each students, and then parents also I got permission, though they are in online teaching. That's why. Then afterwards, only I proceeded with study.
Madam Sasikala.
Yes, ma'am. Good evening, ma'am.
Very interesting study, the Kahoot game-based teaching model.
Yes, ma'am. Thank you, ma'am.
Very interesting, and usually at international level, this is part of the curriculum that they
Thank
have.
you, ma'am.
Yeah,
Students were very interested, ma'am. They were actively the students were very actively participated, ma'am. After the study, I have given the code to the control group of students also to actively participate. They also enjoyed, ma'am.
Okay, fine. I have a couple of worries here. Okay.
Yes,
first and foremost, I appreciate for the effort that you have taken.
Thank
And
you,
my clarification here is Kahoot. It is a web-based one, right?
Yes, ma'am.
So how did you manage the challenge of giving that Android type of Kahoot game-based learning for the students? Do you have that provision of giving all these internet facilities for the students to use Kahoot?
Ma'am, they were in the home, ma'am. And they are having
online
they
one.
were attending the online only. They were attending, ma'am. I have created a separate WhatsApp group for them. I have sent the code. The code, we have to take the code, and then particular time only we have to set within
all
the
the
time.
students were able to utilize that 100%.
Yes, ma'am. Yes, ma'am. Yes,
They
ma'am.
didn't have
I can have a list of marks also.
Fine.
That is the way I can able to calculate the learning outcome of the students now. The score I can give for them.
Okay. Then control group were not given, right?
First I didn't give, ma'am. After the study only I gave, ma'am. After the
So you oriented ethically, you justified that even.
Yes, ma'am. Other group also want to learn. That's why the control group also exposed to that game. They said it is very interesting, and then which is picturized, and then some are in true or false, some are in connection pictures, and they were able to connect, ma'am.
Fine. This is because online you tried it, you were successful.
Yes, ma'am.
How about offline classes?
Offline also, if
are you planning to continue this strategy in your offline classes?
Yes, ma'am. I'm going to develop, but we have to get permission, and then this app we have to purchase, ma'am. And during that first time lockdown, it was free. The Kahoot has given 3 months free. They gave me that time, and then afterwards now we have to purchase. If you want, we can utilize, ma'am. The basic alone we can do, ma'am. Within 10 or 20 questions we can add. Due to the each unit after completing, we can have the game-based learning like that, which will increase the
What was the time period that you used to do the pre-test and post-test? How many days gap?
5 days, ma'am.
4 days. 5 days, huh?
5 days. Yes, ma'am. 5 days.
Anyway, thank you. Congrats. Nice. Good presentation.
Thank you. Thank you, ma'am. Thank you so much, ma'am. Thank you for the opportunity.
Thank you, Sasikala. It's a very interesting research, but it is a very need of the hour, very apt to today's scenario. So thank you
Current
for
scenario,
your
which is
nice,
very much
yes.
needed. Yes. Thank you.
Yeah,
Thank you so much, Valan.
very
Thank you.
interesting.
Thank you, Valarmati. Thank you. Yeah.
Next, I request Madam Vanvakula Devi from Venkateswara College of Nursing to present your research paper presentation.
Good evening, ma'am. Am I audible, ma'am?
Yes. Yes, ma'am.
Yes, ma'am. Just a second, ma'am. I will share my screen. Good evening, ma'am. I take privilege to thank the Dean ma'am and other organizing committee members for giving me this opportunity to present my scientific paper here. Ma'am, my slides are visible, ma'am?
Yes, visible.
Yes, ma'am. Thank you, ma'am. So the my study title is a descriptive study to measure the body fat percentage among women residing in selected urban area, Chennai. So as we all know, obesity is a common risk factor for most of the non-communicable diseases, and it involves excessive amount of fat. So calculating the fat percentage will help us to avoid or help us to plan for a health education on prevention of obesity. So it is a chronic health problem, worldwide epidemic, and body fat percentage is the total mass of the fat divided by total body mass. So according to WHO, in 2006, 1.9 billion adults, especially the people 18 years and older people, were overweight. And of these, 650 million were obese. In India, the prevalence of obesity is 40.3%, and it is higher among women than men. And when we compare with the urban and rural, it is more in urban. It is according to National Family Health Survey 2016. And moreover, physical activity and age are the strongest determinants of obesity. So we have chosen the statement, descriptive study to measure the body fat percentage among women residing in selected urban area, Chennai. And my objectives are to assess the socio-demographic variables of women. And second objective is to measure the body fat percentage of women. And the third one is to associate the level of body fat percentage of women with their selected demographic variables. And the hypotheses are there is a significant difference in the body fat percentage among women, and there is a significant association between the level of body fat percentage of women with their selected demographic variables. The research methodology approach is quantitative approach, and descriptive survey research design was adapted for the study. And the study was conducted at selected urban area of Chennai. And my sample were women aged more than 30 years who fulfill the inclusion criteria. And size of the sample is 50 women, and sampling technique, non-probability convenient sampling technique. And the inclusion criteria were women without any chronic diseases, women who know English and Tamil, and who are willing to participate. And the exclusion criteria were pregnant and lactating mothers, and women who had undergone recent surgeries. And the tool consists of demographic data such as age, income, dietary pattern, and type of activity. And section B, measurement of height, weight, waist circumference, hip circumference, and neck circumference were measured. And the body fat percentage was calculated using US Navy method of body fat calculator. And it was categorized by using WHO classification of body fat percentage. So here ideal, it is between 21 to 24%, and moderate 25 to 31%, and more than 32 is considered severe. So the data collection procedure, after obtaining the permission from the concerned authorities, good rapport was established with the samples, and the purposes was explained to them. And we have collected the myself collected the demographic data and measured the height, weight, waist circumference, and hip circumference, and neck circumference for all the participants. So the data analysis shows demographic data according to age, most of the women between 31 to 40 years. And the income level, most of the women belong to the income group of 5,000 to 10,000 per month. And the dietary pattern, most of them are non-vegetarian, 76%. And most of the women coming under the group of moderate worker. So the second objective, which is to measure the body fat percentage among women, among the 50 samples, one was belong to the ideal group, and 10 women belong to the 10% of the women belong to the moderate group, and 88% belong to the severe group. So this is the diagram which shows the severity body fat percentage. So 88% of the women belong to severe group. And the third objective, associate the level of body fat percentage of women with their selected demographic variables. So the demographic variables such as age, income, dietary pattern, and type of activity were significant with the level of body fat percentage at P less than 0.05 level. So the study concludes that age, dietary pattern, and type of activity have effects on body fat percentage among women. So changing the lifestyle factors will help in maintaining the body fat and reducing the risk of obesity and overweight in women. These are my references. Thank you, ma'am.
Thank you, ma'am.
Yes, ma'am. Yes, ma'am.
Excluded rural area. Statement was selected urban areas.
Ma'am, the incidence shows higher obesity is common more in an urban area, ma'am. So that is why we have selected the urban area. Yes, ma'am. Yes, ma'am. And even our Indian National Family Health Survey report says the incidence of obesity is very common in more in urban, ma'am, compared to rural, because of the lifestyle factors and type of activity, etc.
Without any inclusion criteria. Is it possible to get the sample?
Sorry, ma'am, I didn't get it, ma'am.
No inclusion criteria.
Yes, ma'am.
Without any comorbidity diseases, isn't it?
Yes, ma'am. Yes, ma'am.
Is it possible to get the sample?
Yes, ma'am. Actually, in the urban area, when we go for the field posting, we have seen people with overweight or by physically appearance, and we have inquired about the comorbidity, and we have selected the sample, ma'am.
Okay, madam.
Thank you, ma'am. Thank you.
Ma'am,
Yes, ma'am.
Your study result shows that there is a significant association with age, right? Age.
Yes. Yes, ma'am.
Income, fat body distribution.
Yes, ma'am.
So can you tell me, like, which was the age group highly affected, and what is the income group that is highly affected?
Ma'am, actually, between 21 to 40 years were most commonly affected with obesity and body fat percentage, ma'am. And the middle income group, especially rupees 5,000 to 10,000 per monthly income group, are more prevalent, ma'am.
The middle income group are highly
middle income group. Yes, ma'am. Yes, ma'am.
But not the high income also, right?
Yes, ma'am.
Okay, fine. Okay, ma'am. Thank you. It's a good, interesting study. Okay,
Yes,
you were
ma'am.
able
Thank
to highlight the impact of your study, and
yes, ma'am.
That's nice.
Yes, ma'am. Thank you. Thank you, ma'am. Thank you.
Madam, Dr. Tamishambi, ma'am.
Yes, ma'am.
Ma'am, it is first and foremost, I would like to extend my earnest gratitude towards your participation and effort in contributing your expertise to this platform, ma'am. I would like to request if you would like to share anything with regards to the presentation in this platform.
From this statement, ma'am.
Pardon, ma'am.
Ma'am, is it audible to you?
Yes, ma'am, you can go ahead. It is audible.
First, foremost, I thank Dean Dr. Tanya Mal madam giving me this opportunity. Then I thank Dr. Kavita ma'am and Valarmati madam and Gopinath sir. So from this research presentation, paper presentation, we enhance our research activities in nursing. We especially telehealth nursing service, poster presentation, telehealth nursing services is very useful for us, and external study. Attitude, the awareness regarding organ donation among staff, attitude towards organ donation is also very useful for us. Ma'am, thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. Thank you for your word of appreciation, ma'am.
Thank you, ma'am, for your presence. And a small announcement, because of time consuming, we have little more participants are waiting, that we will be postponed tomorrow. We will send to the shortlists for presenting tomorrow's scientific session. Sorry for the inconvenience because we have some time consuming. Okay, the participants, please, you will be present tomorrow's session.
Yes, like Madam told, due to time constraints, we will continue the scientific session tomorrow. The remaining presenters can present tomorrow. We have arrived to the end of the session, today's session. I hope all these sessions were great. It will help us to groom ourselves. We will again catch up tomorrow. Thank you all for your active participation.